Шановні колеги, добрий день.
Dear colleagues, good
Ми вас
morning.
вітаємо на
We are
нашій
happy to welcome you
конференції,
in our
яка
conference,
називається "Інноваційні
the name of
підходи
which is the
діагностики і
innovative
лікування туберкульозу та інших
implementation
захворювань
of
легень",
modern approaches of
практичні
tuberculosis, case
рекомендації для
management, and high
лікарів
quality
загальної
education of
практики,
doctors
фтизіатрів та
are
пульмонологів.
integral comments on
Конференція
effectiveness
наша
control in tuberculosis.
міжнародна,
So our conference is
присвячена вона
international and it's
сьогоднішньому
dedicated
дню, Всесвітньому
mm,
дню
to
здоров'я,
the
який
International Health
святкується в
Day
усьому
that's
світі
been
7
celebrated throughout the
квітня.
world on the 7th of
Наша
April.
конференція,
Our
вона проходить
conference,
онлайн,
it's happening in an
проходить
online
на
format and it's also happening
нашій
in
платформі National
our
TB Hub.
platform,
І
National TB
також
Hub, and
трансляція
also
нашої
the
конференції
broadcast of our
відбувається на
conference is happening
YouTube-каналі National
on
TB
our
Hub.
YouTube channel
Тому
of National
просимо
TB Hub.
всіх
Therefore, we are
приєднуйтесь
asking
до
you to
стріму,
join the
ставте лайки,
stream and also to
підписуйтесь на
put
наш
the
YouTube
thumbs
канал.
ups
На
and
ньому дуже
subscribe to our
багато
YouTube channel.
інформації
There's so much
міститься не тільки
information
про даний
present,
захід, а й
not
про
just
попередній заход, і
about
про
this
майбутні
event and
заходи.
about
Тому,
the
будь
future
ласка,
events as
долучайтеся
well.
до
So please join us
нашої конференції.
to our
Наша
conference.
конференція
Our
має
conference
такий
has
цікавий
such
сумісний
an
формат.
interesting
Спочатку
hybrid
у нас буде
format because
дві
before we will have
сесії
two
основної
sessions
конференції.
of the
Конференція
main
одноденна,
conference,
і
one
вона
day
дає
conference, and so
5
it gives
балів
you 5
безперервного
points
професійного
of
розвитку.
the
Але у
continuous
вас
professional
буде
education points.
унікальна
But you will
можливість
have an
додатково
opportunity
до
to earn
основних
additional
сесій
points,
конференції прослухати 3
to listen to another
майстер-класи, які
3
будуть
master
іти паралельно
classes
після
that are
завершення
going to
конференції.
be
Кожен із
going
цих
after the conference will
майстер-класів
be
дасть
over. Every
іще
of those master
10 балів
classes will
безперервного
give you another
професійного
10
розвитку.
points of continuous professional
Нагадуємо, що
education.
за
So let
умовами
me
Центру
remind you that
тестування
based
МОЗ
on
для
the
отримання
national
сертифікату
testing
треба
to receive the
обов'язково після
certificates, you need
завершення
to,
і
after the
конференції, і кожного
conference
з
will be over
майстер-класів пройти
and every master class will
тестування.
be over, to go through testing.
Тести можна буде проходити на самій платформі.
You
Ви
can pass the test on
бачите
the platform
в
itself.
стрімі
You can see in the
внизу
stream
справа
on the
червону
bottom,
кнопку
there's like a red
тестування. На неї треба
button
буде
that says
натиснути в
testing. You
кінці
would have to
заходу
press it
і
at the
пройти
end of the event
тести.
and then
Умовами
fill in the
отримання
test. The
сертифікатів є
conditions to receive
70%
certificates, it's
правильних
70% of
відповідей
correct
на
answers
запитання
to
цих
the
тестів.
questions placed
Я
there.
впевнена, що ви справитесь всі
And I'm
успішно
sure
з
that
даним
everybody would be
завданням.
successful with the task
Конференція
at hand.
планується дуже цікавою.
The conference will
Спікерів
be
у нас
interesting.
багато
Speakers,
і
we have
міжнародних, і
plenty
вітчизняних. Кожен
of both
спікер
national,
експерт в
international,
своїй сфері.
and every speaker is an
Наша
expert in their own
конференція
respective
вона
field.
орієнтована в
And
першу
our
чергу на
conference is first and
клініцистів,
foremost at the
тому і
targeting
спікери
clinicians.
також
Therefore,
мають
speakers
і
as well
великий клінічний досвід,
have a
кожен в
big level
своїй
of clinical
сфері,
experience,
і
everybody in
також
their own
досвід
respective field, and
виступів на
also
різних
experience of
заходах, як
presentation in different events, as
міжнародного,
conferences,
так і
congresses, or
вітчизняного рівня.
international or
Ще раз
national
всіх
level for
вітаю,
them.
поздоровляю з
Yet again,
днем
welcoming
Всесвітнім днем
everybody.
здоров'я.
Congratulations
Бажаю
with the
всім
International
успіхів,
Health Day. I wish you nothing but the
майбутнього
best
мирного неба
and
і
peaceful
успіхів
skies,
вашій
and also
професійній
success in
діяльності,
your
вашому
professional activity
професійному
and
зростанні.
in your
І
professional growth.
перейдемо
And we
до
can go
урочистої
to
частини
the honorary
відкриття
part of the
нашого
meeting, the
першого
welcoming
заходу,
words, our first
конференції,
event
яка
of the conference that
присвячена
is dedicated to
Всесвітньому дню
the
здоров'я, але
World Health
розглядати ми
Day.
будемо
But we'll be
питання
looking at the
фтизіатрії
issue
і
of
сумісно
anxiety or TB
пульмонології.
and
І
pulmonology a
слово
bit.
для
And so the
привітання
floor for the
передається
welcoming we are
директору
giving to the
Національного
director of
наукового
the National
центру
Scientific
фтизіатрії,
Center,
пульмонології і
mm,
алергології
the
імені
FTB,
Яновського
physiatry,
Національної
and
академії
pulmonology
медичних
and
наук,
oncology of
Юрію
Yanovsky, to
Фещенко,
Yuri
академіку, доктору
Feshchenko,
медичних наук.
academician,
Юрій,
doctor,
будь
medical
ласка.
scientist. So Yuri, please go ahead.
Вітаю, шановні колеги,
Greetings, dear
шановні
colleagues,
гості,
dearest
шановні пані і
friends,
панове.
dearest ladies and gentlemen.
Слава Україні!
Glory to Ukraine.
Що ж сказати? Туберкульоз
The
дуже
TB
цікаве,
and
на
tuberculosis
мій
is really
погляд,
interesting, in my
захворювання,
opinion.
чому
One of the
присвячена
most interesting
сьогоднішня наша
diseases.
конференція.
And our conference is
Це
dedicated to it.
захворювання
This disease
відоме
is
ще з стародавніх
been known
часів.
from the
Є
ancient times,
інформація
and so
в
there is
письмових, в тому
information,
числі
also
із
written
Древнього
records
Єгипту,
from the ancient
Месопотамії,
Egypt,
інших центрів
Mesopotamia, and
розвитку
other
людства на нашій
centers for
планеті
human
Земля.
development on our
І,
planet
на
Earth.
превеликий жаль,
And
сьогодні
unfortunately,
ми
so
маємо
today we also have
також
the
проблему,
issue of
багато питань
and
щодо
many questions and
туберкульозу,
issues
щодо
on
цієї
TB, on
інфекції. Як відомо,
what kind of
туберкульоз це
issues this infection
хронічне
brings to us.
запальне інфекційне
Tuberculosis is a
захворювання,
chronic
генетично
inflammatory disease,
детерміноване.
genetically
І ми
determined.
це знаємо
And
і
we know
враховуємо в
this,
нашій
and we are
повсякденній
taking this
роботі.
into account in our
Якщо подивитися
daily line of work. If you
такий,
would take a look
ну,
at
якби історично,
like
життєво-історичний зріз, то
historically
про туберкульоз ми
on
багато
TB,
знаємо, багато
we know
нам
a
чого
lot,
відомо.
and a lot
І
of things
вже
are known
є
to us
таке
already.
поняття, як
And so
первинна
there is a thing is
профілактика
the
туберкульозу,
primary
куди відноситься
prophylaxis of TB or
вакцинація
prevention, where the vaccination is
вакциною
dedicated
БЦЖ.
to
І ви
using the
знаєте, що є
BCG
чіткі
vaccine. It's, you
критерії.
know, there is a specific line of
Всесвітня
criteria
організація охорони здоров'я,
from
яка
WHO
говорить про те, якщо рівень
that are
інфікування
telling us like
дитячого
if the
населення від
level
0
of the
до
pediatric
2%,
population
то
is
вакцинація
under 1 to 2%, and the
не проводиться
vaccination
в перші
is
дні
not being conducted
життя
in the first days of
новонародженої
the
дитини.
life of the
Якщо цей
newborn child.
показник
And if this
становить від 2
indicator
до
is from
5%,
2 to
тоді
5%,
або по
then
медичним
it's
показам,
either
або по
based in
бажанню
medical
батьків,
indication
до
or on the
прикладу,
wish
вони
of the
мають
parents.
десь
For example, they have
переміщатися,
like
їхати
they're
з
going
цією
to be moving
дитиною в
somewhere,
території, які
moving with a child
викликають у
in the
них сумнів,
territories that causes
вакцинація
concern,
може
then the
проводитися.
vaccination
І
can be
якщо
conducted in
рівень
that case.
інфікування
And if the level of
дитячого
infection
населення більше
for the local
5%,
population,
значить
pediatric population, more
вакцинація
than 5%,
проводиться
then the
обов'язково,
vaccination is
що
being
і
conducted as a mandatory thing, which is
застосовується в нашій
being
державі в
used
Україні.
in our country and
Обов'язкова
Ukraine as well. A
вакцинація БЦЖ
mandatory
в
vaccination using
пологових
BCG
будинках.
in the maternity
Де
houses,
і
maternity homes.
подальший це
And in the
ступінь
future,
розвитку наших
level of
знань,
development of our knowledge,
практичних навичок,
skills,
це існування
and
туберкуліну.
also presence of
Туберкуліну, ви
tuberculosis.
знаєте, що
As
є
you know,
певні
there are
покази,
some
протипокази для
indications,
проведення
contraindication for the
в
conduct of
спеціальних групах, в
in a
дитячих
specialized
групах
group of pediatric
населення
groups of population
туберкульної діагностики, яка може
using the
виявити
tuberculin for the
рівень
diagnostic. They can detect the
інфікування
level of
мікобактеріями туберкульозу. Із
spread of
сучасних досягнень
TB among the
я маю
population.
на
Among the
увазі в першу
modern
чергу це
achievements, first of all,
існування
I mean
рекомбінантних
that
форм
recombinant forms of
туберкуліну, які
tuberculin exist
абсолютно очищені від
that are
дейтриту,
fully
вони не
clean
містять
from the
дейтритів,
detritus and they don't have
які
detritus in
були в
any sort of
класичних
form that have
туберкулінах
been in
до
classical
цього, а
tuberculin
містять
before
лише
that.
дві молекули
And they only
ДНК,
have like
які
two molecules of
забезпечують
DNA that provides
специфічну
for
відповідь
a specific
організма на введення цього
bodily
препарату.
response in
Ну
case
і
this medication
подальше
will
це
be
вже
injected. And the future
існування
on, those are the
сучасних
existing
методів
of the modern
діагностики
methods for
туберкульозу,
diagnostics of TB,
сучасних
of the modern
засобів лікування
means for
туберкульозу.
treatment of TB.
Наприклад, якщо згадати
For example, if you would
історію, ну,
remember
в
the
тому числі
story
можна сказати і
and
світову,
also
одна
the
із
world
самих
story. So
великих
one of the
держав,
the biggest
тоталітарних держав
countries, totalitarian
на
countries
нашій планеті в свій
in
час,
our
також де була
planet at the
епідемія
time when there has
туберкульозу,
been also a TB
і,
epidemic
наприклад, широке впровадження
and a wider
стрептоміцину
implementation of
в практику
streptomycin
фтизіатричної
in the
служби
TB
творили, як
practice
кажуть, чудеса. Хворі,
created like
які мали
wonders.
б
So patient that had,
померти від цієї
or
хвороби
before
при
that, they would have
застосуванні
died when
курсу стрептоміцину,
a
вони
course of
майже
streptomycin had been given to them, they've
видужували,
almost
воскресали
gotten
на очах. І
fully
це дало
well
підстави
on
одному
their own eyes,
із
and so which
керівників
giving
нашої
us and from the leadership
цієї
of
держави
the
заявити на
country to
партійному з'їзді,
announce
що
for the
туберкульоз в
meeting
цій
that
державі
tuberculosis in this
через
country
рік буде
in a
ліквідовано.
year
Але
will
вже
be
скільки
liquidated. But
пройшло
like how many
після
years
цієї
have
заяви,
passed after
а ми
that,
бачимо, що
and we can
на
still see
території і
that on the
європейської
territory
частини
of both European part
континенту і
of the
в
continent and
азіатській
also in
частині
Asia,
проблема туберкульозу
the issue
існує.
of TB is still in existence and is still there.
Чому ж так відбувається? Чому
So
ж
why
так
does it happen
відбувається?
that way? So why does it
По-перше,
happen?
заява,
First of
що
all, the
туберкульоз
statement that
має бути
TB
ліквідований
has to
або
be eliminated
вже буде ліквідований,
or
я
will
думаю,
be
що вона
eliminated, I
безпідставна,
think it
тому
doesn't
що
have
на
any
зміну
grounds to be because
теоретично на зміну
to the
цій
theoretical change
мікобактерії
to that
прийшла б інша
mycobacteria, there would
бактерія,
come another
яка б
bacteria
можливо спричинила б
that
інше
maybe
більш
cause
важке
a different, more
захворювання.
complex condition or
І
disease.
вже останні десятиріччя
And for the last
всі
decade,
фахівці
all
з
the
медицини,
experts
з
from the
туберкульозу
healthcare,
говорять про те,
TB
що
area work,
потрібно
they're
держати
telling that
під
you need
контролем
to take
з
under control
туберкульозну інфекцію, і тоді буде
TB,
все
and so then
більш-менш спокійно і
you would
нормально.
be
І
having
сьогодні ми
everything more
проводимо
equal and
роботу,
all
яка
good. And
направлена,
now we are doing a
направлена
line of work
на оволодіння
that
контролю
we're
над
doing, how
цією
to
важкою
know what to
інфекцією.
do, how
Чому
to
я говорю
control this
важкою? Тому що
complex infection. Why
хронічний
am I mentioning that it's complex?
запальний
Because it's
процес
chronic
в
inflammatory disease
медичному
or condition.
сенсі має
In a
значення
medical sense,
невиліковності,
it has
невиліковний.
it means
Тобто
that it
людина,
cannot be
яка
cured fully. So that the
захворіла
person that
в
had a
тому числі на
disease
туберкульоз
and also
і
for
успішно
TB
пройшла
and was
лікування,
successfully treated,
клініко-рентгенологічно в неї
and on
немає
X-ray
ознак
they don't
активності
have any
туберкульозного
indication that
процесу,
TB is
все
active,
більш-менш нормально,
everything is
але
good and
вона є
fine, but still
потенційно хворою
they are a
все
potential
своє
patient
життя. Ми
for
знаємо такі
throughout their whole
поняття, як
life. We know this
рецидиви,
means that
повторне захворювання
recurrence
цієї
or
хвороби
repeated condition, repeated
і
appearance of
інші
this
поняття,
condition,
які свідчать
and
про те,
other
що
terms that
туберкульозна інфекція
showing us that
дуже-дуже
unfortunately
складна
TB
в
is
своєму
a
перебігу,
complex thing
в
and its
своєму розповсюдженні.
disease
Наприклад,
pathway or
мікобактерія
disease course,
туберкульозу,
the
вона,
Mycobacterium
я б сказав,
tuberculosis,
стоїть так
I
обособлено
would say that it's
перед
sort of like in its
і
own way, has its
мікобактерій
own place
інших,
among
так
every
і взагалі в
Mycobacterium
багатьох
and
мікроорганізмах.
many
Наприклад,
other
вона
microorganisms. For
зберігає
example,
життєздатність в
it's
температурному
viable
режимі
in the
від плюс
temperature of
80
plus
до
80
мінус
to
270
minus
градусів по Цельсію.
270 degrees
Я
Fahrenheit.
повторюю, зберігає
Yet again, it's still
життєздатність свою.
viable in
Наприклад,
plus
всім
80 Celsius
відомо
centigrade. And you all know that
класичні роботи
the
колег
classical
із
work
Великої Британії,
of
які в
our
свій
colleagues from
час
the UK that at the time
займалися е, розкопками в
they digged
районі Гізи в Єгипті,
near
і там
Giza pyramids
була
and
чергово досліджена
they have been
мумія,
doing the
не
research. They had another
якогось
mummy, not
високопосадовця,
of the
який там був
pharaoh, but like
похований.
a
І ви
high level
знаєте, що є
noble.
певний протокол
And you know that
обстеження
there is like a protocol how you test them.
мумій, в тому
You have to
числі в
actually test
Єгипті,
them as
і в
well in
тому
Egypt
числі
as well.
зробили рентген
And
і
so they did an
подивилися,
X-ray, and so they
що там є
looked
ознаки
that they have
наявності в
signs
кістковій
of
тканині
presence in the bone tissue
кальцинатів. А як
calcinates.
відомо, в
As you know,
99%
in 99% of
випадків кальцинати
cases,
залишають після
calcinates
себе тільки
are
мікобактерія
only left
туберкульозу.
by
Якщо їй щось не
Mycobacterium
подобається
tuberculosis if she doesn't like
в
something in the
організмі
lungs
хазяїна, вона
or in the
накладає
body,
навкруги
then
себе
it
солі кальція,
around
замуровує
themselves they are
себе і сидить
putting
до якогось
calcium and sitting
певного
there
часу.
before the
І
time is
після
right,
того, як
essentially.
було
And so after
діагностовано цей туберкульоз
the
кісток у
TB of
тої людини,
bones have been
каже, за там
diagnosed in that person
4
that
тисячі
lived for
років до
4,000 years
нашої
ago,
ери, і було офіційно з дозволу
and
уряду
officially,
Єгипту вивезено
from the government of Egypt's
якийсь фрагмент
approval,
цих
like a
кісток
fragment of those
в
bones
Англію,
have been put
в
out to
Лондон.
the
Там
UK.
провели дослідження,
And they made a
підтвердили
test and they
діагноз
confirmed the
наявність
diagnosis,
мікобактерій
or essentially the
туберкульозу
presence
і
of the
просто
Mycobacterium
посіяли
tuberculosis, and
на
they just
стандартне
put
живильне
this in the
середовище. Це
regular
були
culture media,
60-ті
so
роки.
which was in
І
1960s.
на превеликий подив
And to your
всіх, через
surprise of
40,
everybody, in
два чи
48
43 дні
days or
мікобактерії
42 days, the
туберкульозу дали
Mycobacterium
ріст.
tuberculosis given
Тобто
growth,
пройшло
meaning
більше 6 тисяч
more than
років,
6,000
як
years
жила
have
ця
passed
людина, як
when
ця
this person
мікобактерія
lived and this
туберкульозу себе
Mycobacterium
замурувала
tuberculosis
в
put itself
кістках
and calcinate in the bone
хазяїна
tissue,
хворої людини. І потім вона зберегла
and then it stayed
життєздатність,
viable.
і коли були певні умови,
And
вона
when conditions
проросла.
were met, it given grows. It
Також ми
started to
знаємо
multiply.
про
And we also
випадки,
know about the
трагічні
cases of
випадки
tragical
захворювання
cases
на рецидив туберкульозу
of the
при
recurrent
травмах,
tuberculosis in case of
коли
trauma.
травма має місце в
So when
області
there's
грудної
trauma
клітини, наприклад,
near the sternum, for
типовий
example,
типовий випадок це травма
so like a typical case, which
автомобіліста,
is
особливо той,
the
що знаходиться
car
за
crash, especially
кермом.
the ones who are in the steering
При
wheel.
травмі
In
ламаються
case this
ребра
trauma,
при
the ribs are being
стиканні з
broken,
кермом, і часто
and
плевра
also
і
frequently
генева тканина
pleura
також
or lung
травмуються
tissue is also being
цими
traumatized
кістками, які
by
поломані
those
ребрами.
bones that, or
І коли попадає в
and when
зону
it gets
цього
into the
ураження,
area of that
навіть кальцинат, людина колись
injury,
захворіла або було
even a
випадок
calcinate when the person
самолікування,
got sick,
про
or
10%
there
яких
have
ми
been
знаємо,
cases of self
тоді
treatment,
і поступає
10% of which
біохімічний
we know
аналіз
of,
в
then the
організмі
biochemical
мікобактерія
testing is going
туберкульозу
in
розчиняє навкруги
and
себе солі кальцію,
it
виходить в
dissolves
циркуляцію
the
і виникає
calcium around
повторне
them
захворювання,
and
рецидив захворювання.
another
іншим
level of
випадком.
recurrence
Я
of
до
this
чого
condition
це
happens
звертаю
to
вашу увагу,
come.
що
So
мікобактерія
why am I
туберкульозу
saying
дуже
this?
дуже
Because the
стійка
mycobacterium
до факторів
tuberculosis is really,
зовнішнього
really sustainable
середовища.
or stable to
Єдиним
the
згубним
external
фактором,
environment.
який впливає
And
на
the only
бактерію
factor that
туберкульозу
sort
і
of
оточуючого
acts to the
середовища є
mycobacterium tuberculosis of the
ультрафіолетовий
environment,
спектр
which
сонячного
is the
опромінення. Але для цього
ultraviolet
мікобактерія повинна
spectrum
лежати,
of the
як
environment. But
кажуть,
for
на
that, the
поверхні і
mycobacterium have to stay on
безпосередньо
the surface and
контактувати
to
з
be in
цим
direct contact with the
промінцем
UV rays.
ультрафіолету. А якщо вона закрита
And if it's being
шаром
closed or
пилу
enclosed by
чи
the level of
ще десь в
dust
тіні,
or
там десь
somewhere
в
in the
мокрому місці,
shadow,
то це на неї згубно не
then
впливає. Чому я
it
звертаю на
doesn't
цю
influence it in
вашу
any
увагу?
way,
Тому що
shape, or form.
говорили
And why am I
раніше,
paying your
що
attention to that? Because
і зараз,
before it was
що
mentioned
туберкульоз є,
that okay,
має
TB is
соціальне коріння.
only has a social
Чому? Тому
like
що
background
крім
in it. And
фактору
how come?
там,
Because apart
ну,
from the
недостатнього
factors
чи
of
нераціонального харчування,
insufficient or
людина, коли живе
malnutrition
в
when a
побутових
person is
умовах,
living in
в
the
приміщенні, яке
environment or in the
затемнене,
room that's being
туди не проникає
darkened, there's
сонячне
no
проміння,
light going in
волого,
there, it's
е,
wet, and
пил, який не
a lot of
прибирається.
dust
Тобто
that's not
створюються
being
умови,
removed. So
якщо
like
є
there are
мікобактерія
conditions, if there
туберкульозу,
is a
вона там
mycobacterium
і поживе,
tuberculosis,
і
it's gonna be
процвітає,
thriving there,
і люди
and
заражаються, і
people will
хворіють,
gonna be
і в
sick,
тому
and
числі із-за таких факторів на
because of such
туберкульоз.
factors for
Відомі
TB as well.
випадки
So
і
we know about the
непоодинокі сімейних
cases
захворювань на туберкульоз,
of
коли
the
в
whole when the
одному
whole family
приміщенні
has
в
to
одній
be in one
квартирі, на
room
одній
and one
території проживає
apartment in one
3-4
territory. You have
покоління
3 to 4
рідних
generations of
людей. Хтось
people with
захворів,
TB.
і в першу
Somebody
чергу
got the
хворіють,
TB and just then
від дорослих захворіє дитина.
and the children are the ones who are being the most affected from
Останнім часом в
adults.
нас
So in the
величезна
last time we
проблема, я б
have an
сказав так,
enormous problem, I would
стійкість
say
мікобактерій
this is
туберкульозу до
the
відомих
resistance of the
протитуберкульозних
mycobacterium
препаратів.
tuberculosis
Ви
for
про це
known
знаєте добре, і
antibacterial medication or
знаєте ті
antimicrobial medication.
розробки
And you
вітчизняних
know what are
фтизіатрів,
the
їх
state
внесок
TB
в світову
doctors are
фтизіатрію
developing
по
their
впровадженню
impact into the
нових
world TB
протитуберкульозних
medication and
препаратів,
implementation of
створення
new
нових
medication,
режимів,
creation
що
of new
визвано
regimen
в тому
systems for
числі і
treatment that are also
світовою
recognized by the world
спільнотою. Це і
community,
Центр
both for
Південно-Африканської
the South
реанімації,
African
так,
Center
і
and
Всесвітня організація охорони здоров'я
WHO as
і
well.
інші. Так що перспективи в
So in the
лікуванні
future, in the
туберкульозу
treatment
при
of TB,
дотриманні певних режимів,
if you
при
follow
дотриманні
like regimens and
певних
if you
методів
follow
лікування, я б сказав,
treatment
методологічних
methods,
підходів,
methodological
вони
approaches,
сприяють тому, що ефективність підвищується. От,
they are
наприклад,
aiding in the fact that the effectiveness is
в
growing. For
клініці, яку
example,
очолює
in the
професор
clinic
Литвиненко Наталія
that
Анатоліївна,
is the head of the
ефективність
Lieutenant Natalia
лікування
is leading the
хіморезистентних форм
effectiveness of
туберкульозу
treatment of chemo-resistance form
майже
or polyresistance form of
90%,
TB. It was
іноді
almost
і
90%,
більше цей показник.
sometimes even higher than 90%.
В тому числі така висока ефективність лікування
In the same way, this high efficiency of treatment
стійких форм
of the
туберкульозу
sustainable
легких,
or resistant forms of TB,
стійких форм туберкульозу,
resistance
мікобактерій,
form of TB and
стійкість
mycobacterium
до відомих протитуберкульозних препаратів,
to
в
the
тому
known
числі, як
anti-TB
ще
medication,
підкреслюю,
also in
вона
highlighting its
обумовлена й тим, що такі застосовуються як
one of the reasons
комбінований
why,
підхід
because
в
there's like a
лікуванні. Я
combined
маю на
approach for
увазі
treatment, meaning
терапевтичне і
it's
хірургічне
also
лікування.
surgical
Адже з історії
and
відомо, що
regular
коли
treatment and
після Другої світової
internal
війни
medical treatment.
був
After the Second World
високий,
War,
дуже високий
they
рівень
have been really high
захворюваності на
level of
туберкульоз
the incidence
в
for TB
німецькій державі, вони
in
і
Germany.
антибіотикотерапія
They
була ще
use
тільки в зародку
antibiotics.
і
It's only been at the
недостатня,
beginning of the way it
недоступна,
was insufficient,
малодоступна в
significant,
ці
or
перші
not
післявоєнні
available in
часи,
those first
то
initial
широко застосовувався
anti-war parts.
хірургічний
Then the
метод
surgical
лікування
treatment has been used
туберкульозу.
widely
І
of TB.
зараз наш центр
And so now
повернувся
our
вже
centers gotten back
більше 10 років,
to more
застосовує
than 10
так звану
years, and so they are
комбінований
using
підхід до
combined approach
лікування
to the treatment of
хіміорезистентних форм туберкульозу.
chemo-resistant
Це
or
також
resistant
в
forms
тому
of
числі
TB.
забезпечує
And
високу
also, it
ефективність
provides for us a high level of
застосування
effectiveness of the usage
інноваційних
of
препаратів
those
і
innovative ways of
розроблених
treatment and
нових
the development
методик
of the
лікування.
new methods for
Тобто Не
to treat those
так,
patients.
як
So it's
раніше
not
колись була
as in
передача,
long
називалася "Не
ago.
так все погано в нашому домі".
If we had a
Дійсно,
TV program,
перспективи
it
є,
says it's not that
гарні
bad in our house,
перспективи у наших
and so
хворих.
the future
О,
holds good things
велика
for us and
відповідальність в
good
цьому
things for us,
питанні
and the big responsibility
лежить і на
in
нас,
there it's
лікарях.
also on us, on
Це
doctors,
доведення до
which is to
інформаційного
prove and to bring this
потоку до
information
кожного
to
хворого про сучасні
every
можливості
citizens that on
лікування
the modern
туберкульозу, про
abilities and
дотримання
what you can do to
режимів
treat TB,
туберкульозу,
how to
про те,
follow the
як
treatment
себе
protocols,
вести
and how to
протягом, я б
act
сказав, всього життя
throughout the
цій
life of
людині, і в
the
тому числі
person,
це
and also
застосування нових
the
інноваційних
usage of
препаратів.
novel
Чому і
medication.
в тому числі присвячена сьогоднішня наша
And also,
конференція,
this conference
яка
is dedicated
висвітлює
to
актуальні
that
питання і
highlights
діагностики.
the
Я б
issues of
сказав,
both diagnostics and
звертаємо увагу на своєчасну
we would just
по
like to point
можливості
your attention to the
діагностику
timely
туберкульозу.
ability of
І
TB
головне це ведення
and
хворого,
also
починаючи від
to having the
стаціонарного
patient, starting with the
лікування, в
inpatient
залежності
treatment
від показів чи амбулаторного
and
лікування, але під
ambulatory treatment,
е,
but
контролем медицини,
under the
медичної
control, under
спільноти.
the
І лікар,
healthcare
і
committee,
середній медичний
both a
персонал,
doctor
і інші
and
заходи.
other
Так
parts of
що
medical personnel.
я
So,
дуже
therefore, I
вдячний вам
am
за
so
увагу.
grateful for
До
your
нашого
attention
сьогоднішнього
to our
заходу
today's event.
хочу побажати всім
And I
нам
want to wish you,
успіхів
all
в
of you,
проведенні
to
цієї
only
конференції,
nothing but
подякувати
success in
вам
this
за вашу
conference, to
активну участь.
say
Я
thank
думаю,
you
що
for
вона
your
е,
active participation. And I
буде
think that it's going to
активною.
be
І побажати
active,
всім
fruitful, and all
міцного,
that. And so
міцного
to wish to
здоров'я,
all of you
щастя,
a strong
успіхів,
health, happiness, and
процвітання, благополуччя і міцного,
that your
міцного
work and
здоров'я.
everything else will go
Дякую.
well and you will stay in strong health.
Дякуємо, Юрій
Well, thank
Іванович.
you so much, Yuri
Слово для
Ivanovich.
привітання
The floor is
передається
given to
нашому
our
національному менеджеру національної
national manager
туберкульозної
of
програми,
the national TB program,
керівниці
to
відділу
the head of the
контролю
Department
за
of TB
туберкульозом
Control,
Центру громадського
Center
здоров'я
for Public
Яні
Health,
Кірлєєвій.
Diana
Пані
Terleva.
Яна в даний
Dear
час є
Yana, at this
координатором
time is the
національної
coordinator
програми по
of the
боротьбі з
national TB program,
туберкульозом в Україні. Також є
and
експертом з
also
питань
she's an expert
туберкульозу
on
Міністерства
TB
охорони здоров'я України, міжнародний консультант
in the Ministry of
Комітету
Health, is
Зеленого
national consultant of
світла
the
Європейського
Green
бюро ВООЗ.
Lights and the European
Є
WHO
не
office. And so
тільки
she's also not only
талановитим
a
менеджером, але й
talented manager,
кваліфікованим
but also a
фтизіатром.
qualified TB
Тому, пані
doctor.
Яна, будь ласка, вам слово.
Therefore, Yana, the floor is
Дякую,
yours.
Наталю.
Thank you
Рада
so much,
вітати
Natalia.
шановні
I'm so happy
учасники
to
цього
welcome dear participants
унікального
of this
зібрання міжнародної
unique
конференції,
meeting of international
що ви
conference,
сьогодні
and
тут разом зібралися
that we are all
досить
gathered
символічно в
here
день
together
всесвітнього
symbolically at the
здоров'я
World
і
Day TB
якраз
Day,
після завершення фактичного
and
цілого
just right after the
місяця
whole
подолання
months
туберкульозу.
of
Власне
anti-TB
кажучи,
activities have
ми
been
можемо
happening.
сказати,
So
що
what we can
хоч і
say
місяць
is
подолання
that even though
туберкульозу
the
завершився,
TB
але
months have
на жаль, не
finished,
дивлячись на те, що
even
туберкульоз,
though
як ми вже також трішечки
TB, as we
повернулися
mentioned
в
here,
історію.
as we got
Дякуємо
back
Юрію
to the
Івановичу
history,
за
and thank you
це.
so much, Yuri,
Відомий
for that.
більше ніж тисячі
TB is
років, але
known
тим
for
не
more
менш
than
це така
thousands
хвороба,
of
яка
years, but
продовжує
yet this is a disease
супроводжуватися
that continues to go
безліччю
hand in
міфів,
hand with
недоказової,
myths,
недостовірної інформації. І
non-proven
сьогодні дійсно
information.
світ змінюється, дуже багато, ціла
The world is
низка
changing,
інновацій, нового передового
and there's a
досвіду.
lot of things
І
that's been
я рада,
changed in
що
the
є такий
international
унікальний
experience.
майданчик і
There's
площадка, як
a
міжнародна
unique
наукова
platforms,
практична
this
конференція.
international
І зі
conference,
свого
and on and
боку
on.
дуже дякую за
And
лідерство
from our side, I would just like
Інституту
to express my
фтизіатрії
gratitude
пульмонології, а
to
зараз
the Institute
наукового
for TB's
національного
and
наукового
National
центру
Scientific
за
Center
те лідерство,
for
яке
the
у вас є
leadership,
для того, щоб ми продовжували
and
фактично
so
кожного
that
року
we
проводити
would
таку конференцію.
annually
І
do this
фактично це є
conference,
такою нашою
and
традицією. Я дуже сподіваюся, дуже
as
очікую
our
ще
tradition.
багато років
And I'm
наперед.
hopefully
Ми
that
будемо
for
її
many years to
продовжувати
come that
і
we will be
підтримувати, тому
continuing
що
this,
дійсно сьогодні для
supporting
медиків
this, because
надзвичайно
now for the
важливо
doctors,
мати
it's
такі
so important
площадки,
to
де
have
можна почути найостаннішу передову інформацію,
that you can
поділитися
hear the
досвідом. І це важливо
newest,
не тільки
the
для нашої
most
країни, а
groundbreaking
власне кажучи,
information
і за кордоном. Адже
and
зараз
also abroad
через
as
війну ми
well.
бачимо,
Because
що
now,
наші
due to
люди
war, our
виїжджають в інші
people are
країни
moving out
і
to other
насамперед до
countries
європейського
and
регіону,
to
але
the
фактично
European
по всьому
region,
світу.
but de
І
facto
бачимо, що
throughout the
є
world.
великий
And we
попит на
see
те,
that
щоб
there is a big
продовжувати
request to
нарощувати кадровий
continue to
потенціал,
grow this
продовжувати
workforce potential
обмінюватися тим досвідом, який є. І зі
and to
свого боку,
exchange
певно,
this
хочу
experience. And from
зазначити,
our
що
side, I
в
just also
Україні
like to
абсолютно
mention that in
погоджуюсь з
Ukraine,
Юрієм Івановичем, що є велике
and I'm
надбання.
in
Нам
full
дійсно
agreement
є
that there
чим
is a big
ділитися, і в
achievement.
тому
We
числі,
do
якщо
have things
говорити
to
про
share.
інновації в
And
лікуванні,
if you
це
say about the
беззаперечно
innovation and
передовий
treatment,
досвід
this
пульмонології,
is your
наукового
institution's experience, the scientific
національного наукового
and national
центру.
scientific
Бачите,
center
зміни
as well.
відбуваються,
See,
зміни
changes are
фактично
happening,
по
changes
всім
in
абсолютно
in
фронтам, і
every
це дуже добре,
possible front
що
line. This
навіть
is
зараз
really great
відбуваються
that
певні
even now
трансформації для
there is a small
і
transformation there that's
відповідності до тих
happening
викликів сьогодення,
according
які
to the
є.
challenges
А
that we
виклики є
have. And so
беззаперечними,
we
тому
do have
що ми
some
всі з вами чудово
challenges
розуміємо, що
because all
настільки
of us
тривалий
understand
час
that
боротьби
for
в
such a
умовах
long
війни
time
вимагає від нас
fighting
з
within
одного
the
боку
war,
більш
it's
глибокого
requests for us
переосмислення
more of
тих
the deeper
існуючих практик і
understanding of
підходів, які
the
є, для того, щоб ми
approaches, the
чітко розуміли,
practices that we have
продовжували виключно ті
and
інтервенції,
to
ті
understand the
заходи, які дійсно між
interventions
собою мають і
that
доказовий
really
підґрунтя,
have
і є
under them both
ефективними,
the
і в тому числі
evidence and they are
інноваційними, тому що
effective
війна створює
and innovative as well
додаткові
because
виклики,
the war
додаткові
creates
бар'єри, на
additional
які
challenges,
ми реально
additional
маємо
barriers
реагувати.
that
І
we
якщо
really
хтось в
have to
своїй
respond
діяльності
to. If
не змінює
somebody in their
підходи,
activity
власне
did not
кажучи,
change their
можливо, саме
approaches,
сьогодні цей день
maybe today
настав,
is the
тому
day to
що
change
якщо
your
раніше ми говорили
practices. Because
про
if
те,
before we
що
were usually
діагностика
saying that the
проводиться
diagnostics is
місяцями,
happening
про те,
for
що
months,
лікування відбувалося
that the
фактично
treatment is
роками,
happening for
а з
months and
профілактики
months.
ми могли
And so
запропонувати в більшій
from
мірі
prevention, we can
фактично
give
тільки
more
вакцинацію
so
БЦЖ.
only
То
vaccination
на
from
сьогоднішній
BCG.
день наскільки світ змінився,
How the
наскільки
world has
є більш
changed
сучасні
and
підходи,
how
зараз уже ніби і не
more
новина, що
modern
діагностувати
approaches
не
for
просто
nobody.
туберкульоз, а лікарсько-стійкий
We don't
туберкульоз можна фактично
detect
протягом
just
кількох
TB,
годин.
but also
А для
everything else.
захисту, для
And
профілактики
of
ми
as it's
чекаємо нову
resistant or not
вакцину, яка
resistant, we are
дуже
waiting for the
хотілося б,
new
щоб дійсно, як
vaccine.
було анонсовано Всесвітньою організацією охорони
And as
здоров'я,
it was
з'явилася
announced
в
by WHO, that
2027 році.
for in
Сьогодні ми
2027 it
говоримо
actually
про
be there.
доступність і інноваційних
Right now,
підходів в
we
профілактиці.
are
Якщо раніше
speaking about the innovative
принаймні були
means
схеми
of
з ізоніазида,
prevention.
багато хто пам'ятає з вас
So
ще
for
тубазид, то сьогодні
um,
є
you all
одно-трьохмісячні
remember
схеми. Лікування
isoniazid
туберкульозу це
regimens
4-6
and also
місяців для
TB
чутливого
treatment for
туберкульозу,
4 to
фактично
6 months
6-9
for
місяців в середньому
susceptible
для
TB, 6 to 9 months
лікарсько-стійкого
for the
туберкульозу.
resistant
І
TB as
трішечки, щоб
well. And
додати
just a bit
оптимізму,
to add here the
власне кажучи, на
optimism.
цьому не завершуються передові
This is
світові
not the world
доробки, і
leading
зараз світ
practice.
працює над тим,
They're
щоб
not
фактично
stopping
при
there. So then we are
одномісячні
working so
схеми.
that
І я
they're going to be
впевнена, що з тим
one
потенціалом,
month's
який є в
regimen.
нашій
So I think
країні,
that with
з тою
the potential
згуртованістю
that the
між
country has,
науковим
with
центром, практичної охорони
the
здоров'я,
union that
Міністерством
we
охорони
have among
здоров'я,
the
всі
practitioners,
ті
scientific
інновації,
centers,
які
and all
будуть
those
доступні
innovations
світу, особисто я
that will
впевнена,
be
що вони
available to
будуть
the world,
доступні, в тому числі і
they
в
will be
нашій країні.
accessible
Головне, щоб
both in
дійсно
their
світ
countries as
рухався
well.
вперед, і ці
It's
можливості
important for us for the
ставали
world to move
доступними для
forward and for
країн,
those
навіть для
capacities to
таких,
be
як ми, які тривалий час
accessible for
перебувають в
countries like
зоні
us,
активних бойових
for
дій.
countries
Що
that are
стосується
in the
війни,
at
то
war.
звичайно
Regarding
це
war, then of
безпрецедентні
course
виклики,
this is
виклики щоденні.
unprecedented
Навіть сьогодні,
challenges,
добираючись на конференцію,
daily
що
challenges.
в
So now
котрий
getting
раз
to the
лунала
conference and
тривога, і ми всі
yet
чудово
again
розуміємо,
in
наскільки
an
важче
era
зараз
where it has been on, and
працювати,
we know
і
how hard it is to work
яка
right now,
відданість, з якою продовжують
and what level
рухатися
of
наші
dedication
медики,
that
наші колеги
our
і в
medics and their
прифронтових
colleagues are
територіях,
continuing to
де
do
свої
so, both near the
особливості,
front lines when
і
they have
в
their
більш
own
безпечних регіонах, хоча
specifics in the
безпечних
safer
регіонів в нашій
region, even
країні
though
на сьогоднішній день
there's no
реально
real
немає,
safe
але є
regions in
просто
our country.
інші,
But yet again, there's just
інші
different
виклики в
challenges
центральних західних регіонах, куди
in a
переміщаються
central or
значною
different
мірою
parts of
внутрішньо
the world
переміщені
where
особи.
internally
А
displaced
також
people
ці
are moving
регіони
within the
беруть на
country and outside
себе
of the country, and also
додаткову
those regions
відповідальність по
are
наданню
taking
медичної
additional
допомоги
responsibility
при
on provision
травмах
of the
бойових і
healthcare
полікуванні
in
військових.
the
Тобто
military
фактично
trauma and
задіяна вся
treatment of
країна
the
в
military
кожного
personnel.
свої
The whole
особливості,
country
але та
has their own
згуртованість та
responsible.
відданість
But
праці,
yet again, that
звичайно, вона
dedication and
нас
commitment,
всіх мотивує продовжувати
it
кожного
motivates
дня
all of
рухатися
us to
вперед.
continue
І
day
завдяки
by
цьому,
day to move
звичайно, ми
forward
бачимо,
and only
що попри
forward.
всі
And
ті
in that,
складнощі, які є,
we
і
can
з порушенням
see
моніторингу лікування, і з
the
затриманням діагностики
complexities with the
туберкульозу, і з тим,
interruptions in
що люди
treatment
багато в чому не зважають для себе важливим
and for
захист,
people who don't think that they need to be
профілактуватися від
protected
туберкульозу.
and to
Але
prevent from
разом з тим у
TB.
нас є щоденні успіхи, про які ми також
And
будемо
we have
протягом
daily
сьогоднішнього дня ділитися
successes that we
разом
will be
з вами.
sharing during
Успіхи
today
багато в чому
with you.
завдяки,
Thank you
як я вже
so and the
озвучила,
challenges
героїзму
and
наших медиків,
successfulness
а також
that we have
тому, що
because of
сьогодні у
how
нас є
heroic our
можливість
medics are
продовжувати
and that we have
працювати
an ability to
завдяки
continue to work
роботі і
because of the
захисту
line of
нашої
work and the
країни, Збройним
protection of our
силам
country by the armed
України
forces
і
of
всім
Ukraine,
тим, хто сьогодні
and
стоїть на
to
захисті.
everybody who
Ні
is
для
there
кого
to
не секрет,
protect
що
us,
в тому
because it's
числі
not a
і
secret for
медики, крім
anybody
того,
that
що продовжують
also medics, apart from the
захищати
fact that
наше
they are
населення від
continuing to
хвороб,
protect
також
our
долучаються
population,
до
they're
захисту
also
нашої
joining into the
країни. І на
protection of our
сьогоднішній день
country, and
ми провели дослідження на національному
we make
рівні,
a
яке
research
глибоко нас
on the
вразило,
national level that
що
has
фактично
deeply
всі фтизіатри
finance that all
в
the TB
доволі
doctors,
такі
almost all the
складній
TB
ситуації
doctors
з
in such a
високими
complex
рівнями і
situation with high
тривожності,
levels of
і
anxiety
депресії, а
and
іноді
depression.
нам навіть здається, що
Sometimes we
медики
even
більш
think that
виснажені,
medics are
ніж
even
наші
more
пацієнти. І, власне
exhausted than our
кажучи, цей
patients.
рік
And
ми
so
оголошуємо фактично
this
роком
year we announce
підтримки
as the
наших
year
колег,
of
наших
support to
медиків,
our
тому що це
colleagues,
найцінніший ресурс, який
medics,
дійсно
because this
ми
is the
не
most
зможемо
important
відновити.
resource
Тому,
that we
користуючись
can't
нагодою,
really
подбайте про себе і
recover
під
quickly.
час
Well, then
тому,
please
щоб
paint your attention to
розвивати себе,
you,
продовжувати
to develop
навчатися,
yourself,
продовжувати мріяти і
and to continue
продовжувати
to do
будувати плани
and to
на
continue to
майбутнє,
create the
тому що
plans for the
майбутнє
future.
нашої
Therefore,
країни
because future
беззаперечно
of our
є,
country
як і майбутнє
is
в
there,
тому, що
and
ми
also is
дамо
the
посилену
fact that
відповідь на проблему
we will
туберкульозу.
give
Адже для
the
цього у нас
response to
є
TB
багато
program,
чого.
because
Це і
we have a lot
підтримка
of things for that,
наших
which is the
партнерів
support
і на
from our
національному
partners
рівні, і
from the
Міністерства охорони
national level
здоров'я,
and
і
Ministry of
Національного
Health
ем, наукового
and
центру,
National Scientific
який
Center
прийняв функції Інституту фтизіатрії і
that put the
пульмонології,
functions of
і
the
також наших
pulmonology
міжнародних
and
партнерів
TB
і
treatment
Всесвітньої
in our
організації
international
охорони
partners
здоров'я,
and
і
WHO
TB Альянс, і Глобального
and
фонду,
TB Alliance
і
and the Global
пацієнтських
Fund as well,
організацій,
and
громадськості,
patient
неурядового сектору.
organization,
Звичайно, всі ми разом
and
можемо
all of us
давати належну
together
відповідь на
can
проблематику
give a
туберкульозу.
response for
Тому
issues
всім
of
нам
TB.
бажаю
So
натхнення,
I wish
мотивації,
all of
віри
you
і
to have
продовжити сумлінно працювати, за
to
що
be
я й
inspired, to
повторяюсь,
be
дякую від
motivated,
імені
to work
Національної
yet again and again. I
протитуберкульозної
just like to
програми
say
і
thank
ще
you
раз
to the
інституту
National
за те, що
Anti-TB
сьогодні
Program
ми тут
and to your
зібралися, і за
institution
те,
for us
що в нас
getting
є
there together
унікальна нагода
and for us to have
продовжувати
this unique
будувати
opportunity
згуртовано,
to build
скоординовано всі наші
coordinated
плани
our
для
plans
того, щоб посилити відповідь на проблематику туберкульозу.
to
Дякую.
improve the TB treatment.
Дуже
And
дякую,
thank you
пані
so
Яна,
much,
за такі
dear
чудові
Yana, for
слова
such a great words
від
and kind
Національного
words,
наукового
both
центру,
in
від
terms of our
нашої
institution
багаторічної
and our
співпраці.
multi-year
Дійсно, з
cooperation.
Центром громадського здоров'я у нас дуже
And with the
давні
public health center, we have a
зв'язки,
really
напевно, з
long
моменту
time,
створення
probably from the
Центру
moment of its
громадського здоров'я і
establishment
понині ці зв'язки тільки зростають.
until
Про це
today.
ми будемо говорити під
They're
час
only
наших
growing, and
сесій
so
і
we will be speaking
конференцій.
about our
А
this
зараз я
on our
хотіла би
sessions. And now
передати
I'd
слово
just like to pass the floor
нашим
to
партнерам,
our partners
також з багаторічним
with the
історичним
multi-year
досвідом
historic
співпраці.
experience of
Це
cooperation,
Всесвітня
which
організація
is
охорони
to the
здоров'я.
WHO,
З
World
ВОЗ
Health
нас
Organization.
пов'язують
With
дуже
WHO,
великі
we are being
історичні
connected by a
зв'язки,
big
тому
and
що саме
historic
Всесвітня
connection because
організація
the
охорони здоров'я у
WHO,
сфері боротьби з
in
туберкульозом
terms of
завжди
fighting
займала
TB,
лідерські
always
позиції.
took the
Ці
leadership and
гайдлайни,
for all
всі
of the guidelines,
настанови
all of the
міжнародні,
protocols,
які
all the
написані в
international things and
туберкульозі,
papers that are dedicated to
лідерство
TB,
в написанні і кумуляції інформації
leadership
щодо
and the
лікування,
level of
діагностики,
information that they're
профілактики
given
туберкульозу
on the TB
належить
diagnosis
саме
and treatment,
Всесвітній організації охорони здоров'я.
it's dedicated
Є
to WHO.
інші потужні наукові
There
центри,
are
які
other
також
scientific centers that
намагаються
also
робити
are
подібну
trying to
роботу,
do
але
similar
як
lines of
за
work,
нашим
but
досвідом, по
in
крайній
our
мірі, в сфері
experience, at
боротьби з
least in the
туберкульозом,
area of fighting TB
кращої
or combating TB,
роботи
there's no
і
better line of work than
організації
in the
і
organizations
представлені всіх
and
наукових
representation
доробок
of all the
в сфері
scientific
туберкульозу не
processing
зробила
workings
ні
in
одна
TB
організація, крім
was not done by
Всесвітньої
none other
організації
organization
охорони
apart from the
здоров'я.
WHO.
І тому мені дуже
And so
приємно
therefore, it's
передати
such a
слово,
great
дати
honor
для
to pass the
привітання
floor for the welcoming words
голові
to
представництва
the
ВОЗ в Україні,
WR, to World Health
доктору
Organization
Ярно
representative in Ukraine, to
Хабіхту.
Yarno
І,
Khabikt,
будь ласка,
and so
запрошуємо вас до
please
слова.
welcoming you to the floor.
Dear colleagues, friends, healthcare workers, I'm pleased to open today's National Tuberculosis Conference in Ukraine, in a country whose strength and resilience continue to inspire us all. We meet at a time when Ukraine is not only responding to long-standing health challenges like tuberculosis, but also doing so under extraordinary pressure of an ongoing war since Russian Federation invasion in February 2022. The full-scale invasion severely impacted the health system. The health facilities have been damaged or destroyed. healthcare workers have been displaced, and the maintenance of essential health services remains under constant threat. Millions of people have been internally displaced, often multiple times. Migration, overcrowding, poverty, and psychosocial distress, all of which are well-known drivers of tuberculosis, have worsened in the last 3 years. The war has placed an enormous strain on the country's ability to detect, diagnose, and treat tuberculosis, particularly among the most vulnerable. Despite this, Ukraine's tuberculosis program continues to function and adapt, a testament to the dedication of national authorities, health professionals like you, and our partners on the ground. And it is precisely this determination that brings us together today. According to the latest WHO estimates for 2023, Ukraine had approximately 42,000 new TB cases, with an incident rate of 112 per 100,000 population. National data reports lower rate of 48.4 per 100,000, reflecting a 7.3% increase from the previous year. We need to look to this trend deeply and interpret carefully within the complex context of war, displacement, and weakened surveillance systems in the health system. Tuberculosis-related mortality is equally concerning. WHO estimates 2,600 TB deaths among HIV-negative people and additional 3,700 deaths among people living with HIV. Each of those figures represents not just a number, but a life cut short. Despite these challenges, Ukraine's tuberculosis program remains active, resilient, and reform-oriented. We at the WHO stand with you. Together, we have supported the rapid introduction of shorter and more effective regimens for drug-resistant TB, helped to safeguard access to diagnostics and medicines even during active hostilities, and also strengthened the national response through strategic planning and capacity building. Dear participants, we have worked closely with the Ministry of Health and the Public Health Center of Ukraine to align policies with the NTB strategy, known globally, and to ensure the tuberculosis response remains patient-centered, equitable, and evidence-based. I encourage you today to reflect on challenges and solutions at the same time. Please share your bold, evidence-based ideas rooted in the realities of war and recovery. The World Health Organization remains fully committed to supporting Ukraine in delivering care, saving lives, and ending tuberculosis. Thank you for your commitment, courage, and partnerships. Let this conference be a platform not only for technical exchange, but also for solidarity, hope, and action. Thank you. Дякую.
Дуже дякуємо, пане
Thank you
Ярне,
so
за
much,
такі
dear Yarno, for such
чутливі
a
слова, за
sensitive,
слова
sensible
підтримки
words of
нашої
support
країни і
of our country,
за ту
and for
впевненість, що міжнародні
knowing
партнери,
that international
дивлячись ні на
partners,
які
even
негаразди,
though
не
their
збираються
difficulties are
залишати
not
нашу
planning to leave us
країну, не
alone,
збираються залишати
they're not planning to
туберкульозну службу, а
to
будуть
make the TB
тільки за
service of
можливості
Sun alone, but
підсилювати цю
they will
підтримку
reinforce the
разом
support,
в
make it stronger,
партнерстві
better,
з
and together
громадськими,
in partnership with
з
the
медичними
NGOs and
організаціями
medical organizations.
і надалі
And also in the
намагатися
future, we'll
досягнути
be trying to
тієї мети
achieve
до
the overall
2035
objective for
року.
2030
Вся
that
світова спільнота в боротьбі з туберкульозом для себе
fight of
поставила,
TB
і ми
are
також
still
маємо
holding
таку
strong together.
амбітну
And so
мету,
we also have
що
this
не
ambitious
дивлячись на те, що
objective that even
відбувається
though
на даний момент
what is happening now in the country, in the Ukraine, all of us together with the international partners support, with the being joined hand in hand and standing shoulder to shoulder, we'll be able to handle all that. We will be able to handle them as it's mentioned and as it's been planned in the international strategy on TB. And so the floor is now being passed for the welcoming remark also to our long-term partners that are working in Ukraine for many, many years, which is the American NGO TB Alliance. TB Alliance is the flagship in the development of new antimicrobial medication and new highly effective and efficient and known to everybody BPAL regimen that has 3 or tops 4 antimicrobial components for 6 or tops 9 months of treatment, which was the development of the organization. And also, as I mentioned by Yana, this organization, together with other international organizations, is not being stopped on the achievements that we received so far, but we are planning to develop new formulas of antimicrobials, new combination of existing antimicrobials, and also for 6 months and even for 4 months. This is not the shortest course we are waiting for, the new information. And so now, during your conference on there's also going to be presentations on that, on this strong organization. But at this moment of time, I would just like to welcome to the floor for the welcome remark the head of the medical department on the development of new antimicrobials, Sandeep Junaidi. It's the Senior President Market Access. So please, the floor is yours.
Dear colleagues, partners, and friends, it's an honor to join you today, even if virtually, for this important conference on innovative approaches to the diagnostics and treatment of tuberculosis and other lung diseases. On behalf of TB Alliance, I extend my sincere thanks to the National Scientific Center of Physiology, Pulmonology, and Allergology, the Ministry of Health of Ukraine, the National TB Program, and all our partners for your leadership in advancing TB care. The theme of this conference couldn't have been more timely. Innovation in TB care is not only about developing new treatments, it's also about how we rethink the way we deliver them to people. Shorter, safer, and simpler treatments are essential, but also is the speed at which we make them available and accessible to everyone who needs them. Ukraine has already shown tremendous leadership in this regard. The rapid move from operational research to programmatic use of BPAL just 3 months after WHO guidelines is a clear demonstration of commitment and agility. Your drafting of clinical guidelines, even ahead of final global guidance, shows the kind of proactivity that truly saves lives. But alongside these achievements, we know that there are practical challenges that still stand in the way of fully realizing the promise of innovation, including the BPAL regimen. One such challenge is the current thrice weekly regimen. I hear regularly from physicians and program managers around the world about difficulties this creates. For patients, it is easy to forget non daily doses, especially outside of directly observed therapy. For clinicians and programs, maintaining adherence to such schedule adds unnecessary complexity and increases the risk of missed doses. At TB Alliance, we have generated evidence supporting once daily dosing of bedaquiline, which could help simplify treatment and improve adherence significantly. And yet, despite this progress, it remains largely unspoken and unimplemented globally. No country has yet made the move to daily dosing. Given Ukraine's record of seizing opportunities and moving fast on innovations, perhaps Ukraine can once again lead the way and become the first country to implement once daily dosing of bedaquiline at programmatic scale. It is a real issue that no one has fully addressed, and with your leadership, we can change that. Together, we can close this gap between science and practice and set yet another powerful example for the rest of the world to follow. At TB Alliance, we believe in continuing to push the envelope on TB treatment and simplify and improve with new drugs and bold new technologies and new ideas not applied to the field so far. Just like we have simplified MDR TB treatment with BPAL-M and once daily bedaquiline, we are now working tirelessly towards much simpler regimens that require as little as 1 month of treatment for active TB and only 1 day for latent TB. We call this our one by one vision. And just as importantly, we aim to ensure that once innovations are ready, they start reaching people who need them without delay. As we look ahead, simplification will remain key, whether through daily dosing, ultra short treatments, or more decentralized models of care. These steps will help us realize our shared goal of ending TB. On behalf of TB Alliance, I want to reaffirm our full commitment to working alongside you in Ukraine and globally so that every person affected by TB receives the best possible care without delay. I wish you a productive and inspiring conference. Thank you.
Дуже дякуємо,
Well, thank
пане
you so
Санді,
much, dear
за
Sandy, for
чудову
such a
промову і
wonderful
за ту
presentation and
надію,
for hope
яку ви
that
нам
you're
додатково
portraying to us
надали з приводу подальшого
on the
розвитку
future development
антимікробіальної
of
терапії,
anti-TB
її
medication,
покращення,
its improvement,
її ефективності, скорочення загальної
and
тривалості, а як
shortening
наслідок
its
кращої
duration,
переносимості і кращого комплаєнсу
better
у людей,
compliance
які
in
мають
people
туберкульоз
that
до
have
такого
TB
лікування.
for that treatment.
Шановні колеги, на цьому наша вітальна частина
Yeah, our opening
добігла
remarks have
кінця.
finished,
Ми
and
вас всіх
we
запрошуємо
are
залишатися
welcoming
в
all of you
стрімі.
to stay in the
Додатково я
stream.
хочу ще
And
сказати, що якщо у вас немає
if you
можливості
don't have an ability to
прослухати весь стрім
listen
від
to the whole
початку і до
stream from the
кінця
beginning till the end
зараз, ви можете
right
це
now, what you can
зробити
do
якраз на
is
YouTube
to watch
каналі
this on the
National
YouTube
TB Hub.
channel of National TB
Всі
Hub.
наші записи і
All of our
конференції, і майстер-класів
recordings
будуть
and
доступні
masterclasses and everything else, it's
безкоштовно
accessible for free
постійно на
and
YouTube каналі
constantly on
National TB
the
Hub.
YouTube channel of
Єдина
National
умова,
TB Hub. The only
пам'ятайте,
precondition
для того, щоб ми змогли вам
for
видати
us to be
сертифікати,
able to give you a
обов'язково в
certificate
кінці
in
заходу
the
треба
end of
пройти
the event, you
тестування
would need to go
і
for testing
дати на тести
and
70%
to
правильних
give
відповідей.
70% of correct
Всім
answer to the
бажаю
testing. So I
удачі
wish you
і
all to
продовжуємо
have a
нашу
great day, and
роботу.
we are
Перша
continuing to do
сесія
our work. So the
почнеться
first
через пару
session will start
хвилин.
in a few minutes.
Дякую.
Thank you so much.
Шановні колеги, ще раз всім
Dear
добрий день.
colleagues, good morning again,
Вітаємо вас на
and
нашій
good morning to
конференції
you. Welcoming you on our
Міжнародній науковій
conference of
конференції, яка
international
присвячена
scientific conference
всесвітньому дню
dedicated to
здоров'я.
the World
І
Health
наша
Day.
перша
In
сесія,
our first
яка
session,
називається
that is
"Впровадження
called the
сучасних підходів
implementation of the
ведення боротьби з
modern approaches
туберкульозу
to
та якісне
tuberculosis case
навчання
management and
медиків",
high quality
це є
education
невід'ємною
of
складовою
partners. This
ефективної
is
боротьби з
a
туберкульозом.
irreplaceable
Протягом нашої
moment
сесії
of
ми з
TB
вами
medication.
поговоримо
So
про
during
дуже
our sessions,
важливі і
we will be
актуальні
speaking of
стратегічні
really
питання.
up-to-date and strategical
Від
questions and
наших
issues
національних
from
і
our
міжнародних
national and
партнерів
international
ми
partners.
почуємо і основні
We'll be able to
досягнення,
hear out both the main
які
achievements
уже
that
на даний
are
момент в сфері боротьби з
present
туберкульозом
with for the
існують,
TB
які виклики
fighting and what
стоять
kind of
перед
challenges there
світовою
are
спільнотою, перед
in front of
людьми,
international
які можуть
community and
захворіти на
in
цю
front of the
недугу, перед
people who can get this
медиками,
disease, in front
перед
of the medics, and in
іншими
front of the
партнерами, які працюють в сфері боротьби з
other partners
туберкульозом.
that are
Але
working
при
in
цьому
fighting
які
TB. But
є
together with that,
надії, які
what kind of
інновації на
hopes
нас
we have,
чекають, про все це
what
ми з
kind of
вами поговоримо
innovations we
протягом
expect to have,
цієї
all of
конференції.
that
Ми з
to
вами
be
стикнемося не
revealed
тільки
later. And so we will also
безпосередньо
face
про
not
лікування
just the
туберкульозу
treatment
в дорослих,
aspects of
також
TB.
поговоримо
For adults,
з
we'll also
міжнародними
mention
експертами
with
про
the
лікування
international
дитячого
experts about the
туберкульозу.
treatment of pediatric
Трошки
TB.
поговоримо про
A few
місце
words
хірургічного
about the place of the
лікування в
surgery in
туберкульозі.
treatment of
І,
TB.
звичайно, якщо ми зараз
And
говоримо про
overall,
такі
if we are
серйозні
to
питання,
mention about the
як
national
діагностика і лікування захворювань, і якщо ми
diagnostics and
говоримо про
treatment, and so
медичні
if we
навчальні
are
заходи
to mention about
для
medical
медичних
educational
працівників в першу
facilities,
чергу, ми не можемо з
medical
вами не
workers, we
поговорити
can't
про
really
медичну освіту,
not
про
speak about
те,
medical
що
education.
чекає українських медиків,
Also, what expect
які зміни в
what our medics
атестації
can expect,
лікарів найближчим
changes in
часом
testing
будуть.
for doctors,
Але ми поговоримо не тільки про наш український досвід і
not
наші
just the
українські
Ukrainian
плани,
experience and not
але і
just Ukrainian
послухаємо
plans, but
доповідь
also
міжнародного
listen to the presentation
експерта
of
з приводу
international
того, як
experts.
виглядає освіта лікарів в
What's like the teaching
країнах
or educational
Європейського
system
Союзу.
for
І
doctors in the European
також
Union countries.
поділимось ми
And also, we
своїм
can share
досвідом,
with our own
як
experience
проводимо
how are we
освітню
conducting
діяльність з
educational
медиками
activities with
на базі
medics
нашого
on
національного
our
тренінгового
national
центру,
training
і
centers,
які
and
у
also
нас плани для того,
and what
щоб
are our
мати
plans
також не тільки національний, а
to also
світовий,
have not just
світовий рівень
national but
медичної
international level
освіти.
of medical
І перше
education.
слово в нашій сесії я хочу
And the
предоставити
first floor would be
Георгію
given
Димову.
to Georgi Dimov.
Георгій є
Georgi
представником
is a
Всесвітньої
representative
організації
or
охорони здоров'я.
working in
Він
the
є
WHO country
національним
office in
фахівцем з
Ukraine
питань
and is national
туберкульозу
expert on TB
Українського офісу
of
ВООЗ.
Ukrainian
Є
WHO
фахівцем у
office.
сфері
He's
громадського
also an expert
здоров'я і
in public
наступив із
health of
15-річним
over
досвідом в
15 years
управлінні програмами
experience in
надання
management of
допомоги людям, що страждають від
helping people who
туберкульозу.
suffering on
Наразі пан
TB.
Георгій обіймає посаду технічного спеціаліста з туберкульозу в
He's
країнному
working as a
офісі
technical
ВООЗ в
expert as
Україні
a TB
Європейського
and
регіонального
WHO
бюро.
office in Ukraine.
Має досвід як
Has an
роботи
experience as both the work
клінічної, так і
of the clinical line of
організаційної
work and also
роботи,
organizational line of work,
і додатково в
and
роботі інших
additionally in
міжнародних
the work of
організацій.
additional and other
І
healthcare
пан
organization. And
Георгій
so Georgi
нам
has a
зробить
lecture or
доповідь на
presentation
дуже
on
важливі
an
і
important
цікаві
and
теми. Ми
interesting
дуже з
topic for us.
задоволенням
With a great
послухаємо
pleasure, we
пріоритетні
will listen
напрямки
to
щодо
him.
боротьби з
Priority areas
лікарсько-стійким
of work and
туберкульозом в
treatment of
Україні
the
за
drug-resistant
поглядом
TB
Всесвітньої
uh,
організації охорони
based on
здоров'я.
WHO priority
Дуже
areas of
цікаво,
work. So
як
it's an
ВОЗ
interesting thing
дивиться
how
на Україну
WHO is
і як
looking
ми
at Ukraine
виглядаємо
and how
на
do we
мапі
look
світу в
on the
сфері боротьби з
world's map
туберкульозом. Пане
in
Георгій, будь
fighting
ласка, вам
TB.
слово.
So Georgi, the floor is
Дякую,
yours.
пані Наталя.
Thank you so much, dear
Вітаю,
Natalia.
колеги.
Greetings, dear
У
colleagues.
своїй
And
презентації
in my
я
presentation,
хотів би
I would just like
обрисувати
to
пріоритетні напрямки
highlight
боротьби
the
з
priority area
туберкульозом
of
і
work of
особливо з
fighting TB, and
лікарсько-шкідним
especially
туберкульозом в Україні.
with the
Розпочати її
resistant
хотів би
forms of TB. I would just like to start
словами
it up with the words of
регіонального директора
our regional
Офісу ВОЗ
director of WHO office in the
ВОЗ
European region,
в Європі доктора Ханса Клюге. До
or
речі,
Hans Kluge.
доктор Ханс Клюге
Hans Kluge
є
is
фтизіатром
the
за своїм
is a
фахом і
TB physician
присвятив багато
actually, and he dedicated a lot of time
роботи туберкульозу.
of his work to fighting combating TB. Please read it on the slide as far as I'm concerned.
Не бачу. Дякую. Так от.
So what he said is,
Доктор Ханс каже, зараз майже неймовірні медичні та
now, thanks to
технологічний
almost
прогрес,
unbelievable
ми
medical
маємо
and technological
інструменти
advantages,
для
we
того,
have
щоб
new tools
здолати
and strategy
глобальну
to
епідемію
prevent,
туберкульозу.
diagnose, and treat TB.
Тим не менш, туберкульоз
Nevertheless,
залишається
TB remains
серйозною
a serious
загрозою.
threat.
Тому треба
That is why we need
діяти
to act
терміново. Ми
urgently.
повинні
We must work together
привернути увагу, щоб запровадити
to
та
introduce and scale
розширити
up
інноваційні підходи
innovative
до догляду,
approaches to care and to harness
використати переваги
the
досліджень і
benefits of
зробити ліки
research
доступними для
and
всіх.
to make
Я
medication
закликаю всі
available to all. I
держави-члени
call
та
all member
партнерів
states and
Європи та
partners
Центральної
in
Азії
Europe and Central
розробити
Asia to
національні
strengthen
стратегії
national
та залучити
strategies and
транскордонне
engage in
співробітництво, щоб
cross-border
прискорити
cooperation
прогрес
to
у
accelerate progress
викорененні
toward TB
туберкульозу. Разом ми
elimination.
можемо досягти
Together we
успіху.
can
Ми можемо
succeed.
забезпечити,
We
щоб
can ensure
ніхто
that
не
no
страждав, ось
one
потреба,
suffers
щоб жодна
unnecessarily,
сім'я не зазнала
that
шкоди
no
від
family
цієї
is
руйнівної
harmed
хвороби.
by this devastating
Давайте
disease. Let's
об'єднаємо
join
зусилля,
forces and
щоб
succeed
досягти успіху
in
та
TB
покінчити з
once and for
туберкульозом
all.
назавжди. Я хочу звернути вашу
Also,
увагу,
I'd just like to
колеги,
point
що
your attention, dear
туберкульоз є
colleagues, that
інфекційною
tuberculosis
хворобою, яка
is an infectious
спричиняє
disease or
найбільшу
communicable
кількість
disease that
смертей
causes
у
the
світі.
largest number of
Це
deaths in the
головна
world.
причина
It's a
смертей
leading cause of
від
deaths
людей
for
з ВІЛ
people living with
та основний
HIV
фактор
and the major
смертності,
factors of
пов'язаний з
deaths related
антибіотикорезистентністю.
with the
Згідно
AMR.
глобального туберкульозного
According to
репорту
the
ВООЗ за
Global
2024
Tuberculosis
рік,
Report for
на туберкульоз у
2024,
світі
TB
захворіло
in the world
38
has
мільйонів осіб.
10.8
На
million
жаль,
people, and
померло з них 1
unfortunately,
мільйон 250
1.2 million
тисяч
people
людей,
died
а
from
понад 14
tuberculosis,
тисяч
and over
розвинулося
400,000
стійкі
people
до ліків
developed the
форми
drug-resistant forms
захворювання
of
на ТБ.
TB.
За оцінками,
It
близько
is
чверті
estimated that
населення
around a
планети
quarter of the world
інфіковано бактеріями
population is
туберкульозу.
infected with
Але
the tuberculosis
туберкульоз
bacteria.
це
But TB
хвороба,
is
яку можна
a
запобігти
condition
та
that can be
яку можна
prevented and
вилікувати.
can be cured.
З цією метою
It was this point in mind and with this goal
ВОЗ
in mind,
та партнери
WHO and the
розробили
partners
стратегії
have developed strategies
НТБ або
and
і
TB
метою
strategies.
стратегії
And the
є
objective of those strategies are
подолати туберкульоз, є мета
to
зробити
conquer
світ
TB
вільним
and
від
to make the world
туберкульозу. До
free from TB.
2035 року,
Till the
згідно стратегії,
2035, the
планується зменшити
strategy is planned
смертність на
to reduce the
95%,
mortality to
захворюваність на
95%
90%
less,
та
and so
зробити
the
так, щоб жодна
morbidity to
родина
90%,
не
and
зазнавала
so that
руйнівного
no
фінансового
family
тягаря
would
у разі,
face
якщо
the
стикнеться з
catastrophic
цією
costs due
хворобою.
to TB.
Як ми все вже
As
розуміємо,
we've
туберкульоз не
seen
знає
around the
кордонів. На
world,
тлі
TB
сучасної
does not
геополітичної
see
нестабільності
any
поширюються
borders and does not
міграційні
pay respect to
процеси
borders.
в
And also because of
європейському
war and other
регіоні.
things,
ВОЗ
migration processes
долучена
are
до транскордонного
getting higher.
механізму
And also
збереження медичних
WHO
даних, де
is
допомагають нашим
involved into
співвітчизникам
transborder
одержати
data
лікування,
exchange and
які
helping
вони
our
були
citizens
змушені
to
переривати в Україні на
continue the
тлі
treatment that they helped
повномасштабної
that they
війни
needed to
розпочатої
interrupt because
Російською
they needed to
Федерацією.
move.
Згідно
According to
статистичних даних,
the statistics data,
досягнення показників
the
з
achievement of
декларованих в
the
стратегії
indicators
НТБ у
dedicated to the
2025
NTB
році
strategy
під
in
загрозою як
2025 is
глобального,
under threat,
так і
both
в
as on the
регіоні
global level and on the
категорії.
regional level and on the
Тому
Ukrainian level
ми
or
всі
national level
повинні
for Ukraine. And
інтенсифікувати
so therefore
зусилля
we
та
have to
працювати
intensify our
разом, щоб
efforts to work together
досягти їх.
to achieve those goals and
Як було
objectives.
визначено вище, суттєвою
As it
проблемою
was
для
mentioned
України є
before, the significant
туберкульоз
problem
з
for Ukraine
резистентністю до ліків.
is
Україна входить в
drug-resistant
п'ятірку
TB.
країн з
Ukraine
найтяжчим
is among
тягарем
5
туберкульозу в
countries with the highest
європейському
burden
регіоні.
of TB in European region.
Проте я хочу зазначити, що ефективність
Still, I would
лікування
like to
туберкульозу в
note that
Україні
treatment
в цілому
efficacy in
співставляє з
Ukraine
європейськими
in
трендами.
general
Проте
is
у
in line with
категоріях
European
імунодефіциту
trends, and in
ні.
some
Це
categories
досягається
it
із
exceeds those
ефективнішим вчасним
indicators.
впровадженням
This is achieved
найголовніших і
by
найефективніших режимів
rapid and
лікування та
timely
прикордонного
implementation
ввозу.
of the newest approaches for
Суттєвий
TB
вплив на
treatment.
захворюваність також здійснюють
The
фактори
significant
ризику розвитку
impact
туберкульозу. На слайді
is
ви
about
можете
the risk
побачити,
factors for TB
що
development. On this
основні
slide,
фактори
you can
ризику
see that the main risk factors
відрізняються
in Ukraine are
загальноєвропейських і
different
світових. Але
from
важливо
those in Europe
дотримуватися
and
загальних
worldwide,
явищ.
and we will speak in more detail about
З
this
цілею
issue.
подолати туберкульоз,
In
ВОЗ
order
розробив
to
регіональний
conquer
план
TB,
протидії
WHO
туберкульозу
developed the regional
і
plan for TB control, and it consists of three pillars. Pillar one is integrated, people-centered care and prevention. Pillar two, bold policies and support systems. And pillar three is strengthened research and innovation. Here on this graph, you can see the trend. And according to this trend, we hope the TB morbidity will be declining, and how these or those activities will impact this decline. As you see, the most significant impact on TB and on reduction of morbidity can be due to implementation of preventive treatment and development of a probable vaccine. However, first and foremost, I would like to spread the following message. The constant fight against stigmas is in all presentations, countering stigma is in the end of everybody's presentation. But I think we should pay more attention to getting rid of stigma, because it prevents us from achieving our goal in TB control. So let's start with prevention. WHO recommends to scale up the cascade approach to TB care and the preventive treatment of TB infection. This includes screening people for TB, clinical assessment to identify active TB, testing for TB infection, and beginning of treatment, as well as end of the preventive treatments. WHO recommends two broad risk groups for systematic assessment of eligibility and provision of preventive TB treatment. These include people at increased risk of progression to TB, including people living with HIV and patients with silicosis who are starting or preparing themselves for treatment with tumor necrosis factor, who are on dialysis or are getting ready for organ transplantation or hematology. People with increased likelihood of contracting TB, which includes household contacts with bacteriologically confirmed TB, people who live or work in overcrowded settings, such as prisoners, healthcare workers, recent migrants, and homeless people and people who use drugs. In 2024, in frames of Europass initiative, the national program for TB control in collaboration with WHO conducted a revision of the national policy on systematic screening and preventive treatment. You can see the main findings and provided recommendations on the slide. WHO recommendation on screening and prevention will be taken upon inclusive consultation within the technical working groups set up by Minister of Health, and it can be one of the core tools for national TB guidelines, which is expected in the first half of 2025. So basically, this work about identifying the most prioritized risks for Ukraine and to provide recommendations for preventive treatments. In Ukraine, preventive TB treatment for people living with HIV makes up 73%, and the coverage with the preventive treatment of household contacts makes up 93%. The next priority is diagnosis, TB diagnosis. WHO helps to enhance TB laboratory service in Ukraine through technical support provided by the supranational laboratory from Germany. The priorities here are to implement molecular genetic diagnosis, to implement a standardized international certification, as well as to introduce sequencing and artificial sputum for quality control. Medical advances have revolutionized TB, and treatment regimens have become much shorter and more efficient. The most recent WHO recommendation on TB treatment recommendations are the following. Bedaquiline is a mandatory component of all MDR TB treatment regimens and is recommended for all ages. 6-month all oral BPAL-M regimen consisting of bedaquiline, ritamanid, linezolid, and moxifloxacin is the regimen of choice for MDR or XDR TB or rifampicin-resistant TB. There are certain programmatic benefits, such as high efficacy, good safety profile, fewer treatment interruptions, earlier treatment outcomes, and there are some economic benefits for both patients and health systems. However, this regimen is suitable for patients above 14 years of age. Unfortunately, it can't be used during pregnancy. In this case, it is recommended to utilize a 9-month regimen. This is the only short regimen available for pregnant women and for children under 14. It can be used in all age groups, regardless of HIV status of patients. Unfortunately, if the first two regimens are not efficient and there is a treatment failure, the last regimen is individualized one. This is the last resort regimen, so it may last for 18 months and more, depending on the resistance. I'd like to note that the rapid adaptation of policies, WHO policies and tools has a significant impact on TB control. And I'd like to also note that Ukraine was the first in Ukraine in European region which updated standardized treatment of TB. On this slide, you can see the vaccine development phases for TB, but unfortunately, it's not available yet for programmatic implementation. What are the constraints? The obstacles to ending TB are mostly political and financial. According to the data available, to provide patients with the TB drugs, WHO introduced the mechanism for border data transfer in European region, which is aligned with Ukrainian NTP. And at the moment, the availability of TB drugs in Ukraine is higher as compared to those in European Union countries. Another challenge is that healthcare systems have many competing priorities, and relatively high mortality numbers of TB as compared to other problems, of course, create certain concern. That's why we need to pay attention to this. And also, unfortunately, the attractiveness of the market for companies for TB drugs is absolutely and relatively low. On this slide, you can see the funds required for the research of new drugs and new formulas, as well as their registration and potential income. And here you can see that for TB, it's even kind of a negative. WHO supports multi-sectoral approach to end TB when all the stakeholders coordinate their efforts and act as a team. Thank you for your attention, dear colleagues. Thank you very much, Georgi, for your wonderful presentation. I have some questions to you, but before I ask my questions, I'd like to read one message in the chat written by one of our participants. Georgi, I'm really happy to hear and see you. Your nurse, Irina Prishva. So you see that even our colleagues, our nurses who support every doctor, they watch us. Yes, let me say hello to Irina. She's a very experienced nurse. She treats patients with drug-resistant TB and TB-HIV co-infection. So at our conference, we don't only exchange scientific experience, but this is also the platform to meet our friends unexpectedly. This could happen anywhere, but it happened at our conference. And I have another professional question to you. This is what we actually started with. In your opinion, how does our country look in terms of TB control as compared to other countries in the world from the WHO viewpoint? Well, from the WHO viewpoint, Ukraine looks like a flagship in implementing all recommendations and innovations. The country invests a lot of efforts to conquer TB. But unfortunately, we all understand that the country has a lot of other challenges related not only to internal problems, but also to the aggression from the part of the Russian Federation. That's why I would say that we should consolidate our efforts. We should keep working, but we're moving in the right direction. Thank you very much. And I hope, actually, we're sure that your words in the future will come true, maybe even sooner than everybody expects them to come true. And Ukraine will remain the flagship of TB control in the world. Thank you very much. And let me give the floor to our next speaker. This is our international partner, Salah Farida, who will tell us about the most recent data regarding the future of DRTB treatment and about innovational shorter treatment regimens. Salah is also a representative of the TB Alliance NGO, and he is a medical coordinator in the Department for the Development and the Introduction of the Innovative TB Drugs. Please, Salah, over to you.
Thank you so much, Dr. Natalia. Can I share my screen? Please let me know if you can see my screen. Great. So thank you very much for the invite. I'm very glad to be here with our partners in Ukraine, who you were the first country to try the BPAL regimen from TB Alliance. My name is Salah Farida, and I work for the TB Alliance, which is a nonprofit organization dedicated to the discovery, development, and delivery of better and more effective TB treatments. In my presentation, I will go very quickly through the history of the drug-resistant TB treatment that we developed and the future research that we are doing towards a better and faster treatment. As you know, the BPAL regimen, which is bedaquiline, pretomanid, and linezolid, started with the next trial that was a few years ago. And in this trial, we tried to investigate a drug regimen for 6 months to treat drug-resistant TB, XDR or MDR, which was very hard to treat back then. The results of the next TB trial, as you all know, was published in the New England Journal of Medicine, and with almost 90% of participants who had severe drug-resistant TB were cured or with favorable outcome. Based on this trial, we received the US FDA approval and the European Medicine Agency approval as well. And starting at that point back in 2020, Ukraine was one of the first countries to start implementing the BPAR regimen under Operation Research. We followed the participants in next TB trial for 2 years after end of treatment. So that's a very long time for follow-up. And still, after 2 years of follow-up, 90% of participants were still like cured and survived and remained healthy, which is the favorable outcome. But in NICS, because we used a very high dose of linezolid, which was 1,200 milligram, that was a high dose of linezolid, we observed two adverse events back then. The first one was myelosuppression, represented mostly as anemia. And the onset of that myelosuppression or anemia was usually early onset, which means it usually happens in the first month or 2 months, and then come to a plateau. While in the peripheral neuropathy, the onset is usually delayed. So peripheral neuropathy usually happens in month number 4 or 5. It's delayed onset related to the high dose of linezolid. That's why we started a follow-up clinical trial, which is XENIX, to investigate if we can maintain the same efficacy of 90% cure rate with lower doses of linezolid, whether 600 milligram of linezolid or like shorter duration than 6 months. And that's the study design that you all know for XENIX. In XENIX, it was multiple countries. As you can see here, 4 countries in that study. And we included HIV patients as well. So 20% of the participants were HIV positive. In NICS, 50% of the participants were HIV positive. Also, most participants, like almost 88%, were either pre-XDR or XDR using the older definitions of WHO definitions. Again, in XENIX, the favorable outcome was almost 90%. That's very similar to what we observed in NICS. So 90% cure rate or favorable outcome was maintained in NICS and XENIX, whether we used 1,200 milligram, the high dose of linezolid in NICS, or the lower doses and shortened durations in XENIX. The median time to culture negative was 8 weeks or 2 months, which is was consistent across our clinical trials. Again, the adverse events related to linezolid were peripheral neuropathy, optic neuropathy, and anemia or myelosuppression. And as you can see, it is lower when we reduce the dose to 600 milligram instead of the higher dose of 1,200 milligram. So in the 600 milligram arms, we did not require modifications of the linezolid dose when compared to the high dose of 1,200 milligram. So we concluded that the 600 milligram linezolid dose is enough for 6 months, and it can be modified based on the adverse events. A third clinical trial that you all know as well is TB Practical. This trial was conducted by our partners, MSF, or Doctors Without Borders, and it included BPAL alone or BPAL with plus clofazimine or BPAL plus moxifloxacin for 6 months. And this study expanded to all patients with any drug-resistant TB. So for all, not only XDR or pre-XDR, but any DR TB patient. This study was published the first time was incomplete results in the New England Journal of Medicine in 2022, but the complete results were published in the Lancet in 2023. And as you can see here, again, the BPAL moxifloxacin was around the 90%, 88%, similar to what we observed in NIX and ZNIX. And also the BPAL regimen was also 86.5%, which is also around the Q rate of NIX and ZNIX of 90%. Adverse events were comparable between the BPAL Moxi and the BPAL without the Moxi. And as you can imagine, the safety profile in BPAL-M and BPAL should be the same. Conclusions were like the BPAL-M, all BPAL-based regimens can be better than the standard of care. And this, like the revision of ZNIX and TB Practical, led to the WHO guidelines, which is to use BPAL-M or BPAL in all drug-resistant TB patients, which means programmatic use. Thank you for all the operation research that was done with countries like Ukraine. You started this, but now it's programmatic use, no more operation research. For any patient who is older than 14 years old, because pretomanid is approved for 14 and above, recommended by the WHO, and the linezolid dose is 600 milligram instead of the 1200 milligram. And the reproductive safety is now have better evidence. And as Sandeep mentioned in the beginning, the bedaquiline dose can be once daily. This is the dose that we used in ZNIX, and all our clinical trials now are using the bedaquiline dose as once daily. And as you know, it can be used as well 3 times a week, like the label of bedaquiline. So many people and countries can benefit from these guidelines for any drug-resistant TB, as you can imagine here. There was another study conducted by the ICMR, India Center for Medical Research, which included more than 400 patients or participants for the BPAL regimen, whether linezolid for 6 months, 600 milligram, or they investigated only 9 weeks of linezolid 600 milligram, and then they reduced the dose to 300 milligram for 17 weeks, or 13 weeks of 600 milligram, and then reduced the dose to 300 milligram for the remaining 13 weeks. In all 3 arms, as you can see, the Q rate was more than 90% in all 3 arms, similar to what we observed in clinical trials, in our clinical trials. What's next? Now to the future research. As you know, pretomanid is recommended for 14 years and older, so it's not for pediatrics. Now we are expanding this, so we are doing the pediatric research, and now we have more than 20 participants in our clinical trial, and 4 participating countries. Hopefully, in a year or 2, we will have results to expand the indication of pretomanid to children below age of 14. This is our pipeline. towards a shorter and more effective regimens. We know that 6 months for drug-resistant TB is a good achievement, but our vision is to achieve more shorter than that and more effective than that. Maybe 3 months, maybe 1 month, as Sandeep mentioned in the beginning. So this is our pipeline, and some research that we are doing is to replace linezolid with a new drug called sutazolid. Sutazolid is from the same family as linezolid. This is one study that is being conducted by our partners, Aurum Institute in many countries. And the idea here is to replace the linezolid with different doses of sutazolid and compare it with the HRGE, that standard of care regimen. And this study is ongoing, and hopefully you will know more about it in the near future. Another study that's conducted by the NIH ECTG, which is the AIDS clinical trial group, is to replace linezolid with our compound called TBI-223. This is similar to linezolid, but we think it could be safer. Or with sutazolid again, similar to linezolid, but it could be safer and more effective. And this study is ongoing as well in many countries. A third compound that we have is called TBAJ876. That's our compound, and it's a new generation of bedaquiline. We think that this compound will be more effective and more potent than bedaquiline, and will overcome any bedaquiline resistance that could be there, and may lead us to a shorter and more effective regimens. This compound is now being investigated in a study called NC009. In this study, we recruited more than 300 patients. We investigated 3 doses of 876, 25 milligram, 50 milligram, and 100 milligram, compared to BPAL and compared to the standard care HRGE in drug-sensitive patients. So 3 doses of 876 replacing bedaquiline in this study. The study design is 8 weeks of 876 plus predominant plus linezolid. So simply we are replacing bedaquiline with our compound 876, different doses, and we are comparing that with BPAL regimen and the standard of care. We will give participants 8 weeks of the new regimen, and then continue for another 7 weeks with HR or isoniazid and rifampicin, and then either stop if they do not have any clinical symptoms and their culture is negative, or continue if they have symptoms or their culture is not negative till week 26. We are currently conducting this trial, and hopefully we'll let you know more information about it in the next few months. The study is still ongoing, and hopefully we have some innovations, whether on the bedaquiline side or on the linezolid side in the near future. All of that would never happen without your collaboration with us. As I said, Ukraine was the first company to start the operation research with BPAL regimen and implementing the programmatic use of BPAL. Also, thanks to all participants or patients who are enroll in our trials, all the donors in this slide, and investigators, physicians, site staff, and all collaborators. Thank you very much, and it was an honor to be with you here.
Дуже дякуємо, Слах,
Thank
за
you so
таку
much for such a
цікаву інформацію.
interesting information.
Ви нас дуже
You have inspired
дали
us
надію нам
and given us
на
hope
майбутнє,
for the future
що найближчим
that
часом
in the nearest future,
протитуберкульозне лікування
anti-TB
буде
medication
не
would be even
тільки
more
і в подальшому
not just
високоефективним, а
highly
ще й
effective in the
як
future, but
мінімум в 2
also
рази коротше від того,
twice
що
shorter
ми
from what we
вживаємо.
had before.
Фтизіатри і лікарі,
TB
які
doctors and
займаються
regular
лікуванням
doctors that are dealing with the
туберкульозом,
TB
тільки
treatment
звикли до
just used to
шестимісячних
6
курсів
months
лікування.
regimen
Навіщо
and
не
that's
всі
it.
країни
Not all the
на даний
countries has
момент
actually at this moment of time has went to
звикли, що
or got
тривалість
used to
лікування
that the
6
treatment
місяців
longevity only
є
for 6 months and that's
стандартною.
supposed to be a
А ви нам
standard and
зараз
not just
пропонуєте ще
and you're
кращі
proposing us to even
спрощення
make it shorter, which is great
протитуберкульозного
for the patient and for
лікування.
the doctor.
Які
And what
ваші
kind of your
можуть бути
can you
слова
say what kind of words
для
can you mention for
клініцистів, для
clinicians, for
лікарів, які займаються
doctors that are
лікуванням
dealing with this every
туберкульозу,
day,
для
dealing with
того,
TB
щоб не було
medication, so that
страху
there's no
і в
fear
подальшому
among them
скорочувати
that
лікування, щоб не було
they would be
стигми
okay with shortening, so that
серед
there's also
саме
stigma
лікарів
among doctors that oh,
до
shorter treatments might not be
сучасних
as effective.
препаратів
So,
і
what kind of words
сучасних
of wisdom can you give
короткострокових
them
схем.
not to be afraid of short-term regimens?
Well, thank you very much. I think the feedback is coming from the field, from investigators and leaders like you. We were all in doubt like 6 years ago, but after we observed what happened in Ukraine, like for example, you had so many patients treated with BPAL regimen in Ukraine, in Indonesia, in India. So some like 5, 6, 7 leading countries, and it started with Ukraine. They gave us the confidence. We were watching the operation research happening in Ukraine and in other countries, and as we get the information from the field, our confidence was increasing day by day from observing and watching what actually happens in the field. And the great thing is, what happened in the field was identical, similar exactly to what we observed in clinical trials. As you know, clinical trials sometimes is controlled, so we want to get more confidence from you in the field, and we got that. WHO was watching as well with us for the last 5 years or 6 years since 2019, and everything that we observed in clinical trials, we observed the same exact thing in the field in countries with leaders like you. So now we have enough confidence. WHO recommended it. Recommended by the European Medicine Agency, FDA, individual countries like Ukraine, India, China. So it's happening, and we have like more confidence now.
Дуже дякуємо, і ми дуже
Thank you so
раді
much,
і
and
дуже
we are so
горді тим,
happy and
що
so proud that
ваша організація
your organization
виділяє нашу державу, Україну
signifies our country so
лідером
much. So
у
either as
розробці і
in the development and
впровадженні
implementation of the
нових
new forms, new
протитуберкульозних
regimens,
препаратів,
and
так
also
і
new forms of
коротких
medication
режимів,
and such short
які
regimens as well
розробляє саме TB
that have been developed
Alliance.
by
Дуже
TB
вам
Alliance. So thank you
дякуємо ще
so
раз.
much again,
Сподіваємося на
and
подальшу
hoping for
плідну
future
співпрацю.
fruitful cooperation in the future for even better outcomes for our patient. Thank you.
Thank you very much.
І, шановні колеги, будемо
And also, dear
продовжувати
colleagues, we
нашу
will
з
be
вами
continuing
роботу.
our work.
Ми з
We
вами
are,
почули
we've heard
погляд ВОЗ
the view of
на те,
WHO
як відбувається боротьба з
and how
туберкульозом в
the
нашій
fighting with TB is
країні.
happening in our country.
Почули від
And we've
наших
heard
поважних
from
партнерів, які
our
подальші
respected partners
перспективи
what kind
щодо
of future
лікування
perspective on treatment
туберкульозу.
of TB.
А тепер настав час
And now the time has
почути
come to hear
безпосередньо
a
від
direct
з нашого
experience
боку,
from our side.
як ми самі
How do
оцінюємо
we
свою
assess
роботу
our
і
line of
як
work and
саме
how
ми сприймаємо ті нові
we
виклики і нові
are looking
перспективи,
at new
які
challenges,
нас
new
чекають.
perspective that are
Я
waiting for
з
us.
великим
And so,
задоволенням
with a
хочу
great
передати
pleasure, I'd just like
слово
to pass the floor to
Терлеєвій Яні,
Yana Terleva,
яка є
who is
нашим
the
NTP
national TB
менеджером,
manager,
є
who is
керівницею
head of
відділу
the
з
TB
контролю
department
та
in
боротьби з
Public Health Center
туберкульозом Центру громадського
of Ministry of
здоров'я.
Health of Ukraine.
І
And We would like to welcome her with her presentation that is called Main Strategic Challenges and Achievements on Fighting the Drug-Resistant TB in Ukraine, Implementation of International Approaches in Conditions of War. Dear colleagues, let me present my presentation that really how we see what kind of challenges and what kind of success stories we have. First of all, what is the real situation here? Here we have the information on how now the incidence is happening for TB, HIV, and viral hepatitis. As we know, the three significant, socially significant diseases that are interdependent from one another and complicate the situation with TB. What we can see here is that at least in the 5-year times, TB has changed and made consequences before during the COVID pandemics when we had the main drop in incidence for TB. Now the situation is stable, almost for 8% decrease in number of incidents, but together with that, a concerning factor that we don't know as of today the real situation because the significant amount of people who have migrated and also big territories of the country that are still staying under occupation, and so telling us that request from us to be even more attentive to the situation, to be even more ready to any scenarios that can happen. And from WHO, and we have the incidence higher than 100 based on WHO assessment, but for the regular citizens, for those numbers, they did not operate because those numbers are based on the data that are not relevant for our countries because they are calculating based on at least 44 million people, and as the based on Western information, we have around 31 million people. And also a big number of people have moved out of the country and are now in migration. Together with that, what can we mention here up front? That in absolute numbers, in comparison with the last year, the number of people has decreased with TB, which makes us optimistic that there's some control on the situation they're still staying, and that also that on the map, in terms of regions, it's a shift the incidence for TB from the south and east of the country to the western and central regions of the country, and where there's the lowest level of disease, we can see that this is traditionally either in the western parts of the country or near the frontline regions where, which is the fact that there's a restrictions in access to medical care, even though we together with the partners are working so that in those regions also the services would be provided. Separate focus of attention is children. We're all fascinated on the weekends from the unprecedented attack that happened in Kryvyi Rih. Daily, our region suffer from shelling from Russian Federation, in which you can see a lot of children without parents becoming orphans, and this all creates from us takes additional pressure for children to be in the focus of our attention, for children to have access to the modern and leading technology that are present in the country, and pointing your attention to the usage of the phthisis as the primary test for molecular diagnostics for all the children that are coughing for more than 2 weeks on the primary care level that's closer to the patient, which is the much higher level of coverage can be provided because of that, and will be a child-oriented approach. If you're speaking about drug-resistant TB, and then all the region, WHO region, and so, and we want to show and demonstrate the high level of influence, unfortunately, for drug-resistant, until we don't see the tendency for when the drug-resistant tuberculosis is being spread more so in the western parts of Ukraine, so that we would know that this is the matter of time, and from one side, and so that we have a big number of opportunities to control the drug resistance TB as well. Rapid diagnostics, short-term treatments and regimen multidisciplinary approach is also there, and there's many other things that's still there. Together with that, and we do understand in that and on drug resistant and susceptible TB can be worsening, and so we can also see we need to put a lot of effort so that we can continue to control the focus of attention that we're still there. Our focus of attention is still there, still the same. We have to fight TB in Ukraine and combat it fully. And what do we do for that from the side of the government and to get to this public health center with the parliament, Ministry of Health have been worked on the draft law that supported last year. Just a few most important things in this draft law. First of all, this is the Euro integration law. It gives for the multi-sectoral, polysectoral approach to the fighting TB. That what does it mean? This means that not only medics and the scientists, educational experts, parliamentarians, public, everybody has to be joined into the fighting the TB. And also on the level of the law, we have a unique coordinating and role of the regional TB centers. So the government is saying about the protection of TB, and it's important at least for the next 10 years. Also, the legal barriers have been removed by the law, and also not as the last portion, but still this is the highest law on the TB. That an important role is being given to stigma and fighting stigma, and it's used this stigmatizing terminology that means that this is such an important focus in the government to this matter. And also, last year we have approved the operational plan by the Public Health Center for the law together with the Ministry of Health, and that is the vector of where we're moving forward. And so this operational plan our team has done in the accordance with the regional plan of the WHO. Let us remind ourselves that in the last year and the end of last year, we were able to approve together with the Ministry of Health of Ukraine a new strategy for anti-TB service and medical care development. And I would not like for us to continue to forecast like the opinions, thoughts that, oh, the service is being destroyed. Based on which facts are you taking those ideas? Are you taking in the internet or is it your personal opinion? The government in their vision has noted down into the strategy for the TB service development. And also, the main parts of the strategy that's supposed to be fulfilled, they're also in line with the ideas from the WHO. And please point your attention to the fact that those facilities has to be and activities has to be fulfilled both national and regional level, because we are last week we presented the information for the Health Committee and the Ministry of Health. Last year, you can see how fruitfully did we work together with the Ministry of Health so that we can comprehensively go to the revision and improvement of our bylaws and everything else connected with CTB. Only this year, we have an order on the development of multidisciplinary teams, and we are not stopping there. We are continuing to work, and there are specific plans that have been written on the webpage of the Public Health Center. And one of the initial plans that we want to make together with the Ministry of Health and the Institute for Phthisiology and Pulmonology, which is the revision of our acting standards of medical care for TB, taking into account that there are new things are there on the regimens of treatment. And so there's another working group is created, and also this year going to be even more progressive standards. Even the one that's there, this is leading. It's a flagship, and so we are continuing to get the leadership on the international arena. Can you imagine the country at war during the full-scale invasion? We are taking the standard that is still inaccessible in the list of countries of European region even, and would create additional barriers in different kind of access to the more forward leading or treatment for with the short regimen, which the WHO mentioned today. We have a bit better capacity, even though how can we say this when there's rockets hitting every day, but still the access to medication, we have an advantage. New flagship initiative that we are implementing right now together with the regions, which is the responsibility on the level of communities and implementation of communities free from TB. There's also Oblast that is leading so far which is Chmelnytsk Oblast, but we are urging everybody, please advocate, stimulate, include communities, because in this level specifically, we can have effective policies that would form a healthy environment so that every patient to whom it's hard for us to reach sometimes to protect them to with prevention and involve them to treatment would have the access for community to be healthier. If you are to mention about the specifics on the wartime and martial law, which is the work with internally displaced people, and we are urging everybody to improve this line of work because we see that the place of the compact presence, not all of them are covered, and also to include NGO sectors, so our partners specifically there where the medical service do not have the time to cover with the screening. And we see that for that we have many things present, and also the protocols, mobile medical brigades, artificial intelligence, and specific policies and what to do, and the models to process. So the last year have become for us a progressive in the implementation of the whole list of innovations based on which there is progress, because the third pillar of the TB fighting TB, essentially based on WHO data, is just the research and innovation. So if you are to mention about the TB prevention, that yet again urging everybody that prevention has to be the main backbone of our activity. And also we have everything for that, and also the modern approaches and standards, modern diagnostic tests for detection of the latent TB infection. And so we have started to fully implement quantiferon tests. And so we are spreading the tuberculosis testing. And so on the July 4th, we have expected big supply, 50,000 of new skin tests that just recently have became announced and available and approved by the WHO. So even now, in conditions of reduction in the international technical support, a number of challenges, we are continuing to work for those technology to be accessible to you, doctors. And are you ready to scale up the prevention, taking into account the tempo that we do have to need to have? And so there are modern short-term regimens, rifampicin. And so when we can see the reports, what we see there that some of the clinicians are continuing to prescribe other less attractive, less patient-oriented regimens with 6 months isoniazid or based on the rifampicin. So please point your attention to the fact that this medication is developed specifically so that patient will be simpler and easier and better result. Rifampicin, it's more than enough. Therefore, revise your approach for a more effective use of such a resource. And so also we are, even though we have war, we are able to get such high levels of vaccination, but together with that, we can see that not enough attention and role to the novel preventive methods that also my colleagues Georgi Dimov mentioned, which is the people who are treated with the transplantation, tumor necrosis factors treatment, and also we can also see here that even for people who've been in contact with TB patient, you need to improve this line of work. Not less important in conditions of war is to provide the timely detection and screening of TB, because the importance of screening conduct from the people who have a contract with the primary care doctors is the part of the law on combating TB. And so here the big line of work that we have also conducted with our colleagues from the WHO, and the result of which, as Georgi mentioned, in the prioritization of groups for risk. And so we expect for them to be less, but the final decision is being done by the group under the Ministry of Health. In the nearest times, we will get back to the fact this issue. And also what we can see here, that the coverage with TB screening overall in the country, it's 83%, but what we can see here as well, and on IDPs, we need to continue to improve our line of work. So regarding the modern diagnostics, so we have a good experience to the molecular genetic diagnostics. We have XDR cartridges, we have the testing to fertility testing. So there are many things that have been conducted, but together with that, what we can see is that the load to existing system is not enough or not sufficient. So diagnostic using pieces is also being implemented and insufficiently, as also the delivering of sputum is happening not regularly enough. And so we also need to improve that, to analyze barriers that we have and what's not working to improve the patient pathways. so that this would
Ми
be
говорили про те,
in
що є
line
обмеження
or line. So we
доступу до допомоги
spoke
на
about that there
прифронтових
is an
територій. Для цього працює
some
ціла
issues on the
низка
pre-front
мобільних
line
бригад,
areas of
фахівців,
work.
які
There's a line of mobile
координуються
brigades that
і
are acting there,
супроводжуються
that are
з
coordinating and
фінансуванням
support with the
Центру
funding
громадського
from the Bose
здоров'я.
Public Health Center.
Зараз це
And
в
so
тому
right now,
числі
this is
мобільні
also
бригади,
the
які
mobile
працюють на
brigades
базі
that
Центру
have
контролю
been
профілактики,
working under the
і
Center for Disease
гарні є
Control and
такі
Prevention. So
практики,
there is
коли
also good
Центр контролю
practices when
профілактики,
Center for Disease
регіональні
Control and
медичні
Prevention,
служби
regional
об'єднуються
TB
і
services are
мають
getting
гарні
together and
результати.
having
Зокрема,
great
сьогодні
results,
проходять дуже
especially now
багато днів
we have
здоров'я,
many
під
day
час яких
house
також
days
спрямують
during
на
which there's also
туберкульоз в
screening for
рамках
TB that's
Дня
happening
здоров'я.
in
І ми
framework
будемо
of
продовжувати
health
робити
day.
цю роботу.
And so we'll be
Зокрема,
continuing
зараз
to do this
планується
line of work
розширення
because
доступу
now we
до
want to
асистента
add
штучного
additional experts
інтелекту. Ми вже
to
говорили
the
неодноразово
artificial
сьогодні,
intelligence
звучали
system. We
про
mentioned
беззаперечне
that
лідерство
there is a
нашої
line
країни
of
в
leadership of our country
адаптації і впровадженні
in
міжнародних
adaptation and
ініціатив,
implementation
які
of
спрямовані на
international initiatives
покращення
dedicated to the improvement
лікування,
of
його
treatment and
ефективності, і
its
воно стає більш
effectiveness, and it
коротким.
becomes
І
shorter.
власне ми
And
фактично кожен
we
рік
de
інститут і
facto
центр
each
громадського
year, the
здоров'я
Institute and Public Health
представляють
Center are
доповіді на
representing the new
міжнародних
presentation
площадках для
and the
того, щоб
international
ділитися
platforms
своїм
to
досвідом і
share their
бачимо,
own
що дійсно
experience. We
ці
see that
режими покращують
those
ефективність
regimens they
лікування,
improve
але разом з
effectiveness
тим,
of
коли
treatment.
ми
But together with
дивимося
that,
на
when
прикладі
we are
регіонів,
having a
бачимо,
look on the
що є певні
example of the
регіони, в
regions, we
яких
see that there are
лікування
some regions
чутливого
where the treatment of
туберкульозу
susceptible TB
гірше, ніж
is
лікарсько
worse than
стійкого,
the
що,
drug
власне
resistance.
кажучи,
So
підтверджує,
which
що коли з
confirms the
увагою
fact that when
відноситися до
with the
кожного
attention you
пацієнта,
treat each
знаходити
patient,
підходи,
you
сумлінно
can find
виконувати свою
approaches,
роботу, то певно
you fulfill
результати
your line of
кращі. Про
work
це буде сьогодні
with
в
the
презентації
commitment. The results
говорити
are going
моя
to be better.
коліжанка пані
My
Олеся
colleague
Медведєва, яка
Olesa Medvedev will
розпочала
be
в центрі
mentioning,
цю
who is
роботу.
coordinator
І
this line of work from the
якраз
center.
логічно,
And so
послідовно, що саме
logically,
мультидисциплінарний
that was
підхід
the
має бути до кожного
multidisciplinary
пацієнта.
approach
Тут один із кращих
has to
прикладів.
be
Ми
taken for
сьогодні
every
є
patient.
бачимо
This is
в
a great
Донецькій
example that I've
області
seen
і
in the
зверніть увагу
Donetsk
на
Oblast, and
новий
you can
наказ,
also see
який
here
був
about the new order
затверджений
of
в
Ministry of
цьому
Health that have been
році,
approved
і
this year,
щоб дійсно він запрацював
so that
і на
it would
папері
really
на
work not
кожному
just on
нашому
paper, but in
заході.
every center,
Також
every
ми
clinic,
будемо
everywhere.
продовжувати
We are also
вкладати
going to be
інвестиції
continuing to
для
invest
посилення
to
оснащення регіональних
improve
фізіопульмонологічних
the
центрів. Це кошти гранту
equipment
і
level,
інших
which is also
партнерів.
for the
Ми
grant
будемо
funds and other
продовжувати
partners to
працювати,
improve
щоб
the line of work
мати
that they do.
можливості для
We want to
подальшого
work
розвитку
to
навчання
have an
наших
ability
колег.
to
Зокрема,
training and
тільки ми в
additional
минулому
development
році
of our
провели
workforce
більше ніж
capacity. We
50
conducted more
заходів,
than
що
50
проводить і
events, and so
Національний
we are also
тренінговий центр,
National
і
Training
наші
Center has
партнери.
conducting them,
Ми будемо
and our other
продовжувати
partners also
зміцнювати
conducting them. So we
нашу
are
науку, наші
continuing to
пріоритети в сфері
improve our
досліджень.
science
Є
and improve
чіткий
our
перелік,
research
і
in a
якраз ми
specific
зараз плідно
list. And so
працюємо з
we are now
науковцями з
working fruitfully
кафедрами.
together with the
Але
scientists from
разом з
the
тим, якраз
scientific
знаємо, я
departments. But together
згадувала
with that,
сьогодні
as I mentioned
результати
today, the
одного із
results of
досліджень,
one
яке ми
of the
завершили в
research that
минулому
we
році,
have just
і
finished
яке
last year.
наглядно говорить про те, що
And that
так
gives an
дійсно на
example that
сьогоднішній день
yes,
медики з
as of
точки
today,
зору свого
medics, from the point
психічного
of view,
здоров'я,
their mental
ментального
health
здоров'я
and their
в
mental
дещо
status
гіршій ситуації, ніж
are
навіть
in
наші
worse
пацієнти. Тому
situation
ще
than
раз
even our patients
закликаємо
is at. So yet
увагу до
again,
того,
we're
що
urging you
зверніть
to
на
the
себе
situation that
увагу,
please
знайдіть щось,
put
що вас
attention to you,
мотивує.
find something
Якщо
that
треба,
motivates you. If need be,
відпочити,
take some rest, and
знайти ці ваші
you
точки
need to
опори, які
find those
допомагають
your
вам
points of
відчувати себе в
contact that
ресурсі
allows you
і
to
балансі, тому
stay
що
resource
тут тільки
filled and
дуже
balanced
маленька
as well, because
частинка
only a small
наших колег в
portion
різних
of our
регіонах, які
colleagues in
дійсно є
different
на
regions that
сьогоднішній день
really are
найціннішими надбаннями і
the
ресурсами
biggest
нашої
asset and the
країни.
biggest resource of
Плани
our country.
подальші
The
національної
plans for
програми
the future
це
program for the
впровадження
country,
тих
which is
підсумуючих
the
стратегій, які ми
implementation of
говорили,
existing strategies that we
залучення
just
більш активних
mentioned, and so
громад,
including more
дорожня
active
карта
inclusion of the
по
community,
дітям і адаптації,
roadmap on children
впровадження,
and adaptation
нові
on children,
стандарти,
so the new
зміцнення
standards, improvement of the
національно-нормативної бази,
national legal
розширення
base, and so
масштабування
that the
доступу до
scaling up
профілактичного
the access
лікування,
to preventive
робота
treatment
над
and the line
покращенням
of work on the
скринінгу,
improvement of the screening,
впровадження послуг
implementation of the
медико-соціального
services of
супроводу,
medical
щоб були
social
кращі
support so that
результати
they would be better results
лікування.
present in from the treatment,
І разом з новою дорожньою картою
together with the new
вдосконалення
roadmap
послуг
of the improvement
медико-соціального
of medical
супроводу,
social services,
продовження
support the information campaign because the anti-TB month was finished, but the issue unfortunately is still there. And also we are reporting so that please read on our pages everything that we do, because all those data is public and it's in open access. And so more information about that you can get to know if you would want to. And also that we have an unprecedented level of support, and so we have significant number of success stories that we are proud of as our team work together with our international, regional, and international partners. And so I wish you all to have victory and great health. Thank you.
Дуже дякую, пані Яна.
Well, thank you so much, Yana.
Подивившись і
And also by
прослухавши вашу
looking at and by
доповідь,
listening to your
виникає
presentation,
ну,
we start to have such a joyful mood till the day of health, World Health Day, and this is just as you put it. We are also thought that our country, it's always been a flagship in our specialty, but for some reason it so that happened that historically that everybody thought that TB, well, this is just like a disease, never be treated, and so Ukraine is just as always an outsider somewhere somehow. But up until we are not gonna treat ourselves, and until we will be bringing our achievements to the public, maybe nobody in the world will be respecting us until we learn how to respect ourselves. And so your presentation demonstrates really the key moments where you could be proud of. You can position them as a success story, you can present them, and to spread them even more. And we have a few comments and one question. And one of the question is quantiferon test. Just a second. Do you plan this year to have an access to free testing of latent TB infection using quantiferon test?
Дякую за запитання. Дійсно
Thank you
важливо
so much for the question.
встановлювати
It's really
зараз
important, specifically when we are now detecting about
профілактики.
dividing the
Перш за
scale
все,
of prevention.
все-таки
First of
ще
all,
раз чітко для
let's
всіх,
yet
що
again, specifically for
про
everybody,
манту також
that
ніхто
the
не відміняв, і вона також залишається
tuberculin
дієвим методом
test,
для
it's not
діагностики
going away.
виявлення
It's an active
латентної
method for the
туберкульозної
latent TB
інфекції.
infection.
Квантиферонові тести
Quantiferon
залишаються
testing,
більш
they're still
дороговартісним
more
тестом,
expensive
і
test,
також
and
тим тестом,
also
який також має як
the test
переваги,
that
так і
has both
недоліки. Принаймні
advantages
те,
and
що необхідно
disadvantages.
брати кров, її
You need to take
транспортувати,
blood, you need
це
to
також
transport
створює
blood.
певні
This
додаткові
is
складнощі.
creating
Тому коли ми
additional
говоримо про
complexities. So when we
виявлення
are
латентної
speaking about
туберкульозної
the
інфекції,
detection of
все-таки
latent TB
треба
infection,
зважати на
you need
всі
to
методи і
think about
обирати
all the
з
methods and
урахуванням
to
того, який
select the
краще до
one
якої
that's the
категорії,
best
тому
one
що
to which
і
category of people,
запровадження на
because with the
національному рівні
implementation on the
в
national level
усіх центрах контролю
in all
профілактики
centers for disease control and
врахує,
prevention,
що
what we saw,
певної такої диференціації
there's a small
епідеміологічної до
differentiation
кінця
that we would
немає,
like
і
to see.
іноді
It's not
використовують
there, and
квантиферонові
sometimes you
тести
use
там, де
quantiferon tests
прекрасно
there where
справилась би
the
проба манту. Але
regular
разом з тим,
tuberculin
ще раз
test would be
підкреслюю
going
наші
well.
чіткі
But
наміри
yet,
в тому,
together with
щоб
that, our
більш сучасні передові
goal for the
тести
more
для
leading
виявлення туберкульозної
test
інфекції
for the detection of
були
TB
доступні в
infection
нашій
would be
країні.
accessible
Ще
in
раз
our country.
підкреслюю,
First
що
of all, I'd
в
just like
липні
to
ми
highlight that in
чекаємо
July we
більш
are waiting for
продвинуту,
more than
скажімо так,
more
версію
advanced
проби
version
манту, нова генерація
of
шкільного тесту
tuberculin test. So the
50
new
тисяч в
skin test,
липні. Чекайте,
50,000
готуйтеся вже зараз до
tests in
розширення.
July.
А другі
Prepare for
квантиферонові тести
this, and the
також
second one, quantiferon
будуть
test as
більш
well,
масштабовано доступні.
more scaled up.
Принаймні зараз вже половина регіонів
And so
отримали
half of the
квантиферонові
region
тести,
received
решта
quantiferon
буквально
test, and
протягом
so the other
тижня
part
мають
in a
доотримати
week
ту партію. Але
have to
ще раз,
receive them.
використовуючи їх,
By
необхідно зважати
using
на користь,
them, you
ризик
need to
дороговизну
understand like
і
how
доступність.
expensive it is,
Тому
so the
за про це,
benefits and
до
all that.
речі,
Together with
16
that,
числа
on
буде
the
вебінар Центру
16th of
громадського
April, they're going to be a
здоров'я
webinar of Public
з
Health
балами
Center
БПР. Кому
with
цікаво
the continuous
більш
professional
детально
education
почути
point. So who's
інформацію про
interested
всі
to hear
нюанси,
more
особливості
information about all those
використання,
things,
кому
specifics of
краще,
use, whom
будь
better to
ласка,
use it,
будемо раді чути там від вас
we'll be
також
more than happy
питання.
to hear questions from you on
Дуже
that webinar.
дякую,
Thank you
Яна.
so
І
much,
є
Yana.
ще
There's
одне
also another
питання
one,
від
another question
лікаря загальної практики.
from the family
Воно
doctor.
перекликається з попереднім
It's
запитанням.
goes
Чи
well with the
змінена
previous
масова
question. Did
туберкульозна-діагностика
we
дітям,
cancel the
якщо так, то яким
the
наказом?
regular TB testing for children? And if
Шановні
so, if
колеги,
canceled, in
основний
which
наказ,
order?
яким
The main
регламентовано
order with
підходи
which
до
regimens the approach
профілактики,
is to
виявлення,
prevention,
діагностики і
detection,
лікування,
diagnostics, and
є
treatment
стандарт
is the
медичний
standard of
прotокол, який
medical care
затверджений
that is
102
approved by the
наказом.
order number
Власне кажучи,
102.
масова туберкульозна
So the
діагностика
massive TB
в минулому і
diagnostics, and
позаминулих
I think
10
that
як
for last 10
відмінена.
years have
І
been
разом з
canceled,
вами
I
зараз
guess,
представник
together
Всесвітньої
with us, there's
організації
representative of
охорони здоров'я,
WHO
який також вкотре
that
підкреслив і
also
наголосив
and
на
again
необхідності
said that
впровадження саме
we need to
доказових
implement
підходів. І,
evidence-based
на жаль,
approaches.
туберкульинові
And
проби
unfortunately,
залишилися в минулому, так як вони не
tuberculin skin
показали
test is in the
своєї
past because they did not
ефективності,
show
і
their
на сьогоднішній
effectiveness
день
and
рекомендовані застосування і
recommended to be
квантиферонових тестів,
used
і
also the
когорту,
quantiferon
і
test
нової
and the
генерації
tuberculin
швидких
test, the
тестів
new generation
саме
skin
серед
test,
визначених дуже
because of the
конкретних, дуже
detected
специфічних
specific
груп підвищеного
group of
ризику,
higher
які
risk
є в стандарті. Будь
that are
ласка,
in the standards. So
подивіться. Все
please
там
read
є.
the standards. It's all there.
Дуже дякую,
Thank
пані
you so
Яно. І в
much,
нас тут
Yana.
є один
And we also
коментар.
have here another
Це, я
comment.
так розумію, коментар більше від
As I understand,
скептиків.
there's most of comment from the
І
skeptics,
я так думаю, ми не можемо
and I
їх не
think we can't
озвучувати
really
для
not
того,
voice
щоб
them, so that
сказати якісь
to
такі
tell like
меседжі для того, щоб
what are the
все-таки людей
messages, so that
переконати
people can
в
be
тому, що в
persuaded
нас в
that
країні все ж
in the
таки все
country
добре, і
everything's
інновації
good and
існують.
the innovations are existing,
Ось
and
є такий коментар.
there is a comment, the
Короткострокові схеми
short-term
лікарні працюють,
regimens are
але
great and
більше
they're
позитивних
working, but
інновацій немає.
there's no
Що можна
other
сказати
positive
на такий
innovations. What can
коментар?
you mention to such a comment? What can you tell
Напевне, це
them?
те, що
I
говорила
guess
Наталя, і те, що ми
this was what
також говорили
Natalia had mentioned and
неодноразово.
what we had
Дуже
mentioned for
важливо
many
не
times. It's really
знецінювати ту
important not to
роботу, яка
devalue
проводиться. І,
the
власне
line of work
кажучи,
that's being
про
conducted. And
цілу
so,
низку інновацій, які
about the
доступні
list
в
of
нашій країні,
innovations that are
було
present in
дуже
our
чітко
country,
продемонстровано
it's been
лише
demonstrated
частину цих інновацій,
about
була
only about the part of
продемонстрована
this innovation
на
that have been
слайдах, які
demonstrated on the
були в доповіді.
slides
Кому
that
цікаво,
have been in
прошу
the presentation.
почитати,
So,
будь
who's
ласка,
interested in
звертайтеся
learning
до
more,
сторінок
please
центру, слідкуйте за
reach out to
новинами
the pages
наших
of the
партнерів,
center. Look
тому
for
що на
the updates
сьогоднішній
from our
день
partners because as of
насправді
today,
інновації, от
in
навіть
reality,
тому,
the
що сьогодні до
innovations by getting there,
конференції і
preparing to
підводячи
the
такий певний
conference, and by
проміжний
getting such
підсумок
a
того, що
small
стало
summary
доступним лише за
what
останні кілька
started to
років,
be
і це
accessible
вже в
only in the
умовах
past few
повномасштабної
years
війни,
and in
це
the during
відбувалося
the
за
Fosco
всіма
invasion, that it
напрямками,
happened throughout all
починаючи
the
від
areas of work,
профілактики, ті ж
starting with the
квантиферонові
prevention.
тести, які
The
буквально
same
2 роки
quantiferon
назад були
test that two
доступні
years
тільки на
ago have
базі
been
приватних
accessible only in
лабораторій.
private labs.
Це ті ж нові шкірні тести, знову таки
New skin
профілактика,
tests as well
які
for prevention
щойно я озвучила,
purposes that
будуть
I've just
доступні в
mentioned
липні,
that
адже
will
вони
be
вже
accessible in
замовлені, вони
July
вже
because they have
ідуть
already been
на виробництво.
procured and they already
Це
being
і короткі
manufactured. And this is also
профілактичні
the
схеми
short
лікування.
term
Можливо, для
treatment,
когось це
short
дійсно не
regimens. For
інновація
somebody,
і не
maybe this is
прорив,
not
але
an
для інших
innovation
це
and not
було
a breakthrough
отримати
when before you
профілактику
need to
6
take
місяців із
the
заняттям, а
prevention
зараз
for
можна
6 months
отримати
of visit, and then
профілактику
you can take
за
this
1
preventive service for
місяць.
1 month
Можливо, дійсно
only.
для когось це не
Maybe for
інновація, але
somebody
коли
this is
йдемо
not an
про
innovation,
обов'язки,
but
про
when I'm speaking
пацієнтів,
about
про
the close
людей,
ones, the
і для мене
patient
здається,
people,
що це все-таки дійсно
for me, I
очевидний
think that
прорив.
this is an
Як, власне
obvious
кажучи, і по
breakthrough
лікуванню. Якщо раніше
just as
фактично
in treatment.
тільки
Because if
медик
before
займався пацієнтом, то
only
на
a doctor dealt
сьогоднішній
with the
день
patient, then as
і
for
держава
today,
в тому числі
even the
виступає гарантом
government as well
соціальної
as the
підтримки,
guarantor
і
of the social
фактично вже
support
2 роки, нехай не в
for
повному
two
обсязі,
years, even
але
though not
на
fully,
10% вже
but at
хоча б
least
покладена
10%, they
основа, закуповується
started to
послуги
have the
медико-соціального
procurement of
супроводу
medical social
за
support
кошти державного
services for the
бюджету.
funds of the global budget.
Якщо я починала
And if,
працювати
since we've
і
started to
ми
work
тижнями,
and
місяцями
for
чекали
weeks and months and
результати
we waited for results
діагностики, то на
for the
сьогоднішній день
diagnostics, and so even though
XDR картриджі,
the
які, до речі,
XDR
також почали
cartridges that also
повномасштабне
have been
впровадження в перший місяць війни. І я особисто це дуже добре пам'ятаю, як це було, коли війна, коли немає логістичних шляхів, коли заклади під постійними бомбардуваннями, а ми впроваджуємо XDR картриджі, які до
access.
сих
So when
пір
you're doing the
недоступні в
XDR cartridges,
масштабах
they're still not
багатьох інших
accessible
країн.
in
Тому
the many other countries.
це добре,
Therefore,
але тоді, коли він
being
не
skeptical is
знецінює
good, but
роботу
when it's
цілої
not
команди,
devaluing the
які
line of
дійсно
work that
бачать
we do
цей
for the whole
результат.
line of
Тому, власне,
teams that
відповідь на
see this
запитання.
result.
Дуже
And so this is
дякую.
our
Я
answer.
вважаю,
Thank you
що
so much. And I think
важливо
that
саме на таких
it's important to
заходах,
have
як
such a
конференції, говорити
events as
і
a conferences and
дискутувати,
everything else to
відповідати
discuss and
нашим
to be
слухачам,
responding to
якщо
our
в них є
people who
якісь
listen to us, that if they have a
питання і, можливо,
question and maybe
переконати тих
to
людей,
make
які
sure to persuade
вважають
the people who
приблизно
think
так само, і тому
that
що
they have
дійсно
of the
та
same thing,
величезна
because
робота, яка
really
проводиться в
this line of
Україні,
work that's being done
вона
in Ukraine,
повинна мати
it
адекватне
has
і
to have
правильне і
the adequate and
освітлення, і
correct
відношення до
both,
нього
the
з
how
боку
it's being treated
медицинстів,
from
з
the
боку
clinicians
лікарів,
and from
ну і взагалі з
doctors
боку
and
громадськості.
overall from the communities as well, at all. Skeptics are always going to be there, and somebody's going to be criticized all the time. And so we need to focus on the fact to support those people who are really working, functioning, trying their best. So it's supposed to work in the terms of full-scale invasion, just in the emergency conditions. What is the emergency? Which is when you have to provide for the access to get the diagnostics and to get the treatment. Our country went in a different way. Our country, in terms of full-scale invasion, is speaking about the real innovation that's been implemented. And so with that innovation, not only slides are there, but also in that innovation, there are specific clinicians, practitioners, social workers, scientists that are using them, implementing them, what's new there, and are using this outside of the emergency focus. Therefore, my focus on the support of people who are really working in the field, near the front lines, and on and on. Thank you so much, Yana. And so we will be continuing to do our line of work, and our conference is just taking more volume, and every presentation is interesting. And then we will be moving to an interesting and important topics on the education of the doctors. How does, where and how the quality medical education can be received, how all that officially is supposed to be assessed, what kind of requirements are those requirements that been before that, are they in line and in line with the like testing and certification doctors, what kind of changes are expecting for doctors, medical workers, and to what extent those changes that are expecting for the future would be useful to our medical community. And also for that, I would just like to pass the floor for the presentation to Yurchenko Alexander, who is Deputy Director General of Public Health Center of Ministry of Health of Ukraine. And his presentation on the main strategic area and future in the post-grad education of medical workers, updates of continuous professional education and challenges. Alexander, please, the floor is yours. Greetings to you, dear colleagues. So happy to be here on this conference, and it's such an interesting presentation that have been presented so far, and I'm hopeful that the next information would also be interesting for our listeners and viewers. So what do we like to discuss here about the updates in laws and bylaws on the continuous professional education of doctors? What do we have as of now, and what are we expecting to have in the nearest future? So a few things that can be discussed about the ideas of the continuous professional education that we have in the country, and the one of the main documents is a decree of cabinet ministers of Ukraine of 2021 of 705, and as you all know, on the approval on the continuous professional education of the healthcare. And also they are deciding upon what is the continuous professional education, which is a continuous process for training and improvement of the professional competencies in the workers of the healthcare that allows them to support or improve their level of professional activity that they do according to the needs of the healthcare system. To whom do those decree are acting upon? For the leadership, or for the professionals, experts, and workers with the either higher medical or pharmaceutical education, and also labor unions and other parts. It can also act in within the healthcare system. So everybody who is in the part of the qualifications and who of the healthcare system. And also, do beg your pardon, just a second, we don't see your slides for some reason. You have to stop sharing and open the presentation, not just the screen, because you've given the wrong window of access. Just a second.
Just a second. Well, while Alexander is sharing his screen, dear colleagues, I'd like to urge you to take an active part. Now you have a unique opportunity to ask your questions in the chat to our speakers directly. Can you say it now?
Там повинен бути ваш перший слайд.
There should be your first slide, I guess.
Спробуйте ще раз, пане Олександр.
Can you try again, Alexander?
Да, дивіться, коли демонструєте, вибираєте демонстрацію, там повинен бути ваш перший слайд на
Yes.
весь екран. Виберіть, будь ласка, його і поділіться ним.
When you select share in the screen, there should be a first slide, full screen slide. Select it, please. Just a second.
Так, все в процесі.
It used to work before.
Колеги, пробачаємося за невеличку технічну
Colleagues, sorry for some
зупинку.
technical
І
issues.
поки вона триває, хочу вас
And
закликати
meanwhile,
задавати активно запитання в
I'd like
чаті,
again to
не
ask
тільки
you,
тому
please
спікеру, який на
ask your
даний
questions in the
момент
chat, not
проводить
only to the
презентацію,
current
а
speaker,
якщо ви
but also
згадали
if you
якісь питання до
recalled some
попередніх
questions
наших
to the
спікерів,
previous
будь ласка,
speakers,
пишіть в
please
чат.
feel
Ми
free to
всі
write them down
запитання
in the chat.
фіксуємо. І якщо ви не
We
встигли
note
задати
all
своє
the questions,
питання
and if you
під
didn't
час
manage to ask your
самої
question during
презентації
the
після її
presentation,
завершення, ви
um,
обов'язково
you
отримаєте всі
will
відповіді
have
письмово
all the answers in
в
writing
розсилці по електронній пошті разом із
in our mailing
сертифікатами
list, together
щодо
with the
участі в
certificates,
конференції.
participation certificates.
Зараз слайд є у вас.
Can you see
Дивіться,
this
ми бачимо
slide?
Well,
Well,
ваші всі слайди зліва. У вас
we
слайди розвернуті на
see
весь екран, а ми
all the
бачимо ваші
slides.
слайди.
It's your presentation is not in the
Прошу,
presenter's mode.
продовжуйте
If you
презентацію,
could
вибираючи
press
слайди зліва.
escape and then continue by
Можете
selecting
змінити
the
слайд.
slides in the left. Can you change the slide?
Що ми бачимо? О, чудово.
Now is great.
Шановні колеги, продовжуємо нашу
Dear
роботу.
colleagues,
Пане
let's
Олександре.
continue our work. Alexander, over to you.
Так, і
Yes.
ми вже
So,
трошки сказали про
we already mentioned
постанову 725.
the resolution 725 and who is subjected to this resolution. This resolution regulates continuous professional development of healthcare and is related to the managers, health professionals, experts, as well as those who are not working in healthcare facilities. These are the people with pre-graduate or postgraduate education. And what is important to underline in this document is that all professionals, all specialists who received their graduation certificates or diplomas, they become committed to perform continuous professional development activities in terms of pre or postgraduate education during the whole period of their professional life. What kinds of education, continuous education, can we single out? They are formal education, non-formal education, and informal education. Based on the results of CPD, healthcare workers, as a result of such kinds of education, can receive CPD scores or points, and these are the units of measurement of acquired theoretical knowledge as well as practical skills acquired during continuous professional development. CPD scores, CPD points, are included in educational portfolios, which combine all the professional achievements, professional upgrade, formal, non-formal, and informal education in healthcare as a part of continuous professional development. Now, just a few words about the types of education we've just mentioned. What is formal education? This is a higher education at the educational and scientific level of education, which means this is acquisition of a scientific degree, Doctor of Philosophy or Doctor of Science. Another interesting type is informal education. This is a self-organized acquisition of professional competencies in the course of professional, societal, or other activities. This includes writing and publication of papers, articles. Also, these are the activities for um, continuous and systematic review of the issues related to their own professional activity. In this case, when we're speaking about critical review of such professional issues, this is about horizontal level in healthcare facilities and in the facilities which provide care and have the respective permits. Non-formal education is more familiar to us. It includes topical improvement cycles, specialization cycles, professional medical internship outside the healthcare facility, and training at the continuous professional development activities. And what are these activities? They are electronic training course, masterclass, simulation trainings, seminars, topical school, scientific and practical conference, where we are right now. And we need to understand the difference between these events. For instance, training is an event to for acquisition of new professional knowledge and skills. It has a limited number of participants, up to 20 people, according to the current legislation. Seminar or workshop is about acquisition of new knowledge without skills. And also it is limited by 20 participants in one group, which is clear. And it makes sense in terms of correct and professional provision of information, and also this helps to carry out discussions within the groups. In the professional topical schools, this notion is a bit wider, and there are several groups which can be identified. The big groups in theoretical part and smaller groups, 10 to 12 participants, in practical events. Continuous professional development system. What is it needed for, and how is it represented now? You can see there is the testing center as a part of the Ministry of Health of Ukraine. Why does it exist, and what is its role and the goal in ensuring CPD? First of all, this is a registration of all legal entities, all the providers which organize the events in continuous professional development. All project participants, like international technical assistance projects, partners, stakeholders, beneficiaries, recipients. So this is the tool which gives us understanding of who can be a CPD provider, and that this provider can officially award the scores, the CPD scores, to our healthcare workers, to those who work in healthcare. What else can be provided by this tool? This is the list of the CPD facilities or CPD events which happened or which are planned in the current period, and where our specialists can apply for participation. Also, this resource publishes CPD scores and creates an opportunity for the personal educational portfolio of a healthcare worker. The information contained in this tool is fully protected and secured, and also it is in line with the legislation on the protection of personal information in electronic information communication systems. How do we score CPD points? This is the order 446, dated 2019, with all the amendments and changes. And what is considered when scoring the points? This is, first of all, the event which is carried out by the provider and which is included in the system we have just discussed. Also, people who have no conflict of interests should be involved in the event. The providers which carry out CPD events ensure the examination, the check in terms of conflict of interest of the participants. The event should be correspondent to the declared goal of the training. The content of the learning materials should be based on evidence and contain the respective references. During the event, the provider should ensure the control over the participation of healthcare workers, also as well as the assessment of the knowledge, competencies, and practical skills acquired during the event by the participants. So it means that there is the whole range of the requirements based on which the CPD score, CPD points are scored and can be used by a listener, by participants, to include them in the educational portfolio, so that in the future he or she could prove participation in CPD. The same order 446 highlights that the types of physicians certification can be the following: certification or attestation for qualification category and certification to confirm a qualification category, meaning that a healthcare worker, a doctor who works in this system and is subject to this certification should acquire minimum 50 points per year. It means that 250 points in 5 years, which then are included in a personal educational portfolio. Score accounting is performed at the job place by the certification committee. We know that since the beginning of the full-scale invasion, the certification was suspended. So there was the order 1415, and in 2023 some amendments were made there too, and now it's called Order 1555, which suspended certification during the martial law period. Certification of the providers was extended, and 60 days after cancellation of the martial law in Ukraine, the certification will resume. So it means that currently the situation is the following. Our doctors and healthcare workers shall undergo continuous professional development and meet the requirements, but the process of certification has been suspended so far. And as soon as the martial law is cancelled, the certification or attestation process will be resumed, and the healthcare worker will have to apply for the required amount of points which he has accumulated over the past years. And now just a few words about some innovations stipulated by the draft order of the Minister of Health, which actually was placed at the website for public discussion. And now the public discussion is over. But this draft order can be found at the ministry's website. This is the draft law on approval of the procedure for certification or attestation of the healthcare workers. What's interesting about this order or this draft? This draft order will cancel, when it becomes effective, it will cancel the following orders. Number 73 on the provisions for examinations at the pre-attestation cycles. Order 818 on improvement of attestation of providers and pharmacists. Number 748 on attestation of junior specialists with medical education, and number 588 on attestation of professionals with higher non-medical education working in healthcare, and number 446 some issues of continuous professional development of healthcare workers. So it means that this order stipulates introduction of a unified procedure for attestation instead of existing 5 procedures. There will be one procedure for doctors, pharmacists, nurses, and other healthcare workers like rehabilitation experts and specialists with non-medical education. So, and this will approve the unified nomenclature of specialties. The draft law identifies the professional qualification and specialty with consideration of the healthcare features. And there will be the one certificate which will confirm professional qualification or competency of healthcare workers. What are the other innovations in this draft order? The first one is attestation or certification at the place of work once in 5 years. Our healthcare facilities now carry out attestation twice a year in April and October for those whose certificate has expired. Previously, healthcare facilities certified the nursing staff. Now it will be related to the whole staff, which works in a healthcare facility. And such attestation will be carried out in the facility. So a healthcare worker will not have to apply for attestation. It will be automatic, meaning that if a person in between attestations has collected all the required documents and participated in the required number of CPD events and received the respective documents, which are correspondent to the requirements. So this attestation or certification will take place automatically at the place of work of this person. The additional documents will be required only for people who would like to have the next level of professional or competency. The procedure also foresees the out-of-turn attestation by the committee, which is created according to the order of the manager. And such cases will be included in the draft procedure. So this procedure allows attestation at the place of work, and healthcare workers of educational facilities, trade unions, and non-governmental organizations which work in healthcare domain. It is suggested they will be certified or accredited in other healthcare entities, which are appointed for this purpose, like regional or central attestation committees will not exist anymore. Attestations will be carried out to confirm the level of professional competency or to ensure the next level of professional competency. Also, this implies the work experience not less than 3 years during 5 years attestation period and minimal number of CPD points. So this will be the requirement for healthcare workers. For doctors and other professionals, there should be 50 points of CPD per year. For nurses and other specialists, 30 points per year. To confirm professional competency, one should demonstrate at least 250 points for professional and 150 points for other specialists in 5 years. So here, this provision has not been changed, but we need to pay attention to this. Also, if you remember at the previous slide, I made a note that this should be according to professional standards. The mandatory CPD areas are determined by the provision and include ethical issues, communication skills, healthcare standards, digital competencies, emergency care, and infection control. We hope that this draft order will be approved soon, and we will be able to start certification or attestation using this new procedure, which is more up to date, closer to life, and does not require any extra actions for our professionals to be able to confirm their competencies. Thank you for your attention. If you have any questions, please feel free to ask them. Alexander, thank you very much for very up-to-date, very relevant and important for doctors, for healthcare workers information. Yes, there are a few questions in the chat, and I will read them.
Чи потребують сертифікати від Центру громадського здоров'я реєстрації та оприлюднення на сайті
Do
Центру
the
тестування?
UPHC certificates require registration and publishing on the testing center? Because in 2024, they were not included in the list. Thank you for your question. No, the certificates awarded through the UPHC platform do not require publication at the test center of testing website. We publish them, and this is enough to make them legitimate because the UPHC, Ukrainian Public Health Center, is identified as the CPD provider. Thank you. And next question, Alexander. Is it enough to get 50 points, CPD points every year online, or offline events are also needed? Thank you. That's an interesting question. Well, basically, the legislation and sub-legislative acts do not restrict the right of the professionals in terms of collecting the points. But from the practical point of view, I can say, and from my teaching experience, I can say that online events may be not sufficient for sharing and providing the required information, especially if this is related to practical skills. If it is related to the competencies which a professional should do in real life. So in that case, such events, well, let's say the regulation of the events, such as seminar. Yes, the seminars can be online. They can be online conferences, but if the competency is related to master classes or some practical skills acquisition, then this should be done offline. Thank you. And the next question is about acquiring higher category. If one has acquired category 1, is it possible in a year to apply for a higher category if one has 15 years of work experience and 250 CPD points over the past year? Yes, yes, it can be done because this is the kind of an emergency application, and in this case, in the previous version of the order, the decision should be made by the attestation committee. According to the new one, The decision will be made at the workplace. And the question about if there should be attestation committee or not, this will be based on the requirements stipulated by the draft order. Thank you.
Пане Олександре, то я вас перервала.
So, yes, Alexander.
Добре. Дуже, до речі, це важливе питання, тому що
Okay, so this is really important issue because
прикладних роз'яснень в цьому
there are no
проєкті наказу
practical
немає,
explanations in this draft order. Thank you very much for your comments.
Коментар, про який
There is a similar
не написано в наказі.
comment which
Тут багато
is not
написано,
mentioned
я
in the order.
швиденько
I
своїми
will just
словами
summarize the
запитаю,
question.
чи буде впливати категорія на заробітну плату?
If the category will impact the level of the salary.
Це окремі зовсім питання. На сьогодні категорія
Those are completely different questions. So this,
заробітну плату,
the categories
і
of
це
which
не
rank
питання
are you as a
саме
doctor are supposed to influence, but this is
атестації,
not
це
the testing or
інша
certification kind of point.
нормативна
This is a different
документація.
legal
Вона
documents that's supposed to
в
be
неї
there.
зміни не вносяться, і
We did
вона
not see any
буде
changes
чинною
there,
з
and so
вами,
it's
як
going
ми
to be
сьогодні
acting and
працюємо.
work as it's working today. So no changes there.
Добре,
Thank
дякую.
you. Thank you so much.
І ось питання з приводу цих обов'язкових
There's also a question
напрямків,
about those mandatory
які
ways
ви
of learning
перелічили, які обов'язково за 5
that you
років
listed.
пройти. І
And
учасниця питає, з цих
and the
нових
participants
обов'язкових
asking from
напрямків
those
ВПР, їх
new areas of
потрібно
work,
пройти всі за
do you
5
have to
років,
went all
і
of them
яку
in 5 years,
кількість
and what
балів у
amount of
цих
points
обов'язкових напрямків
in those
повинні бути
mandatory
в
ways of
портфоліо?
moving forward is supposed to have in portfolio?
Скажімо, не всі обов'язкові
Not all of
пройти
the mandatory is
повинні.
supposed to be
Весь
passed.
перелік заходів
Not the whole
потрібно
list of
пройти.
activities supposed to be
Якщо ми
passed. And
говоримо
so,
про
if you are to mention
такі заходи
about the
безперервного
activities of
професійного
continuous
розвитку, як
professional
автоматичне
education,
удосконалення, то
as
на
the
сьогодні виділяється два
then as
терміни
of today we
автоматичного
have two
удосконалення.
different
Це недільний і
definition, which is the
двохнедільний термін по
week and
колишньому
2 week
удосконаленню. Недільний термін – це
courses. So
25
1
балів
week, which is 25
ППР,
point gives, and 2 week gives 50 points.
двохтижневий термін – це 50 балів ППР. Тобто це що стосується саме тематичного удосконалення.
This is what's concerning the improvement or those courses that you mentioned. Regarding the other types, and it's in different way, like the conference
в якої ми сьогодні беремо участь, якщо
that
не
we are
помиляюсь,
participating in
відбувається.
this today. If
Скільки
you
балів?
said how much points are there?
5
So far,
балів,
it's
так.
5. Okay.
Тобто, от із цього складається
Then
портфоліо.
out of that, the portfolio is being made.
Ну тут мова йде, скоріш за все, про ті нові напрямки.
I think that the point is about new area of work, like mental health or care,
інфекційний контроль і так далі.
IPC, and others. So those new mandatory areas of work, like how much they're supposed to be, like what percentage they're supposed to be in overall
Не можу це
points.
прокоментувати, на
Can't
жаль,
really
і
comment on that, unfortunately.
дякую за
So,
запитання.
but thank
Я
you so much for the
його
question, and I will
візьму для вивчення
bring this up
і
for
трошки
study,
пізніше зможу вже надати коментар з цього.
and a bit later I will be able to do that.
Добре, дякую. Дуже цікаве питання, до речі.
And an interesting topic if the doctors have a few specialties and you need to get points in every specialty. Do you need to take 50 points on every specialty for a year?
Якщо говорити по кожній спеціальності, є
If you speak specialty by specialty,
заходи БПР об'єднуючі, які
by merging together,
можуть бути дотичні до
they might be connected to a few specialties together, but there's also specific parts of continuous professional education that cannot be attributed to different specialties. So this is specifically for one specialty, like for a family doctor, and they have a certificate that gives them the right to conduct like an ultrasound diagnostics, and he has like a certificate of a cardiologist, then of course he needs knowledge on cardiology and ultrasound diagnostics and on and of general practice for family medicine. So this is not, you can't using one specialty to cover everything that you need to have. There's another question like on TB and pulmonology, and those are separate specialties so far, but what if case this joint events like our conference that's both for physician TB doctors, and then it's being counted into both parts. Okay, the certificate can be taken in. And then good. Thank you so much for the explanation. It's been interesting for us. And also the how many points you need to take for the improvement of as we mentioned before, if this is the there are questions of the testing because somebody wants to do that to move to a higher level, or the worker that when they prescribe additional testing because of any kind of changes or ambitions. So on the additional testing that goes based on the wish of the patient or the expert, he needs to provide the same amount of points for continuous professional education as for 5 years. So if it's in a year, then 250 points still. Great. And then the last question that we just recently have, how frequently can you go through those courses of professional education during the 5 years? Like, is there a limit of how much you can pass? Like, how many you want, really? So there's different names, right? If you are to mention honestly, then the government can provide one time a year for free. Other things, for your own funds, you can go there even every month. Thank you so much, dear Alexander, for your wonderful presentation. That was so important, and for your answers to questions. If there are going to be any answers additionally provided, we will send it to the people who answered, and if there are any questions, we will send it to you, and then you can provide it in written way. Colleagues, don't worry if you remember there's like a question and we started to listen to a next lecture. This is not an issue. Just wrote down any questions that you remember to any topic. We will present it and we will send it to you after we will process the question, and together with the certificates, you will receive the file with the answers. And so yet again, thank you so much, dear Alexander. And we are moving to the next presentation, which is not, it's not even less interesting, it's more interesting, it might be. I think the changes that are waiting for us, that Alexander mentioned, that's not the last one. We have to move to the European level of education, and so it's what's interesting is to listen to the presentation of our dearest international partner and friend from Riha, international trainers from the WHO, how things are happening from medical experts, medical employees in the country of European Union, on the example of Latvia, Latvia Training Center, and we are welcoming to the floor the head of Riga International Trainer Centers of WHO, Riga Kuksha, to presentation. Liga, the floor is yours.
Dear colleague, it is a pleasure to be here with you, even it is recorded presentation. I'm happy for this invitation and being again in such a very important conference. My task today is to talk about the international education of doctors, an example of the International Training Center of Latvia. So, and just a bit of the context of our presentation in Latvia, the you may see that Latvia is a very, very small country in northern Eastern Europe with a long coastline of the Baltic Sea. We have a border of the Estonia and Lithuania, and also Belarus and Russia. We have a very tight linguistic links with Lithuania and historical and religious ties with Estonia and northern part of Latvia. Since 2004, Latvia is the member of European Union. In the beginning of 90s, we had a very severe situation with tuberculosis in Latvia after the getting independence in 1991. And the highest point in Latvia was in 1998 with 78 incidents per 100,000 population. So, and you see the very steady and good increase since then. Even you can see only the numbers from 2005. And now, last year, we are reaching 15 per 100,000. But of course, these data are not confirmed yet. And personally, I don't believe in such a large decrease from the last year. But let's see what would be after some months when all data would be confirmed. But I still think that it is a bit less than 18 per 100 inhabitants. So when talking about the MDR TB cases, we always were a country with high burden of MDR and percentage. You see fluctuated all the time from the 7, even some years 6% to the even almost 13% among all TB cases. So that is one of the explanation why very soon after getting independence, it was clear that we need to do something with high MDR TB burden in the country. And immediately after start of Stop TB, not Stop TB, but Stop TB Baltic project, that was clear that Latvia is capable for doing educational and capacity building issues in the region, and was launched project in the collaboration with CDC Atlanta and USAID in 2 stages. One was creation of regional center of treatment and management of multi-drug resistant tuberculosis, and the second stage was creation of the international training center to disseminate experience in the region, and experience not only in management of MDR TB, but also all around the TB situation in countries like Latvia. So in 2001 was we piloting the first international training, and straight after that, just 2-3 years later, WHO nominates the center as a WHO collaborating center for research and training and management of multi-drug resistant tuberculosis. So when you see in a picture our TB and lung disease center, and also our training center is situated in this a bit smaller building. So since 2001, more than 3,000 participants from more than 60 countries have attended the WHO Collaborative Center Latvia training activities. We held more than 200 training sessions. There are established more than 25 training programs. The majority of programs are developed for on-site implementation, but we did also in field trainings in the countries around 20% of all our activities. So, and the same map with the countries you see, just there are the more precise list, even it is very small. You see that there are more than 60 countries, and we are not restricted only in European WHO European region. We had trainees from all over the world. And the main trainings were on comprehensive trainings on clinical management of drug-resistant tuberculosis, but also the programmatic management of drug-resistant tuberculosis, MDR-TB management in outpatient settings, including DOT, laboratory diagnostics, including training of technicians, pediatric TB and drug-resistant tuberculosis, as well as innovative training programs like role of surgery, palliative care, training of trainees, drug supply management, including the procurement and counting the drugs, infection control, and also communication, and including some trainings inside of sorted initiative. Yeah, so far so good, but time is changing, and even before we were discussing the opportunities of changing the modes of action, thinking more of involvement digital activities, also transition from the on-site to online activities, but of course everything changed when the COVID-19 pandemic came in. And there were changes not only in our work, as you may see how the MDR-TB ward personnel look like during this period, but also we had to think how to change our mode of action as a training center, international training center. And you see the many of activities and many of the series of consolidated guidelines came in, but we also understood that last on-site training was held in March 2019, straight before all COVID-19 restrictions were launched. And still during that time, there were high demand from European region countries for the update in TB field. And we see that many of series of documents came in, and we understand that the countries still need such kind of training. And we always had been the training body which translate guidelines to practical life, but also always we felt our responsibility to translating from the English language to the Russian language, which the vast majority of our region physician can understand and later adapt these activities. So that was quite hard, because they understand how to show how the OT happens, how the cough induction or infection control activities should be done through the video. Also to show how the concilium is working. That was quite a difficult task, but we did it in the way how we understand this. And the full 4 years, all trainings happened in online version. And only in 2023, we fully came back to the on-site way of action. The also very important thing to remember is that to being international training center, we have to cooperate with the WHO working groups, and our colleagues should be involved. This is the very good way how to transmit the knowledges received in working groups to the trainees, also to our training center capacity building. Our consultancy and technical assistance to National Tuberculosis Control Program, it is a very important part for the International Training Center. And also each of our trainers can be the temporary consultants in their fields, and in the same time to transmit the practice and knowledge, and and from the other hand, also to see what is happening in other countries and to bring those knowledges back. The also very important part of the International Training Center is not only think about the uh, training sessions and courses happening here, but also think about the regional distribution of the information. And we are in the middle of the Baltic countries. We always try to find the ways how to disseminate information to the our neighbor countries, and also to encourage the international cooperation in various projects. And also you see their picture from the Baltic Symposium, as well as a field visit to the Klaipėda hospital, which is situated in Lithuania. So in coming to the end of my presentation, to position ourselves as an integral player in regional development, we must focus on the following strategic actions. We always have to think how to partner with local educational institutions, governments, and industry to tailor offerings to regional needs. Also, equip the center with state-of-art facilities and learning technologies to provide advanced training solutions that are competitive on a global scale. Also, always think that we should offer courses that meet local needs and attract international attendees as well. So also the next is what is very important to continually refresh courses to align with current industry trends and also the technology advancements. Also, the regularly update training programs to reflect the latest industry trends, I already said, but implement sustainable methods in both the curriculum and the center's operations to promote environmental awareness and position the center as a leader in sustainable development training. And also foster connection with similar training centers. That's very, very important. And educational institutions worldwide to facilitate knowledge exchange and collaborative projects. And as a last but not least activity in our lessons learned, that we utilize both traditional and digital marketing strategies to raise awareness of the center's programs and success, targeting both regional and international audience. So at the end of my presentation, that I would like to say that we have to be very active in finding the ways how to develop, not stay on the one place on one stage, and always think about how to adapt training programs according the situation, but also according the technical solutions what are coming into our regular life. And I would like to conclude with the cite from Calvin College. All growth depends upon activity. There is no development physically or intellectually without effort, and effort means work. Thank you very much and for your attention, and all information I talked about you can find in our website as well. And have a very successful meeting.
Thank you so much, dear Lihat, for such an interesting piece of information on the international development. From our side, we'd just like to say that Liga and Riga Training Center overall are my personal teachers, I guess, because the first international training that I went there have been specifically at the Riga International Training Center of WHO, and many of the state phthisiatrist has also visited at least once the training in the Riga center, and this was always the really precious forward-leaning experience that we got during this training. And this was creative, this was in negotiation discussions and whatnot, and this is the professional discussions and also how both on the professional topics and getting new friends throughout your life path. Therefore, thank you so much for such a to both Liga and to Briga Training Center for training us, giving us hope for the future, and also a lot of clinicians from Ukraine. Hopefully, we will be continuing this line of cooperation. Additionally, I would just like to express my gratitude to Liga personally that she has added to our national TB hub and training center and presented as an international trainer for a few of the training facilities, which was a master class chemo-resistant TB and a few topics and a few areas of work. And so we also launched the new master class that a lot of our listeners liked, which was the management of special cases with the TB. So with comorbidities and adverse events and post-TB changes, post-TB lung disease. And on that masterclass, Liga has also been there as an international trainer and support for us. And for you, dear colleagues, I urge you to point your attention to Riga International Training Center that allows to give an international certification. And sooner or later, I guess we will be also moving to the international certification or international credits. And take those credits, you would need to do those in the international training centers and also in our training centers that will be dealing with the professional medical education would also have to be going through the certification in accordance to those credits. And so this is in the future still, but as you can see how time flies, and so this kind of future can reach us fast, and so therefore we need to be ready. And we already have this strong partnerships that would gladly take us to all of our experts to be trained. Thank you so much, and we will be continuing to move on. Thank you.
Шановні колеги,
Dear colleagues,
продовжуємо нашу роботу.
let's continue our work. And the last presentation of this session will be made by myself. My name is Natalia Litvinenko. I'm a head of at the National Scientific Center of Tuberculosis, Physiatry, and Allergy named after Janovsky. I'm also the head of the National Training Center on Professional Growth of Healthcare Workers, and I'm also an international expert on TB and other pulmonary diseases. But my today's this is the wrong one. I have two presentations today in session 1 and 2. So let's change a little bit. And we will continue. While we have some technical pause, I'd like once again to ask you, please don't be shy, ask your questions in the chat. Absolutely all your questions will have answers in writing when you're going to receive your certificates on your emails. And we continue. Since we started speaking about education, let's talk about the experience of our National Training Center of Professional Growth Healthcare Workers, the way we work, and we will just take our center as an example of the conditions for attestation or certification of the physicians. We'll talk about new opportunities, new requirements, and about how realistic it is to provide a quality medical education. First, before we start speaking about our activities, we need to go back in history a little bit. On these pictures, you can see starting 2016, we have been working in the Institute of Physiatry and Pulmonology together with the partners, with the donors. We had only offline trainings in some premises because we didn't have our own. But still, at that point, we tried to be creative with the maximum capacities regarding the learning process. And also, we were trying to use all the modern and available methodologies for education, which were technically available at that point.
Так, колеги, пробачайте, ще у нас одна
Sorry, colleagues, we keep having some technical issues. While I was telling you about our historical photos, somehow our system decided to halt, probably for you to see them better. And I will continue. And again, think about it. Medical education and new conditions for certifications are very important issues. That's why please ask questions to all the speakers, especially to those who represent UPHC, Dr. Alexander, who told us about the up-to-date conditions for the attestation. And we will continue. I'll show you some other historic photos. Apart from the fact that our speakers and employees of the Physiology Institute who developed trainings under my supervision, we were not just doctors and scientists. We wanted to be the best. We learned ourselves, participated in many international trainings. We attended international conferences, and invited international experts. And on these pictures, you can see our meetings with international experts, international conferences, discussions, And based on that, we learned some things which we could implement in our educational activity. Apart from the trainings themselves, trainings are for small groups, maximum 20 people, who came to our trainings, but we never stopped at this, and we always had national conferences. Those TB physicians who have been working for several years must remember on these photos our hall in the National Scientific Center. And in this hall, we usually had our national conferences. Then we moved a little bit further, and starting 2017, 2018, we started to rent the premises for the national events or international events. And when the COVID pandemic started in 2020, we started having online conferences. Then in 2018, thanks to the Challenge TB project implemented by international organization PATH, in partnership with this project and with PATH and the support of USAID, we equipped the training center at the premises of the Institute of Physiology and Pulmonology. Our management allocated some premises for us. The donors helped with the technical equipment. We've got furniture, we've got equipment, and we became to be able to have the courses in our institute, which you can see on the pictures. And this was much better because clinicians had an opportunity to go through clinical cases while being in the clinic. And back in 2018, 2019, we had trainings in the form of role-play games. Actually, we always used modern methodologies for learning. What do we have now? How can we meet the requirements of the new attestation process? As you heard, Alexander said that one of the requirements will be a mandatory in-person learning. And to have this, apart from the clinical base, there should be the premises comfortable for participants. And thanks to the international organization PATH, we managed to achieve this. So we have the central hall on one of the photos, you can see it. We have small rooms for the small groups to work, and we have an opportunity to organize catering. We have a kitchen where all this can be placed, and maybe to have some rest in between the sessions. And not mentioning the equipment, which is, I think, which is of maximum quality. Every participant has his or her own laptop to work on clinical assignments, clinical tests, and other learning methodologies. Apart from having own premises, quality education requires a modern educational platform. What is it? Both for trainers and for the staff of the training center. This is an opportunity for full analysis in one place, which includes automatic generation of the lists, the information what's happening in the personal cabinets of the participants. And here on the picture, to the right, this is how a personal cabinet looks like for each facility. This is an example of clinical tests or tasks. which our participants deal with, and the trainers can see it right away and assess the test results. So no need to send it by email. Everything is concentrated in one place. The training staff, it's a very important issue. All trainers undergo qualification testing, and the requirements include clinical experience of a trainer, experience of teaching, and possession of modern teaching methodologies. We also appreciate participation in the national and international TOTs. We value the experience of reports at the national and international conferences, using modern educational platforms. And also we involve the specialty experts. And we invite the experts at the national and international levels as trainers. As you heard from Alexander, now there's going to be a new requirement. So, meaning that each training center which wants to deliver quality education should cover the whole spectrum, the whole range of educational facilities. We have both offline trainings, offline masterclasses, online trainings, and now we have a new methodology, learning methodology. All the training cycles we have, and sometime the participants are invited for a refresher training, like mentoring, supervision, and there we deal with clinical cases, we do some testing, and look at the clinical cases presented by the participants. By the way, all the activities we perform, they are uploaded to the platform, as well as home assignments. For every participant, it's really convenient to log in to his or her personal cabinet, do some assignments, and then we can discuss them during the stream. We have discussions, which sometimes can be quite hot, but very useful for further activities. Now, just a few words about our outcomes. In 2024, we had more than 20 in-person trainings for clinicians, for them to get some practical skills. It was about principles of management of drug-resistant TB, management of adverse events, microbiology diagnosis. And on these pictures, you can see some insights of how our clinicians are trained. Apart from clinical trainings, in 2024, we had 10 trainings in mental health. And this is not only for clinicians, but also for other entities involved in provision of TB services. Very interesting, very creative. You can see on the pictures how we use all the modern methods of learning. Online masterclasses with the up-to-date educational platform, we can have a very high-level masterclasses. And here I would probably disagree with Alexander, who, when answering the question, said the masterclasses should be only offline. Yes, if you don't have an educational platform and the only thing you have is Zoom, yes, you're probably right. You can't have a master class in this format, and its quality won't be high. If you have the respective platform and possibility to do any clinical assignments, go through clinical cases and the clinical tasks, which can be both real time or as a home assignment for the participants. and then they can be discussed in small groups. Such a masterclass, its quality sometimes is even higher than that of the offline masterclass. And I think all our participants can confirm that. And there are some additional results of our training center. As I said, we're delivering not only trainings, but also conferences, national conferences, or like today, international conferences. We invite speakers from many countries, and these pictures are from the previous years, from 2022 to 23. We had speakers from the USA, Great Britain, Belgium, Denmark, Philippines, Indonesia, and others. Of course, the participants of our streams are clinicians, healthcare workers, nursing specialists, other people, other specialties involved in TB control, absolutely from all domains. Our streams are viewed abroad, and here we have the whole list of the countries who watch our events. And all previous events had at an average up to 2,000 participants, and we'll see how it works this year. In 2024, we had a very intensive year. We had one stand report at the European Respiratory Symposium, ERS 2024, and at TB Union 2024, which took place in Indonesia, in Bali, we were invited for the verbal report where we spoke about our refresher training system. During 3 years, our center has issued more than 12 CPD certificates. We're not going to stop. We're trying, and we will be improving the quality of our training activity. And going back to the title of my presentation, what are the conditions for provision of quality and up-to-date educational services in Ukraine? Very briefly, this includes technical capacities, no matter how we want it or not, but in the modern world, one should have a comfortable and convenient premises for educational activities if they're offline. If you have online or hybrid activities, or even offline activities or events, we use the personal cabinets of the participants on the educational platform. This is what is really needed in the 21st century. All the events should use modern methodologies. There should be clinical cases, clinical presentations. There should be a sustainable system for refresher trainings, such as mentoring, supervision. And the trainers should be experienced clinicians with experience of teaching at the modern educational activities. And they should be able to deliver the information both online, offline, at the conferences, the whole range covered by the requirements for continuous professional development. And educational events, not only for clinicians, but for other specialists who work in different domains. This is also needed. Colleagues, thank you for your attention. And once again, I'd like to emphasize we're expecting your questions in the chat box. I will have a look if there were questions to myself. And since we are supposed to start the next session according to our agenda, with your permission, if you ask me a question, I will answer you in writing in the chat. Thank you for your attention. Thank you, our speakers, and all the participants for active participation, for your feedback, questions. And in the near future, we will start the next session of our conference.
Доброго дня, шановні колеги. Будемо продовжувати нашу конференцію. Мене звати Марина Погребна, старший науковий співробітник відділу хіміорезистентного туберкульозу Національного наукового центру фтизіатрії, пульмонології та алергології. І я буду з вами протягом цієї сесії в якості модератора. Наша сесія присвячена досягненням та викликам у впровадженні інноваційних методик діагностики та лікування лікарсько-стійкового туберкульозу, найкращі дослідницькі та клінічні практики. Це надзвичайно актуальна тема, в якій ми намагались зібрати клініцистів, дослідників, науковців, для того, щоб ми могли з вами обмінятися досвідом і прийти до якихось спільних рішень. Протягом сесії ми будемо роздивлятись найкращі дослідниці та клінічні практики. В цій сесії у нас приймають участь провідні фахівці нашого інституту України, а також приймають участь міжнародні фахівці. І будемо розпочинати нашу сесію. І першим до доповіді ми запрошуємо пана Олега Горошенка. Пан Олег – асистент кафедри внутрішніх хвороб, гарант освітньої програми інтернатури радіології, гарант програми циклу спеціалізації рентгенологія, головний радіолог, керівник з розвитку радіологічної служби, заступник медичного директора з променевої діагностики центру «Добробут», також рентгенолог, інтервенційний радіолог клініки Феофанія. Пан Олег є учасником бойових дій, лейтенант медичної служби, інструктор із тактичної медицини. Бере участь у науково-дослідницьких розробці стандартів надання медичної допомоги. Будь ласка, пані Олег, вам слово.
Доброго дня, дякую вам за таке пишне представлення. Давайте поговоримо про променеву діагностику. Отже, ми поговоримо про КТ грудної клітки. Здавалося б, така банальна історія, всім добре відома, але поговоримо про певні її особливості в практиці. Я от так обрав тему, мені здається, що вона звучить досить цікаво. Робота радіолога, вона складна і пов'язана з цілим рядом викликів, перш за все, між тим, що ми фруструємо від того, що як ми себе бачимо, не зовсім виглядає так, як ми бачимося в очах клініцистів. Власне, так само, не будемо зупинятися на тому, що таке туберкульоз, про це сьогодні багато говорено, і, безперечно, фтизіатри
Mentioned about what TB is, and a lot of TB doctors can tell more than radiologists. If you see as the topic, like how do we see TB on the X-ray, that there is like a list of patterns that are quite widely known. This is the consolidation areas that might be there in different parts of the TB cavitation. So the openings and parenchyma and different kinds of nodular miliary nodules, and also the tree-like nodules, and also additionally lymphadenopathy and presence of the pleural exudate. What we can use is X-ray methods and CT methods as well. Here, what we are facing was the number of myths and legends. Multispiral or other types of CT, multi-slice. This is just a computer CT or computer tomography, because just one spiral or one slice tomographer, this is like not just yesterday, it's last year. And I guess it's hard to find this kind of equipment in Ukraine. Those tomographers are multi-spiral in any shape or form, because we need to refer patients to any kind of computer tomography that is accessible to them, to you, not worrying how many slices there are, and the number of lines in the detectors, which is technical characteristics of the computer tomographer that influences the number of data that they can get from there. But if you're taking into account the visualization of visceral pleura or lungs, they don't have any meaning. The more slices there are, the faster the tomographer is going to scan. The speed is going to be between 6 seconds and 9 seconds. For patients that are conscious and can take the breathing, so it's not going to be a problem, then we can see that wasted. The possible usage of the lung reconstruction, technical specifics, then you just need to ask for the radiologist who you're working with, and the scanning is not really important for a faster tomographer. This is an older recommendation, so 2 or 4 slice tomographers. Now with 16 slice tomographers, you're not going to find less than that in your clinical practice. Also, computer tomography to take into a point of the dosages of radiation. So now the diagnostics is at the level when we can't really make thinner slices. We can, but it's no point, because when you're mentioning about really thin ones, there's technique specific that you're taking more of the. So all the computer tomographers manufacturers, they're decreasing the dose.
And for that, other materials are used in detectors, These can be the technical features. And generally speaking, we can say that the modern CT computers are very safe, and we can have unlimited number of X-ray studies. So, like I said, it should be as low as reasonable. However, in 100 years of using radiological equipment, there was not a single confirmed case of the patient's deterioration due to diagnostic irradiation. Now we're not talking about using contrasts, etc. That's why we can safely have as many CT scans as needed for diagnostics, and we don't have also the data about negative impact on children. That's why we're against radiophobia. Here you can see how we scan the same area but a bit faster. And if we're talking about pulmonary windows, pulmonary kernels, here you can see it on the picture, it's a standard. Basically, I already mentioned the signs on CT scans. Here you can see the pronounced consolidation in the left part of a lung. We can see also bronchi lumens, and of course, when a radiologist sees that, then we can speak about the inflammatory process. So cavitation, we can see in the upper apex of the left lung. Also here we can see a big confluent foci of cavitation. We can see also the small cavern with small nodules. Basically, you can see pulmonary nodules. That is what we call miliary tuberculosis. This is a non-specific sign, and consolidation is more characteristic for the disease. As a rule, in such cases, we can see several combinations, like changes from miliary to consolidation. And this is a good advantage of the computer tomography, because thanks to such slight changes, we can notice the presence of intestinal thickenings. And here we can understand that the infection most likely entered through bronchi. There is the expansion of the inflammatory process in lungs, and here you can see the underlined in the left. In the right, you can see some single nodules, and this is the manifestation of the inflammatory process. Speaking about the advantages, they include better resolution, less dependence on human anthropometric data, and of course we can make some corrections. High sensitivity of parenchymal changes, we mentioned that already, and the ability to examine lymph nodes in mediastinium. And again, this is an all-in-one approach. Here we can look at lungs, airways, mediastinum, pulmonary sinuses, bones during one examination. And from our experience, there are some typical pictures with nodules, with consolidations. The presence of such nodule can be taken for lung cancer, basically. But of course, here there must be the clinical study, the sputum test. In some situations, there should be verification dependent on the location. And another picture. Here there are some poorly pronounced atelectasis. And in the studies which compare angiography and CT, there is a good study. It's a Canadian study. During 15 years, they studied patients with TB, and they discovered that detection of cavities, miliary nodules, etc. When compared with CT, cavitation was detected much more often, as well as endobronchial spread and parenchymal damage. It means that CT has much better sensitivity when used in case of pulmonary TB. Again, some illustrations from the same document. You can see if there is in the apex, we can see the nodule with cavitation. We can see it on the X-ray, but in this situation on CT, we can see the damage to the lymph node in the upper peripheral group. On X-ray, we can't see it because it is hidden behind the sternum. So, and on CT, we can see that it is enhanced with the necrosis. There is a whole group of complications after TB, and again, from the lung parenchyma, we can differentiate a lot of signs thanks to CT. I'm not going to read all these complications. You can see them on the slide. So we're not going to go deep on that. And again, this is how the classical MPM can look like: thickened pleural, fibrosis scars, the background of cavitation, Ramussen aneurysma. This is how it looks like on the CT with the contrast. Without contrast, we can take it for a node or nodule. That's why it's important to involve contrast in such cases to avoid some complications and injury to the patients. This is another interesting subject which should be considered separately. This is how ARDS looks like, a non-specific picture on CT, but in the background of miliary nodular lesion, we can see a thickened interstitium and the roots of the lungs, etc. So this is the picture which we can see. Picture of ARDS we can see on CT. Chest wall empyema. Here again, we can see the arrows, the accumulation of fluid under the skin, and even we can see the skin defect in this situation. These are the differential diagnosis, the changes which we can use during the differential diagnosis. So it can include bacterial pneumonia, sarcoidosis, silicosis, pneumoconiosis, hyperactive pneumonitis, and lung cancer. Here you can see consolidated pneumonia, cavitation in case of destructive pneumonia, and here there are some pictures demonstrating what situation we can observe. TB, non-specific pneumonitis, sarcoidosis. That's why we need, in this case, the clinical context and the assistance from the part of a TB doctor to make the final decision. Now here we have the same picture. We have TB on picture 2. And still, this requires the confirmation of the diagnosis. And again, here we can see in the right carcinoma, and in the right we can see tuberculosis. Can we In practice, when we want to verify this, sometimes a patient may come and we can see in a short time span, we can see a different picture. It means that this nodule or focus has no oncological cancer. Another opaque glass and granulums. That's what we can also encounter. Sometimes such nodes require morphological verification after biopsy. And if we have only damaged lymph nodes and there is no other way to verify it, we can do verification of group 7. Sometimes it can be done in case of sarcoidosis if other methods are unavailable. We can use MRI for diagnosis. Here you can see the pulmonary nodule, which we can see both on CT and on MRI if we use it in the certain mode. Here we can see the lymph nodes on MRI and nodules in the upper lobe of the right lung. And I would like to end my presentation with a clinical case. A patient, a woman 30 years old. She used to work in a hospital, and then there was detected a small focus in the 6 segments of lungs. And you can see from right to left and the dynamics. And on the last picture, we can see the changes which can be well seen. And here it's the same picture, a little bit enlarged in axial projection. Also, it should be noted that there was a big study which demonstrated that localization in the upper lobes is characteristic for immunocompetent patients. And lower lobe location, significant lymphadenopathy, and pleural effusion in adults are signs of immunocompromised patients. And conclusions are the following. The sensitivity of CT is significantly higher than that of radiography for detecting signs of pulmonary tuberculosis and its complications. There are significant similarities between the manifestations of pulmonary TB and other diseases of the lungs. It is necessary to consider the clinical context and communication between a clinician and a radiologist. And at this, let me thank you for your attention and let us conquer this enemy, tuberculosis. Thank you, Oleg, for very meaningful presentation. Well, physiatry goes hand by hand with radiography, and of course, in many cases, we need help of the experts. I would like to ask you about your attitude to the new technologies. We already mentioned that Ukraine is a flagship, and in some oblasts we have AI driven X-ray facilities. What do you think about this? Well, of course, I'm extremely positive about such innovations because there is a global trend that the number of examinations and complexity of examinations is increasing. This is a global trend, including Ukraine. That's why radiologists need assistance, and the AI, machine learning, etc. They're really helpful. There are some vendors who provide us with semi-automatic equipment to detect certain foci like in liver, in lungs, in cancer patients. Also, we use computer automatic detection, CAD, which we use, and now we actively are within this process. So regularly we provide the companies, not only the clinic that I represent, but when we talk to the clerk, there is a big demand on these images. We provide certain comments, and they use it. And we're trying to use artificial intelligence to improve the quality. In the most recent publications on this subject, it looks like that when certain changes are detected with AI, the role of the radiologist will be either to confirm or to decline this in order to set the diagnosis. Otherwise, we will just drown in this massive amount of images. And for the next presentation, we would like to invite Oskar Yanenbaev, head of the department at the WHO in Europe. He is a regional advisor on TB and resistant TB. He has experience on working on different programs and scientific studies. His report is achievements and the problems of implementation of innovative methods of DRTB treatment. Please, over to you, Oskar.
Dear colleagues, dear friends, it is my pleasure to be here today with you on this international conference on innovative approaches to the diagnosis and treatment of tuberculosis and other lung diseases, the practical recommendations for general practitioners, TB doctors, and pulmonologists. My name is Oskar Yanenbaev. I'm Regional Advisor for Tuberculosis and Drug-Resistant Tuberculosis in the WHO Regional Office for Europe. And today, it is my pleasure to speak about the achievements and challenges in implementing the innovative DRTB treatment modalities, best research and clinical practices. The recently released WHO and ECDC tuberculosis surveillance and monitoring in Europe report about 2 weeks ago is one more time demonstrating that the highest burden of TB and drug-resistant TB lies with the eastern parts of the WHO European region. The region has been demonstrating over the past decade a significant progress in decreasing incidence and mortality from tuberculosis. However, many geopolitical factors, including the humanitarian crisis in Europe, the COVID-19 pandemic, have significantly impacted reaching the targets that were set up at the regional and global levels. And the COVID-19 pandemic one more time demonstrated that pathogens do not respect any borders, any artificial walls. And the same applies for tuberculosis. An estimated burden of rifampicin-resistant, multi-drug-resistant tuberculosis in the WHO European region is 65,000. So most of the burden, as been said before, lies with countries in Eastern Europe, Central Asia, and the Russian Federation. And the burden of tuberculosis with resistance to rifampicin and isoniazid, MDR-TB, is showing at the global level the highest rates, with 24% among the new tuberculosis cases and 53% among those who were previously treated. This is times higher than the global average. Those were the estimations, but the actual number of cases with rifampicin-resistant tuberculosis notified in the WHO European region in 2023 was 29,000. And the prevalence among the notified cases of rifampicin-resistant, multi-drug-resistant tuberculosis among new cases was 20% and 50% among those previously treated. And looking by the rates of the MDR-TB, rifampicin-resistant TB among new pulmonary tuberculosis cases by countries. The highest is in the Russian Federation, Belarus, Kazakhstan, Republic, and Moldova, with the rates exceeding 30% among the new tuberculosis cases. Treatment outcomes for tuberculosis in the WHO European region are good for drug-susceptible tuberculosis, with 75.5% among the new and relapse cases, almost 90% among children below 14 years of age. However, treatment outcomes for patients with co-infection of tuberculosis and HIV, that's the cohort of 2022, and for drug-resistant tuberculosis, both for MDR and pre-XDR TB, still remain suboptimal and below those regional targets that was set up by the Regional Action Plan for Europe. Those targets set up by the Regional Action Plan for Europe is 85% of treatment success among MDR TB, rifampicin-resistant TB by the year 2030. But it is too far, still 6 more years to go, and the Regional Action Plan for tuberculosis in the WHO European region is setting up ambitious regional milestones to be achieved by 2025 in comparison with the levels of 2015 of 80% for treatment success among rifampicin-resistant and MDR TB. Latest data on the treatment success for tuberculosis with multi-drug resistance is indeed suboptimal. And we expect that the later cohort of patients with availability of and scaled up access to the new tuberculosis medications and shorter regimens will present much better treatment outcomes, and that it will be possible for us by the end of 2025 to reach these ambitious milestones. And because countries in the year of 2022, 2023, and further have been scaling up of access to the new tuberculosis medications. And with the new recommendations that the WHO have, we are ensuring that treatment should be ESSSA. This is the way how we call it in the WHO European region. It should be effective by using the drug combinations with possibility of S, shortening the duration of treatment. They should be S, safe or safer, by using medicines with proven safety profiles. The treatment also should be S, simple in terms of the drug administration, with which is patient-friendly, with no injectable agents, fully oral, and with the decreased number of pills. And A, it should be affordable for the national health systems and bring benefits, both from the economic perspective for patients and for the national health programs. Look back in the history, about 5 to 6 years ago, there was a recommendation on the use of the new tuberculosis medications as a part of the individualized longer treatment regimens for MDR-TB. And there was only one regimen, 9-month long, that was recommended for the programmatic use. However, regions and countries vary, and when we speak especially about the countries of the WHO European region with high burden of drug-resistant tuberculosis, this regimen was not quite suitable because majority of patients with pulmonary tuberculosis and confirmed resistance to rifampicin had resistance to some or even 4 drugs highlighted in red in this regimen. This is ethionamide, pyrazinamide, ethambutol, and isoniazid. So that regimen was not completely suitable to the countries of the WHO European region. However, the WHO was stating that if there was a baseline resistance or this regimen was not applicable or being applied to the settings or countries, they can use a modification to this regimen, but under the operational research conditions. And the operational research conditions are the conditions when they're close to the programmatic implementation with thorough monitoring and recording of all the variables that are being used for safety and effectiveness of this regimen. This led the WHO to development of the Operational Research Initiative, Regional Operational Research Initiative, and on introduction of the modified, fully oral, 9-month-long short treatment regimens for drug-resistant tuberculosis. Back then, this was the only opportunity for patients with multi-drug-resistant tuberculosis in the countries of WHO European region to benefit from shorter treatment regimens. These regimens were 9 months long, they were all oral, and had 6 times lower pill burden in comparison with the longer regimens that were recommended for the use. And this initiative combined 13 countries, 13 high-priority countries, and with the unified approach using the single protocol, clinical guide, information materials, and data collection instruments. And it resulted in the enrollment of more than 9,000 patients across 13 countries. And also this operational research initiative opened the door for the introduction of the BPAL-MOXIE regimen under the programmatic conditions that was recommended later in December 2022. What were the modified shorter treatment regimens that were fully oral? The logic behind the design of this regimen lies with the hierarchy of the grouping of the medicines for the longer treatment regimens, Group A, Group B, and Group C. So the first and the second regimens comprised of the medications from Group A and Group B, with only difference when cycloserine, for this or that reason, was replaced with delamanid. There was also a regimen for children under 6 years of age, comprising 4 drugs, but it was a delamanid-containing regimen because bedaquiline was not recommended for this age group. I'd like to repeat that these regimens, as part of the operational protocol, have been used in 13 countries of the WHO European region. And Ukraine, your country, is one of them, showing the highest cohort of patients enrolled. The primary objective of this operational research was to determine the treatment outcomes of patients who were treated with these modified regimens. And the secondary objectives were to look at the safety profile of these shorter regimens, but also to determine the proportion of patients with recurrence during the 12 months after successful treatment with these modified regimens. And the approach was unified and was the same in all 13 countries listed here. There were almost no exclusion criteria for being enrolled in treatment with these modified shorter treatment regimens under operational research conditions. And patients with co-infection with HIV, with some baseline conditions, were still eligible to benefit from these regimens. The only exclusion was, as a significant one, if the patient had a baseline resistance to fluoroquinolone at the beginning of treatment. This slide is demonstrating the timeline of enrollment into the regional cohort in each of the country. That was 12 months and then 12 months of the post-treatment follow-up. Also, after completion of enrollment of patients into the regional cohort, each of the 13 countries continued enrolling patients as part of this operational research initiative into the national cohorts because they found the modified treatment regimens as effective and safe. That was opening the door for patients, many patients, to be treated with shorter regimens. More than 2,800 patients were enrolled into the regional cohort within this regional operational research initiative, and then countries continued enrolling patients into the national cohort. The largest cohort of patients has been enrolled in your country, in Ukraine, and indeed almost 45% of the regional cohort were patients from your country, and congratulations to Ukraine on this achievement. The results of the treatment effectiveness and safety of the use of this 9-month-long shorter treatment regimens modified for treatment of multi-drug-resistant tuberculosis demonstrated a high effectiveness of 82.7%, which is much higher than the regional average of 60%, and already this is higher than the regional milestones by the year 2025, according to the Regional Action Plan. The results have been published in summer last year in the Lancet Infectious Diseases paper, highlighting the great success of this regional operational research initiative. And now we're living in time when WHO is recommending even shorter treatment regimens, 6 months long, for the treatment of multi-drug-resistant tuberculosis under routine programmatic conditions, comprising of 4 medicines, bedaquiline, pritomanid, linezolid, and moxifloxacin, with 20 times less pills, no injections, for the majority of patients with multi-drug-resistant TB. And the WHO is calling for action on the use of these regimens and as a gold standard and to scale up. WHO is calling to scale up use of these short treatment regimens for the routine programmatic conditions, as it's been considered as a true breakthrough in the management of patients with multi-drug-resistant TB. And according to the latest recommendations by WHO, bedaquiline is an essential component of all treatment regimens for drug-resistant TB, and this is the regimen of choice. These short treatment regimens are bringing in truly programmatic benefits because they are highly effective with a very good safety profile, which is leading to the significantly lower rate of loss to follow-up or patients defaulted from treatment. We get the results earlier of the treatment outcomes, and also the use of the short regimens opening the doors for the more economic benefits for the health systems and also for patients, and opening the doors of treating patients in the outpatient settings and with optimized treatment monitoring. Very soon, most likely within the next few weeks, WHO will release a consolidated guidelines of treatment of tuberculosis. These guidelines will combine guidelines on the treatment of drug-susceptible TB, treatment care and support, and treatment of multi-drug-resistant tuberculosis. The new recommendations will include the use of the 6-month-long regimens. BPAL, MOXI regimen will remain, and the new treatment regimen comprising of other 5 medications, bedaquiline, delamanid, linezolid, levofloxacin, and clofazimine, will be also recommended as an alternative, because the BPAL-MOXI regimen is not recommended yet for the patients below 14 years of age, women who are pregnant and breastfeeding. However, new regimen, 6-month-long, can be used for them. Another 3 regimens that are the information from which is coming from the NTB clinical trial will be recommending the use of 3 9-month-long regimens, also for patients with multi-drug-resistant tuberculosis. And there will be a role remaining for the longer treatment regimen, 18-month-long, individualized, in the situations when the 6 and 9-month regimens cannot be used or they are not available. Now the hierarchy of all regimens for treatment of drug-resistant tuberculosis will give the prevailing role for the 6-month-long regimen over the 9-month-long regimen, and longer treatment regimens of 18 months, and so will be only used as a regimen of last hope for the smallest number of patients. I'd like to continue this presentation and switch from the clinical aspects to the programmatic aspects, reminding us that the COVID-19 pandemic had demonstrated not only the challenges that were associated with the disruption of provision of essential tuberculosis services, but also brought an opportunity for us to think out of the box, to apply additional modalities for delivering patient care, for treating patients in the outpatient settings, for applying digital health solutions to support patients' adherence to treatment and expand the community-based approach. We all remember that during the COVID-19 pandemic, the video-supported treatment was considered as an opportunity to treat patients without any interruption, without any disturbance at the outpatient settings. And it also is an opportunity to contribute to the decrease of the stigma and discrimination associated with tuberculosis and decrease unnecessary costs both for patients and for the health systems. And the use of the fully oral regimens, mostly shorter treatment regimens, under the video-supported treatment is opening the doors to optimize, to make it more effective and people-friendly. And I would like also to say that the term video-supported treatment is coming from the WHO European region, because before that it was called video-observed treatment. But this is more than an observation. This is a supported treatment. Both a combination of the advancements in the approaches in the clinical management of drug-resistant TB with short treatment regimens with effective and safe drugs, uninterrupted supply, treating patients in the outpatient settings, but also introducing the modalities as a video-supported treatment is all breaking the chain of the development of the antimicrobial resistance, because when there is an interruption of treatment or the treatment is suboptimal and there are poor compliance to treatment, it will increase the development of drug resistance. It will bring to the spread of this resistant strains to others. There will be more people who will be harder to treat, and this will all fuel the development of antimicrobial resistance. So the use of the shorter treatment regimens is indeed, and with an application of the programmatic modalities and the outpatient settings, will definitely contribute to decrease of the burden of tuberculosis with drug resistance, not only in our region, but globally. That is so true that we are living in a very interesting and exciting time when the tuberculosis drug pipeline is the strongest in the decades. There will be new tuberculosis medications available in the next years, because many of them are in the phase B or 3 trials. They're underway, and there will be recommendations by the WHO after analyzing the data coming from the clinical trials to be used. However, I think that we should not be waiting for the availability and recommendations on the use of these new tuberculosis drugs. By using the current recommendations, the current regimens properly and wisely, and avoiding the development of the resistance. However, whatever will be recommended in future, in the next coming years, will be the new regimens in the combination of drugs that will be so effective and safe to even decrease the duration of treatment further, 4 months or below. And this will be very much awaited and very much needed. I would like to finish by the words of the famous American author, Jackson Brown Jr., that nothing is more expensive than a missed opportunity. We shouldn't be missing the opportunity of having the low resistance to the new tuberculosis medications by treating patients properly, effectively, by offering them support throughout the entire duration of treatment and decreasing the reservoir of infection. Because otherwise, if these regimens will be used improperly, this will lead to the more severe consequences. And at the very end, I would like to thank you once again for your great collaboration, for your great involvement, and for your support, and for your indifference. Thank you.
Oh, thank you so much, Yaskar, for such a profound and interesting presentation and ability to hear yet again the biggest achievements of the last years in the TB medicine. And we will all be eagerly waiting on the new consolidated regulation. Thank you so much. And we will be continuing. Next presentation will be from Natalia Litvinenko, head of the chemo-resistant tuberculosis and the head of the National Training Center and the National Scientific Center of Pulmonology, TB, and Allergy. She is the head of the organization committee of this conference. TB doctor, pulmonologist with 20 years of experience in TB treatment, and also Natalia is the national expert on TB, especially for drug resistant. Is part of the international, is part of Union, MRS, and others. As of now, Natalia is the leader of the scientific department of chemo-resistant or drug-resistant TB. And also on the National International Organization on the TB. In the presentation, Natalia will have the use of 6 months regimens for drug-resistant TB in Ukraine within the research, the main results, and the route results and selection practice. Thank you so much, Marina, for your presentation. Dear colleagues, I think that after the presentation of Oskar, it's so hard to tell you about something new, but in the framework of our conference, a lot of things has been done that maybe we need to appreciate our achievements as well. And so we are used to international recommendations, international experts are telling about some kind of achievements in other countries, and we are only using those achievements in our practical line of work. And in our presentation, I would just really like to make sure and that you understand that optimism is still there, that our country for many, many years is a flagship in TB medication, TB treatment, in treatment of drug-resistant TB. And we can start off with the historic excourse and then the things that we have as of now in our country as well. So TB doctors know how it all started. Even in 2010, when we have the people that then worked in TB service and fighting TB, they remember that the first publication on the 9 months regimen for treatment, 2010 has been the time when everybody treated minimum 2 years chemo-resistant TB, and even shorter for a few months forms considered as the unattainable goal. And so then, speaking about 9 months courses, and those courses included regular courses, but because of the correct algorithms, and that we would be able to achieve high results in treatment. And also after that, we started to have a new era of antimicrobial medication that you can share into 4 stages. First stage, which is 2016, 6 years after this first stage, we gotten to know about the short term regimen from WHO, and this was the beginning or improvement of this short term regimen that has been recommended in 2019 or in 2010. So it has included as the background, this was injectable aminoglycosides, and so fluoroquinolones, and so other ones, the older anti-TB medication. But in the correct usage, what you can see and you can achieve from this table, almost 90% effectiveness in treatment. In case there's the resistance of torquinolones, you could achieve at least 67% effectiveness. In that times, we have the topic of the scientific topic, the line of work on the code A1602, then where we have made an operational study. And so then into the country came the new out of the profile medication, the Nezolid, for the new one for us. The doctors from other specialists worked with them as the antibiotic of the wide spectrum of activity, but then we start to shorten the overall treatment duration, and in the 2017, the cohort, our monthly cohort of 2016 that received 12 months short-term, and because of the cooperation of Public Health Center, the list of patients that had the WHO passed on in our country had been one of the few countries that in 2016 covered as the country that had implemented short-term treatment regimens. And so is it not the innovation? Is it not the reason to be sure and be proud of your country that we are leaders in any areas of work? So if you are, all of those dedications and everything else, they've been published in the international media, and so it was presented on the international conferences. In 2019, even on the TB Union conference, we have presented on that in the oral presentation on the effectiveness of the short-term regimens. Not even 2 years has passed. There's second stage of new era of antibacterial treatment as the WHO improves the short-term regimens and adds to 9 months regimen. New anti-TB medication, bedaquiline specifically. And so this is a strong reinforcement of this treatment option. They remove from the regimen injectable medication, aminoglycosides as well, so that it starts to look much more attractive and much more patient-friendly option. So we, based on our scientific center, we're not standing aside the innovation that the WHO is proposing. And in 2018, in 3 years, we started to have new operational studies, so that what we saw at 12 months regimens with the linezolid were giving 90% effectiveness for treatment. Why don't we include into the short regimen also new medication? So we would propose two options of the short-term 9 months regimens with bedaquiline, and sometimes there goes in line with the regimens or treatment schemes that WHO is proposing. But there are a few differences on the number of medication, and in each group we are achieving a high level of effectiveness of treatment, more than 90%. So in case of there's no episodes there additionally, and also that there's a early sterilization activities happening, and more patients have no bacteriology excretion during the first months of treatment. And so the results of this study are giving us the background to plan our future developments by shortening the overall duration of treatment, because what we can see is that even 9 months, it's too much. This is too long, and so about that a bit later. In the same way, those regimens could also be presented on the TB Union in 2019. And those regimens caused a lot of interest from the international community. We've been invited to world presentation, and all those regimens can be shared among the international community as well. But the world is not standing still. In 2022, WHO proposed to us to make an official BPAL regimen, BPAL-M regimen that I would also mention slightly later. The whole world just hears about those types of treatment, and we are already implementing them. Since BPAL has been recommended by the WHO only in 2022, we have started to use this regimen in 2020, 2 years earlier than that. And so we were the only country, the first country that started to use the BPAL, not within the clinical trial, but within the national program or operational study. And we are receiving the level of effectiveness in those 91.5% effectiveness. And in 2001 and 2002, independently from the COVID-19 pandemic, we are making presentation at international congresses, and we've been invited to the oral presentations to spread out our experience in the world. And in 2023, together with partners, we have spread the information in the world on the implementation of BPAL and its high efficiency, and that the safety profile is also good. And the last stage on the BPAL implementation, which is the European Respiratory Congress in Vienna in 2024, where we are sharing not just the results of BPAL directly, but also the long-term results as well, or long-term consequences. But the fact that BPAL and BPAL-M does not have the recurrence is one thing, but also in our line of work and in our poster for the presentation on IRS, this has been taken for the poster presentation. We are showing what kind of issues we have and what kind of options we have and during the follow-up period, in the observation period, and also what kind of options we have of the data collection can be present there on all of those stages. Additionally, on the ERS, we also presented another presentation together with the partners, together with the regions, on the implementation on BPAL and BPAL-M and the routine practice in the regions of Ukraine, where this project has been implemented. The most interesting thing when we are just starting the stage 4 that we are entering with both of you together, which is apart from BPAL and BPAL-M, WHO in 2015 recommended us, apart from the known 6 months regimens with britamide, and to have 6 months regimens with delamanid. And so this is how it looks like, the approximate algorithm, how to use based on the opinion of international experts, WHO experts, and those short-term regimens. So how you can see on the slide, there is a place both for the BPAL regimen for 6 months, BPAL and BPAL-M, and it's basic from which you need to start off. And if you have like any contraindications to the BPAL regimen, then you need to use 6 months regimen with delamanid. And other proposed 9 months alternative regimens for treatment, but taking into account that the present strong and interesting proposals on 6 months regimens, then they're just losing their brightness essentially, but they can also be recommended for usage. The Institute of Physiatry or National TB Institute, as of now, we're not standing as a bystander of the stage 4, and the WHO in 2025 they recommended to have the 6-month regimens for treatment, and we have already started to have the new operational trial in 2022. In 2024 we have finished it on the usage of the shortened 6 months forms of treatment. And of course, we couldn't, together with the experts of WHO, to get to know and fully one-to-one be in line on the list of the anti-TB medication into those regimen, but they're really alike on the basic medication. Our thoughts have been absolutely the same. So we have recommended within our algorithm to start with the bedaquiline, linezolid, moxifloxacin in high doses, cycloserine and delamanid. And so if there is resistance to fluoroquinolones, then to change it to clofazimine. And so we had taken into the first group 89 patient into 45 groups as well, respectively. And this is the results that we get for the treatment compared to with the BPAL regimen. BPAL has also been used by us as the comparison group so that to answer on the question of the clinicians. And what do we do? How do we select from two algorithms, which is the best one, because there's an algorithms of usage of BPAL and BPAL-M, and there's an algorithms of usage of this 6 months regimens with Delamine. If you are to mention about what was chosen in Ukraine, the one simple thing gives an answer in Ukraine. The indicator, how effective and what the price is. Two algorithms fully comparable, effectiveness is fully together. The safety profile is almost the same, but on the pricing and effectiveness in our country, of course, we are having the algorithm, the BPAL, BPAL-M, because the price of pretamanidine as of this moment of time is much, much lower compared with the price of the lemony. And no matter how we would calculate it, but in the end of the day, still the indicator for price and effectiveness, it's one of the key things. And so therefore, our algorithm compared to the algorithms proposed by the WHO, it does look like it's a bit different with the small changes and shifts. But if, for example, there are indications to use a 6-month short-term options with the lemonade, then depending on the beginning of the resistance profile or susceptibility profile to fluoroquinolones, we can change this regimen for treatment. But the difference of our algorithm compared with the WHO algorithm, that in case a patient is susceptible to fluoroquinolone but is resistant to linezolid, for such groups of patients, you're able to use the 6 months option, so that we had such patients, they have finished treatment and nobody has recurrence happening. So how are we planning to implement our developments? And so this year we were planning to apply traditionally abstracts in IRS and in the union. We do have hopes that our abstracts and everything else will be approved. But so far, at this moment of time, we have methodological thing for doctors where we will be detailed looking at all the short-term options. First and foremost, we will looking at BPAL and BPAL-M in this guide, starting from what it consists of, how it acts on anti-TB medication, how you diagnose, detect, and treat patients with TB. This guide will be shortly available. We were not able to send it out in 2024, but in the nearest times, we will be able to send it into every anti-TB facility, into libraries, on the registries, and also additionally, this guide as an online resource will be also available on our webpage, National TB Hub. Therefore, please do go ahead and who's interested. And I think that if you are dealing with the TB treatment or patient with TB, independently if you are a TB doctor or not, or a pulmonologist or a general practice physician, this will be really useful in such a profound material, even though it's there's clinical cases that are interesting to be seen to every clinician who's dealing with the tuberculosis. Thank you so much for your attention. And if you have any question, then please do go ahead. I'm more than happy to answer, to give them an answer. Thank you so much, Natalia. A great presentation. I also want to highlight yet again that yes, we do have things to be proud of, both in our country, in our clinic, in our scientific center. And our clinic and center are developing new regimens for many, many years, and many, many topics have been planned and used. And it's such a nice thing that the latest topic that we have, it's really in line with the latest WHO recommendations. I would just like to open this door. Like, what are the clinic is plans to do for the next 3 years? Because we plan the new topics, and I think for everybody it will be interesting to hear, like, what are the future, what does the future hold for us? So for a long time we've thought like what to do later on. And so in chemotherapy, essentially on this stage of our endeavors and our capacity, we've studied everything we could. So the all options of the short-term regimens that are available within the operational research and studies have been conducted. And so I think now the word is under the strong centers that are doing with the development of new anti-TB medication, and Maria will be mentioning this later on. So we decided to concentrate on more of the close-scale questions, like, for example, of the people who have TB, and to have a look what kind of comorbidities there are, what are other states that there are, the leading with the patient, what needs they have, how does it influence the effectiveness of the treatment, does it influence the compliance, and how to manage those patients with the comorbidities as well. So part of that, right now in our country, there's war, and many of our army personnel that are protecting us, that are reaching out for help because they have TB. And so therefore we decided to study whether is any difference of the course of the disease in the civilian people and the military personnel, and which stages did it detect in civilians and the military personnel, and maybe if there's going to be any difference, to develop like an algorithm to give them like recommendations to improve the status of those patients. And so also what's important is to improve the mental health status in patients that are receiving these short-term regimens, and also depending on like what kind of person this is it the civilian or military personnel, people with dependencies, people with comorbidities, maybe some of the things of different methodology of care provision or improvement of the state of mental health also have to be present for those categories of people to be differentiated. Therefore, the area of our future work would be sort of in that area of work. Thank you so much, dear Natalia. We still have questions from the chat.
And the question is, did you observe many adverse events when using BPAL? Thank you very much for your question. With BPAL, there were much fewer adverse events, and the explanation is very simple. The thing is that we started with BPAL, and BPAL-M arrived later. So that was BPAL was absolutely new regimen, and the first cohort had a high dose of linezolid, 1200, and we paid so much attention to these people who were on the innovative treatment that the physicians recorded all and any events. So the attention was too high because it was a new kind of treatment, and one should understand whether people tolerate it well or not. When it became clear that people tolerate it well, there are some adverse reactions, but they're not serious, they are controlled. This is the human psychology as well as physician psychology. You can do nothing about it. After a few years of using BPAL, the number of recorded adverse events dropped down significantly. And sometimes, physicians are used to adverse events and don't register them. So, and this was the same. So my physicians just started treating patients without paying attention to minor adverse events. This is the only explanation I have. If with BPAL we had more than 50% of adverse events, with BPAL-M we had 25-30%. Thank you, Natalia. Okay, let's move forward. And we are inviting Olesya Medvedeva, a TB physician and coordinator of the TB treatment programs, Ukrainian Center for Public Health. And she also works as a TB doctor, and she's a clinician in the operating reports. So she will be speaking about experience in implementing flagship trials of innovative short treatment regimens in Ukraine. Thank you very much. Well, after Oscar and Natalia, it'll be quite hard for me to report. I have a very important task today to present the results of operating reports for the whole country, and all experts in our regional TB centers, under support of the UPHC, of course, as well as the Institute and other partners. So let's first remember the main steps to shorter treatment regimens. Starting November 2020, the premises of regional TB centers in partnership with NTP and WHO Euro, we started enrollment in regional WHO cohorts for STRs. At the same time, as Natalia said, at the premises of the National Institute of Physiatry Pulmonology named after Janovsky, there was the implementation of BPAL study. In 2021, the recruitment to the country cohort started for MSTRs, and it is still ongoing for patients with counterindications to BPAL-M, including children under 14, pregnant women, and the patients resistant to delamanid and pritamanid. So this is the current situation. We know that the new WHO guidelines were published regarding TB treatment. That's why we're expecting changes to the national standard. And after those changes, after they are published, after the order, MOH order is approved, we will have new treatment algorithms. Irrespective of a full-scale Russian aggression, in June 2022, the full-scale BPAL study was initiated in all regions of Ukraine, with the exception of penitentiary center. In January 2023, the standard of care tuberculosis was approved, and the programmatic application of BPAL and BPAL-M began. And in January, February, it was implemented in the civilian sector, and in 2023, BPAL and BPAL-M became available for the penitentiary sector. So what were the objectives for such shorter regimens? The main one was to determine efficacy of these regimens and to assess their safety. And secondary objectives were to evaluate adverse events of particular interest, evaluate how many patients completed their treatment, so their adherence, to identify if there is resistance to some components of the regimen, and also the frequency of relapses and reinfection after 12 months upon the completion. Let's start with the operating study of MSTR. This is the country cohort. Regarding WHO cohort, it was already mentioned that 45% of patients in this study were patients from Ukraine. Therefore, of course, our regional centers did very good job. If we look at the inclusion geography, you can see, so according to TB morbidity, in those regions, more patients were enrolled. With regard to the distribution between men and women, again, it's characteristic to common distribution. There were mostly men. There were around 190 children under 18, and there were children under 14 as well. 30% had HIV, and 10% had viral hepatitis B or C. Regarding screening, it's still going on, and this is for a very small cohort of patients. Starting 2021 till April 2025, more than 5,000 patients have been screened. 43% of them were enrolled in this study, And now almost all patients completed their treatment, and only less than 4% left the study because of resistance or for some other reasons. And you can see that the main reasons for not inclusion of the patients was the decision of the research center and resistance to fluoroquinolones. Regarding safety of treatment, almost in every fourth or every fifth patient had adverse events. And for the majority of patients, it was only one adverse event, first grade, and only every fourth adverse event was serious. Most commonly, it was myelosuppression and hepatotoxicity. And as of now, we have the following results: 77.8% treatment success, treatment failure a bit more than 6%. And I'd like just to reflect on why these results are a bit lower than we expected. We have more than 10% of those lost to follow up. It's quite a big number, but since the study was performed during the war period, so that was one of the reasons. Such things as mass migration that could be quite expected, and we would like you to pay attention to this so that clinicians could involve NGOs, social workers to search for these patients and pay attention to this. BPAL included 358 patients in the study. This was the beginning of the full-scale invasion from February to June 2022. We understand that not everyone was able to participate in the study because some of them were from the regions where there were active hostilities. There were patients with HIV, with hepatitis, and there were 4 children from 14 to 18 years of age. The reasons for non-inclusion were susceptibility to fluoroquinolones, and the research center for some reason decided not to enroll them either because of their pulmonary condition or because there was no reliable DST. With regard to adverse events in the PAL study, they were more frequent, almost in every second patient, but 8% of them were serious. And of them, 8% resulted in either changing the dose or treatment discontinuation, and only 1% led to complete discontinuation of the regimen. And again, like with STRs, at the first place there was myelosuppression, and the second place was with hepatotoxicity. And also some percentage had neurological events. So the treatment outcomes were better as compared to the previous study, almost 90% treatment success, 3.7 treatment failure, 4.5 were lost to follow up. So what do we have now in the programmatic implementation? If compared with 2021, then of course treatment efficacy has improved significantly. But if we compare this with operational study, then the efficacy is lower. And This is because if the regimen is implemented as a part of the operational study, then the more attention is paid to it and more requirements are put forward to those patients. That's why we'd like to highlight that in the programmatic use, the efficacy indicators cannot be lower as compared to operational studies. That's why, if you could please revise your monitoring, involve NGOs to improve treatment results, treatment outcomes. As I said, we're planning to update the national standards in order to give more opportunity to those who have counterindications to BPAL and BPAL-M, and those who can't be included in the MSTR operational study. During 2022, here you can see the international publications of Ukraine. Today it was mentioned many times that Ukraine is the flagship, the leader in implementing all the innovations, not only regarding screening or diagnosis, but also treatment of TB. We are the first to rapidly adapt and follow all WHO recommendations, and we share our experience worldwide. And this is thanks to almost absolutely all the partners. Of course, these are those who protect our country, because this is all done under the governance of the Ministry of Health, UPHC, National Scientific Center of Pulmonology, and other partners. And as you see, now we have the main enemy, and I'm sure we will win. And then we will conquer TB. We have everything to achieve that. And thank you very much for your attention. Thank you for your presentation. We understand what work is standing behind these slides and what work was done by the UPHC. That's right. It's quite difficult to implement an OR in a country, especially in the conditions of war. Thank you for your work. From your experience, what lessons can be learned from Ukrainian experience? What were the biggest difficulties in implementation? Well, of course, the most difficult thing was war conditions, a shortage in staff, destroyed infrastructure, when patients cannot come to monitoring because of missile attacks. And if we speak to close to the frontline areas, they have constant bombing and shelling. And of course, this affected monitoring. Not all the studies were performed, and we have a high percentage of loss to follow up due to migration. If the migration was inside the country, we were searching for these patients in other regions and continued their treatment. If patients left the country, sometimes our experts provided them with the drugs, and they managed to complete their treatment. But speaking about occupied areas, of course, we don't know what happened to those patients. We don't know their fate, so it's hard to say. That's a big work to do, and mostly local clinicians are dealing with that. Thank you very much, Olesya. And we're going to move forward. And well, I would like to say it's really great that you're writing your words of gratitude in the chat. But apart from these wonderful words, we're also expecting questions from you to our speakers. You have a chance to ask these questions in the chat, so please get engaged, dear colleagues. And we're moving forward. And I would like to invite Maria Dyachenko, Senior Market Access Manager, to be Alliance. And She started her career as a scientist, then she moved to pharmaceutical sector. She has 10-year experience in various companies such as Johnson & Johnson, etc. And the name of the presentation is Experience in Implementing Short Regimens BIPAL-M in the World, Results of the Operating Research and Routine Practice. Thank you very much, colleagues, and thank you for an opportunity to speak about the experience of introducing shorter regimens, not only in Ukraine, but worldwide, because I think there is nothing more left to say about Ukraine. We can only say that Ukraine is very much different and it's really leading as compared to other countries. We were talking today about the innovations in the country. This is quite subjective. That's why it's quite interesting to look at other countries and compare ourselves with other practice and other countries and other practices. And my colleagues already mentioned TB Alliance. It's a non-commercial organization. We're dealing with developing innovative medications, especially specifically for TB. It was mentioned that TB is not very interesting for pharmaceutical companies because it's not profitable. But that's why TB Alliance as a partnership was created in 2000. So we're 25 this year, especially for the purpose of focusing on TB niche to develop, to deliver medications and innovations to the patients with TB. In general, the development of innovations is a lengthy process. Clinical trials take around 10 years from the point of discovery of the molecule to getting the permission to use it in clinical practice. There is the second part of this process, is the access to the innovation from the part of the patient. And unfortunately, here again, we lose quite a lot of time with TB because historically, innovations for our patients, they reach our patients only 7-9 years later, even more, depending on the country. That's why there are a lot of reasons and explanations for that. But every time with every innovation, when the WHO declares or updates some recommendations, we're doing better and better job. And innovations reach our patients faster, like in case of BIPAL and BIPAL-M, thanks to the work done by the Center of Public Health and the Institute. All these data collected within the country and in other countries, and the collection had started before WHO recommended STRs. And also thanks to some other steps made in parallel, we managed to bring this innovation to patients only in 3 years, which is much faster as compared to the previous time. Still, 3 years is still a lot. Sometimes we're afraid of innovations. Sometimes we don't understand them. We need more experience and understanding of what innovations are. That's why the early interaction and cooperation, this is what colleagues mentioned already, are extremely important. And we're really grateful to all of you in Ukraine who are engaged in these operating studies. Basically, we start research into the alliance before FDA approval, before phase 3. We are not only involved in phase 2, which is clear, but we also evaluate to what extent this innovation will be accepted and how affordable it will be for the country. This is a part of phase 3, and this is a very important precondition to engage regulators and the leading clinical centers, patient groups. That's why all this is extremely important, and it's a precondition for correct formulation of clear KPIs for phase 3, and to understand how necessary this innovation will be for the countries and for patients. We also started application of BPAL and BPAL-M quite early, starting 2010, thanks to TB Alliance and the KOICA from South Korea. There was a project called Leave TB. It united 7 countries: Ukraine, Afghanistan, Uzbekistan, Myanmar, Philippines, Indonesia, and Vietnam, all of them with high burden of MDR-TB. These countries started with operational research. Ukraine was the first country which started this research as a part of Live TB program, and then scaled this up for the all Ukrainian cohort nationwide. And after several stages of Live2B project, operational research started, and then after publication of the WHO recommendations, many partners supported and were involved in this project over all these years. We're extremely grateful to everyone for their leadership and partnership. A few words about the results. They vary across the countries because countries are different, health systems are different. In some places, care is provided in decentralized way, somewhere in centralized way. And it was interesting for us to see to what extent application of BPAL and BPAL-M in different programmatic conditions can be comparable with the efficacy in clinical studies, as we see more than 92% efficacy. So what is comparable with the results achieved during clinical trials? And as you see, Ukraine had the largest cohort of patients. And again, thank you for this to all who were involved. Regarding safety, and we will speak a bit in more detail about safety. This is a general slide. I'm not going to go deep in the details, but OR was initiated when linezolid was recommended in the dosage 1200 milligrams. And then part of the patients were enrolled for 600 milligrams. A bit later, I'll show you what we gained in terms of safety, because there is a certain difference, which can be expected. I also want to know that for us as developers of medications, it is extremely important to have the reports about adverse events, especially in programmatic sense, because this becomes the direction for us to improve the existing medications and therapeutic approaches. And we're really grateful to those who report about adverse events. Here you can see that for Philippines, the AEs are much higher as compared to other countries, and this is because reporting is different in Philippines. And again, what colleagues mentioned is extremely important, and this is more meaningful than just reporting to the health system. In 6 months, the patients who returned for follow-up study were assessed, and we discovered that 96% of these patients have no signs of TB. We detected a few relapses, and for some patients it was related to the fact that patients with HIV discontinued treatment and were reinfected. Basically, all these samples, all these specimens are being sequenced at the moment to find out whether it was a new infection or it was a reinfection. And of course, we will share the sequencing results. And it was mentioned that dosage of linezolid, 1200 and 600 milligrams. In terms of the percentage, for 600 milligrams, the cohort was much smaller because they were enrolled later, after the the reduced doses were recommended. But there were some interesting results based on cohort analysis, and it was could be expected. The number of myelosuppression and peripheral neuropathy cases was higher for the cohort which had the dosage 1200 milligrams. And the cohort analysis showed that this depended a lot on sex and age. Still, there was a correlation, and we will continue monitoring this. And this will provide a lot of insights for us. Regarding to ASI, grade 3 and higher, the correlation was found only for myelosuppression with a dosage 1200 milligrams. And the factors associated with myelosuppression are mostly age, sex. So females were more sensitive to it. And for peripheral neuropathy, likewise, it was sex. And of course, we need more data for our cohort analysis to make it statistically credible. Sex is the main factor, which is related to the development of peripheral neuropathy. With regard to the acceptance of innovations, Ukraine is a really important country. First of all, it's a leader in implementation of innovations, and that was marked at the international level. Last year, it was mentioned that Ukraine is one of the leaders. Also, Ukraine shared experience with the colleagues from India at the time when India didn't know how to use BPAL, and BPAL-M was not recommended. Ukraine had already the experience, that's why we're happy to share this experience. And many countries started implementing BPAL and BPAL-M. 87 countries at least procured all the components and are expecting supplies or already started implementation. And there are 3 leaders, Indonesia, Philippines, and Ukraine. In this regard, and LIFT-TB, many countries with the STRs, decentralized treatment to primary care. Some countries very intensively started involving private clinics, and this is very important and relevant for India, Indonesia, and Philippines, where they have many private clinics. And also we note a very significant reduction of those who were lost to follow-up. For instance, one example is Peru, where during 8 months of implementation, the reduction was from 25 to 7%, which is very significant for their cohort. I would like also to mention cost effectiveness. This study was performed in Ukraine, Pakistan, Philippines, and South Africa. Now, these $1,154 per patient, they're just transferred to improve care for this patient or other patients. And it's always good that innovations are responsible not only for safety and efficacy, but they also help to save costs. You know, the WHO now is very active in focusing on application and implementation of shorter accelerated therapeutic or treatment regimens. There will be new guidelines, and we do support new opportunities, new regimens which can be used for patients, like 6 months regimens, to enlarge the pool of our patients and to improve their lives. From our side, we're trying to promote the experience of our country globally. We have opened the center called PeerLink. This is the hub located in the Philippines, in Manila, and basically starts in the previous year. It's been quite active in helping other countries. Here you can see Peru. It was the first country which came to Manila to get some Philippines experience, and they started implementing BIPAL-M quite successfully. Everything which is happening in Ukraine and seems unusual in terms of implementation, it has such a big impact on global society and other countries. And quite often we may not notice it, but it's absolutely huge and very important. A few words about new molecules and regimens. This is our pipeline. I will share the presentation because there are a lot of things here on this slide. The main goal of this slide is to show that there is a lot of work. It's carried out by various partners, and now there is a trend to the merging of the partners to create optimal regimen, optimal durations, dosage. A lot of work is being done. A lot of innovations are to come in terms of medications, vaccines. The main developments are related to improvement of safety, tolerability to the drugs to be used. So this is our pipeline. You saw it previously. And now we've finished clinical trial of TBA J86. We're expecting the results to be presented at the unit. This is the same class as bedaquiline, and I hope that next year at such a conference we will meet and be able to report to you on the results we received within this study. This is a pan-TB therapy. This is both for patients with susceptible and resistant TB. And this is about, again, shortening treatment, improving safety. Also, today we mentioned our ambitious vision regarding treatment of latent TB. Of course, in one day, and the active TB in 1 month. Of course, this will not happen tomorrow, no matter how we want it, but this is about new drugs, new administration routes. There probably will be some long-acting injections, and many partners are working on that to make it possible. And we do rely on the partnership with Ukraine, with consideration of active implementation of innovations here. We rely on fruitful partnership regarding operating research. And at this, I would like also to note that apart from the fact that treatment should be shorter, we must be faster. And I do hope that there will be time when all innovations will become available in 1 year, not in 9. And at this, I'd like to thank all the partners, yourselves, for your work, for your focus, and I'm sure that altogether we'll be able to conquer not only the occupants who unfortunately came, but also TB. Thank you very much. Thank you, Maria, for a very interesting presentation. I think everyone can agree with me that we can listen about BIPAL endlessly. That was a real breakthrough from 18 to 6 months. I wanted to ask you if there are any comparisons. Are there differences in treatment outcomes if we compare operational research and routine practice? Well, that's a very interesting question. Thank you. I don't have such statistics, but of course we compared in the countries because every country is interested in understanding that. As Olesa said, well, efficacy is a little bit reduced because higher proportion of the patients are lost to follow up, or not centers implemented BPAL and have experience of implementation. That's why the first stages efficacy can be a little bit lower at the programmatic level. And there is a very big difference in safety. But in most of the cases, this is because of differences in reporting in ORs and in clinical practice. I have a few examples of programmatic application in different countries like Philippines, Indonesia, and Vietnam. They maintain efficacy at the level 87, 88%. But this depends on the size of the cohort. And one more question. Maybe you have this information about resistance. I think every TB doctor is interested in that. We're trying to avoid it, but do you have any information worldwide? Resistance to pretamanid, of course, is detected. In 2023, WHO issued the guidelines on minimal individual concentration for phenotypic DST to pretamanid. And actually, there are two indicators, 0.5 and 2, which means that, of course, resistance is expected, like to any antimicrobial. And also, since pretamanid and delamanid are kind of a relative drugs, and the resistance to delamanid potentially can also take place to pretamanid. However, in some countries, in operational research, we don't observe detected cases of resistance to pretamanid based on the concentrations recommended by the WHO. But it doesn't mean it doesn't exist. We should be very attentive and cautious about new medications. We should understand that potentially this is possible, and that's why we need to use it only in the frameworks of the regimen according to all the guidelines. Thank you for very interesting information, and now we're moving forward. The next speaker is Mr. Igor Kalabucha, Deputy Director of the National Scientific Center on Pulmonology and Physiatry, a Doctor of Medical Science, Professor, Deputy Director, and expert in thoracic surgery, co-author of the WHO consensus on TB, and the name of the presentation is Main Modern International Approaches to the Diagnosis and Treatment of Childhood TB. Thank you. Dear colleagues, I'm very grateful for an opportunity to be present at this forum, and I'm really happy to share surgeons' view on TB. Now, over the recent time, highly effective modern TB treatment regimens produce outstanding results. And I think for more than 2 years, I'm asking Natalia to give me patients for surgery, but she says, we have none. They don't require surgery. But we know back in 1960s, 70s, when a lot of effective TB drugs were developed, even then, it seemed that probably the surgery is over. But then in early 1990s, we encountered huge resistance, and it appeared that surgery is still needed. I don't want to. I can't exclude the possibility that at some point we will have to develop some other and new approaches with regard to surgical treatment of TB patients. God forbid, but still it's possible. At the same time, still, these days, TB surgery is still in place, it is applied, and at the first rate, the surgery is used to eliminate destructive changes in lungs in case TB treatment failed. Of course, this is about elimination of life-threatening complications of pulmonary TB, such as pulmonary hemorrhage, spontaneous pneumothorax, pleural emphysema. A big specific lesions of lungs. As we know, this is a kind of a reserve or resource for infection to remain and to be disseminated. And finally, improving quality of life and this is also the indication for surgery. Of course, none of these objectives can be achieved with merely surgical methods. There should be the integrated approach with the use of chemotherapy. So I decided to group the types of surgery, to split it into groups. There can be radical surgical interventions and palliative surgery for TB patients. Radical surgeries, surgical operations, include surgical excision of all changes, physical changes to the lung tissue due to TB. And this is done by means of various types of resection. Sometimes it can be combined with collapse surgical methods. In terms of palliative operations and surgeries, it includes collapse surgical interventions, local surgery on cavities, interventions to the vessels and bronchi without ectomy, without excision. The highest importance in the modern practice is with the resection of lungs to eliminate lung destruction. And of course, since the cavity remains the main source of infection, of course, the elimination is the main goal. The majority of partial resections, pulmonary resections, are partial resections, and they are highly effective if the methodologies and protocols are followed appropriately. And among them, lobectomy, segmentectomy, bisegmentectomy, polysegmentectomy, and others. Lobectomy, the removal of part of the lung, is indicated in case of cavities and fibrosis cavities, TB, with lesions within one part of the lung. Combined resection is used in case of destructive or cavity processes in different parts of the lung. Bilobectomy, the most, let's say, full-scale combined resection, is applied quite rarely. It is requires thoracoplastics or pleuroplastics. Lower bilectomy also most frequently requires the correction of hemothorax volume. And resection, large-scale resections like lobectomy, can be followed by various variants of limited sarcoplastics. In case of non-typical segmentectomy, the whole mass of the lung tissue, in this case, the part of the lung is sutured, and if the pathological process covers less than one segment, in that case, the age or precision resection is applied. And part of lung resections due to TB is done with the help of video-assisted thoracic surgery. In case of expanded fibrosis, cavity tuberculosis, pneumoectomy is used. Quite often this is due to complications of TB or post-surgery relapses, or if TB is combined with chronic pleural emphysema. So this was about radical surgical interventions such as resections. Another big part of surgery in TB patients is for diagnostic purposes and treatment purposes. Thoracoscopy allows, in case of exudative pleuritis of TB etiology or emphysema, allows to visually assess the lesion of pleura and to have some biopsy from there, to make local debridement of pleural cavity, to process pleura with ultrasound, and to ensure adequate drainage of pleural cavity, which is an absolutely necessary in such cases. In case of suspected disseminated infiltrated lesions on intrathoracic lymph nodes, this is also used to assess the degree of the lesion. And I'd like to know that in the most of the cases, the materials such as biopsy, etc., is the only way to verify the specific process and to test for drug sensitivity. The indications, it can be used in any with any forms of TB, especially in case of life-threatening complications. The primary indication is the chronic intoxication, relapses of inflammation, lesions to trachea, bronchi, etc. Okay, I'm not going to read further. Infiltrative TB with destruction also can be subject to surgery in case of progress, maintained intoxication, and bacterial excretion. Caveus pneumonia, unfortunately, is quite a rare thing to see, but still there are such patients, and mainly we can call this a surgical condition, but in case of progress, and then the surgery is indicated. In case of focal TB, the indications to the surgery have relative nature and are used in case of relapses or exuberation of bacterial excretion. Regarding tuberculomas, the size of pathological lesion above 2.5 centimeters in diameter, multiple tuberculomas, and also if a patient doesn't want this condition to progress, in this case, the surgical approach is taken. Cavernous tuberculosis, this is not quite a systemic term, but we see such patients, and it is the indication for surgery in the absence of significant clinical or radiological dynamics during 4 and more months. The additional indications in favor of surgery are duration of bacterial excretion, resistance, bronchi drainage, and also if the cavities are localized in lower parts of the lung. So the use of surgical method in patients with multi-drug resistance also bears some increased risk of post-operative complications and relapses. However, a low efficacy of conservative treatment, low life expectancy, and epidemiological issues can drive to the indication of surgical intervention. In terms of the time for surgical interventions, here we can speak about diagnostic and treatment surgery, which I already mentioned. Also for treatment of some emergency conditions due to pathological process, and also there can be elective treatment surgery, some elective resections. Also there can be some indications in terms of verification of the diagnosis when the standard examination did not provide enough information. So this approach is used in case of disseminated TB, in case of infiltrates. Over the past 5 to 7 years, we had quite significant, quite good results when using for biopsy, one started using molecular genetic methods of diagnosis. Emergency surgery, this is for life-threatening conditions such as pulmonary hemorrhage, tension pneumothorax. So these surgery operations are made to save patients' lives. After stabilization of acute impairments of the main functions, here the indications are progressive cavus pneumonia, also bronchopleural fistulas. And what is the objective of the elective surgery? The destruction of the cavities, tuberculomes with destruction, with signs of activity, solid infiltrates with destruction and signs of activity, limited fibrosis, cirrhosis with multiple foci and signs of activity, limited atelectasis as a result of bronchostenosis. And in all these cases, bacterial excretion is an absolute indication to surgical intervention. With the absence of positive dynamics, and we're talking about direct indications, with the progression of the activities of the specific process, If bacterial excretion continues, if the disease is progressing, then again, this is the indication. And the terms for decision making should be based on the CT control, the first CT scan, the preliminary evaluation of the course of disease. For the second CT scan, we evaluate the trends, the dynamics of the pathological process. And if there is no dynamic or negative dynamics, then we look at the third CT scan, and this is the final determination if the surgical intervention is needed. The optimal terms for elective surgery, previously it was 6 to 9 months from the treatment onset. Now for shorter regimens, probably these terms will have to be revised. But so far, as I said, these patients don't have the need for surgical treatment. Maybe it will continue like this. And at later terms, surgical treatment is not justified from the point of view of medication burden. Also, delay facilitates more adverse reactions and complications of TB, as well as adverse outcomes. If there are indications, but surgical treatment is not performed, then the number of cured reduces, the number of relapses increases, disability increases, and resistance increases as well. Thank you, Dr. Volodymyr, for such a very interesting report. And yes, now with regard to the fact that we have such medications, there are not so many patients who require surgery, but still there is certain proportion of the patients who still do require it, and that's why surgery is needed. I have a question about how the approaches to surgical treatment changed over the past decade. What surgeries are most common in your clinic? Well, first of all, the surgical capacities for process verification increased significantly. And here we're talking not only about confirmation, whether it's TB or not, but also we get the materials for microbiology tests, for genetic tests, for drug susceptibility testing. And in this regard, over the past 10 years, our activities have expanded greatly. What changed? So now the cases of cavernous pneumonia are quite rare. We have much less emergency indications to surgery. With the new equipment with video-assisted surgery, we have less, well, not less, we have more accurate scopes for resection, and the number of surgical complications, technical complications reduced, thanks to the modern, up-to-date surgical equipment. Also, we have significant reduction on major surgical interventions, again, thanks to higher accuracy of the equipment. And the spectrum of our capacities is increasing when treating patients with TB complications, with bronchopleural fistulas, with the MPMs, with the complications which can cause surgical interventions. In case of some reduced functionality of the patient's body in the post-operative, post-surgery period. And the number of these patients becomes lower. We have fewer and fewer patients who we have to refuse because there is either no resources or possibility to help them. Thank you, Igor, for your presentation, and we are moving forward. And next, we're happy to invite Iveta Ozere from Latvia, from Riga East University Hospital, TB and lung diseases. She is a pediatric pulmonologist and is working for 30 years in the pediatric hospital, dealing with diagnostics, with treatment of TB in children. And in parallel, she studies drug-resistant TB, and now she's working on molecular and genetic diagnosis. Also, Iveta is the consultant at the National TB Program on Pediatric TB in Kazakhstan, Kyrgyzstan, and Turkmenistan. And the name of the presentation is Main Modern International Approach to the Diagnosis and Treatment of Childhood TB, Perspectives for the Use of New Drugs and the Shorter Treatment Regimens in Children. Please, over to you.
Everybody, do you hear me? Okay, I will try to share my screen, okay? But where, So, do you see my screen? Yes.
Yes.
Yeah. Okay. So, dear conference organizers, dear colleagues, it's really my pleasure, and I'm happy to participate in this very significant conference and to learn about your significant experience and innovative approaches to the diagnosis and treatment of tuberculosis and other lung diseases in the Ukraine. I really believe that your knowledge and your experience in TB treatment exceeds experience of all other countries in the world. So, but my presentation about children and part of new information you have learned and know already, but I will try to introduce with the latest recommendations from WHO, and my presentation will be based mainly on those two documents, WHO Consolidated Guidelines and Operational Handbook on Tuberculosis, released in 2022, and the latest document, Key Updates to the Treatment of Drug-Resistant Tuberculosis, released in 2024. Why we should talk about children? Because every year, approximately 1.3 million children become sick with tuberculosis, and it is equivalent to approximately 12% of the estimated total number of tuberculosis cases globally. 214,000 children died from tuberculosis in 2022. And when calculated, then the mortality rate of tuberculosis in children population is approximately 16%. Why children die from tuberculosis? An estimated 80% of these deaths were in children under 5 years. 96% of them were in children who never received tuberculosis treatment because they were not diagnosed with tuberculosis. And also out of them who become sick with mild drug-resistant tuberculosis each year, it's approximately from 25,000 up to 32,000 children. Only 14% of them were diagnosed with TB in 2022. Why children are still dying from this preventable and curable disease? The main reason is that tuberculosis has not been diagnosed in children, and it happens either it happens because of lack systemic screening of contact children, because of possible ciliary nature of tuberculosis in young children particularly, and challenges in sample collection in those children. And in those who don't have bacteriological confirmation, we use clinical criteria for diagnosis, and the sensitivity and specificity of clinical criteria is quite low. So if tuberculosis has not been diagnosed, children do not receive treatment, and partly it explains high TB mortality rate. Currently, we have huge success, substantial progress in the treatment of TB in children. But gaps in TB care for children still exist, including identification, prevention, and particularly diagnosis. How to find and where to look for children with TB? Screening, systemic screening for children who are contacts of TB patients and for those who are at high risk for TB disease and progression of TB infection into TB disease. If we will deal with screening of those children, we will diagnose tuberculosis early. We will identify, first of all, we will diagnose early, and we could cure completely those children. And the third group where we can look for and should look for TB, it is children who comes with clinical and radiological signs of tuberculosis. Approach to diagnosis of TB in children. To diagnose tuberculosis in children is more complicated, more challenging in many times, particularly in young children, because young children will usually have post-bacillary nature. And that's why for diagnosis of children, we should use all data of anamnesis, clinical, radiological, immunological, bacteriological examination. Everything what we have, we should put together like pieces of puzzle. And this approach includes very careful medical history, clinical assessment, immunological diagnosis of TB infection, radiological examination, including chest X-ray and CT in case of necessity. It's HIV testing, it's bacteriological investigation, and other investigations relevant for diagnosis, for example, bronchoscopy or biopsy taking, or even video-assisted torcoscopy sometimes. Bacteriological investigation of clinical samples should be sought in every child when we suspect tuberculosis. Any type of biological sample can be investigated bacteriologically. WHO currently approved respiratory specimens for diagnosing of pulmonary TB include sputum as a spontaneously expectorated or induced sputum, gastric aspirate or lavage, nasopharyngeal aspirate, and stool. Stool is a relatively new sample, and I know that Ukraine's colleagues that we are working with this. Gastric aspirate stool should be investigated because children swallow the contaminated sputum and mycobacteria can be identified within those samples. Methods for bacteriological investigation are the same as for adult people, and all methods should be used, including microscopy, including culture, and including molecular tests. Liquid culture still remains the gold standard for confirmation of tuberculosis and drug susceptibility testing. However, its limit of detection could be lower compared with molecular tests. It seems that currently the most sensitive molecular test for detection of presence of Mycobacterium tuberculosis complex in the clinical sample, that it is GenExpert real-time PCR by GenExpert rifampicin ultra method. Its detection limit is 16 colony forming units in 1 milliliter of sample, compared with previous generation expert, which can detect 114 colony-forming units in the milliliter of the sample. And that's why WHO recommends the use of Expert Ultra over the older generation Expert method as initial diagnostic tests for TB. Instead of microscopy and culture, when we are investigating sputum, nasopharyngeal aspirate, gastric aspirate, stool, cerebrospinal fluid, and biopsy or aspiration from lymph nodes. Of course, we can use GenExpert Ultra on all other samples as well, but WHO recommendations is based on the evidence of the studies available, which were included for analysis and resulted in recommendations. Collecting multiple specimens, either of the same or different sample types, increase the yield. WHO recommends the transition from Expert to GenExpert Ultra for molecular diagnosis of tuberculosis. It is important to note that for children, negative bacteriological investigation results or molecular tests never exclude possibility of tuberculosis in the child, because particularly if we try to diagnose early tuberculosis in children, if we screen them due to contact or due to other criteria, we will identify this child with tuberculosis in early stages. And bacteriological confirmation can be as low as 15-20%. Just one slide regarding reporting and recording. What's new? New is that tuberculosis of the interthoracic lymph nodes is now classified as pulmonary TB. Pulmonary TB can be bacteriologically confirmed or clinically diagnosed case of tuberculosis, which involves lung parenchyma and or tracheobronchial tree. A little bit about diagnosis of tuberculosis infection. Yeah. First of all, definition of tuberculosis infection is that it is state of persistent host T-cell immune response to stimulation by Mycobacterium tuberculosis antigens in person without evidence of clinically manifest TB disease. And currently the term tuberculosis infection is preferred over the term of latent tuberculosis infection. Then we clinically clearly can distinguish tuberculosis infection and TB disease. What are we talking about? Tests which can be used for the detection of tuberculosis infection and which are recommended by WHO are three types of tests. First of all, tuberculin skin test, our old method. The other group of methods are interferon gamma release assays, including quantiferon TB gold and intube and TB spot TB test. And the third method, relatively new, but I know that you used this test already under the name Biaskin test. This test belongs to Mycobacterium tuberculosis specific antigen-based skin test. This Mycobacterium tuberculosis antigen-based skin test uses specific mycobacterial tuberculosis antigens to antigens which are used also in gamma interferon tests. And there are early secretary antigenic target 6 and culture filtrate protein 10. And this test it's a good test because it combines skin test platform. It is easy to perform like the tuberculin skin test and easy to read. And it combines specificity of interferon gamma release assay, which is which is high, much higher compared with tuberculin skin test. And such tests which are mentioned here are currently qualified by WHO and recommended for use. But what we should remember that immunological tests mentioned above, they are intended for diagnosis of Mycobacterium tuberculosis infection. They are not intended for diagnosis of active TB disease. But in children, they can assist for diagnosis of active TB disease. In most cases, as I have mentioned, children has possible ciliary nature, and the diagnosis should be based on the clinical and radiological diagnostic criteria, triad of criteria, which includes close contact with tuberculosis patient, radiological abnormality consistent with TB, and positive immunological tests which confirms presence of Mycobacterium tuberculosis infection in human's body by T-cell immune response. Because diagnosis of tuberculosis in children can be challenging, WHO now recommends interim treatment decision algorithms, integrated treatment decision algorithms for those children who are not yet bacteriologically confirmed, but who are brought to healthcare facilities. These algorithms cover children under 10 years of age, the diagnosis of pulmonary TB in children under 10 years of age. And the main goal of these algorithms is to support healthcare workers in diagnosis and treatment onset in children, because in children without bacteriological confirmation at the admission, the delay of treatment for tuberculosis should not be allowed. Yeah? And there are two types of algorithms. Algorithm which is intended for the settings where chest X-ray is available. And when we go through this algorithm, then we obtain the result, and we just should count these points together from chest X-ray and symptoms and signs. And if we have more than 10 points, then we should start the treatment of TB. And this algorithm also can be used in settings where chest X-ray is not available. Then we are basing only the clinical symptoms and signs, and again count together these points, and if the score is over 10, then we start the treatment of tuberculosis. So regarding treatment of tuberculosis, current treatment recommendations offer great opportunities for treating of tuberculosis in all children, because without exception of rifampicin for children under 2 years of age and predominant for children under 14 years of age, all other anti-tuberculosis medications currently available can be used for children. And except predominant, all other anti-tuberculosis medications are available in child-friendly drug formulations. Here you can see the overview summary of WHO recommended treatment regimen for children and adolescents. So, and we have 3 regimens, 1, 2, 3 for drug-susceptible TB. We have regimen for isoniazid-resistant TB, and we have a lot of regimens for treatment of rifampicin-resistant, multidrug XDR-resistant tuberculosis in children. And you have talked a lot about regimen, BPAL regimen, 6 months regimen, which is very, very great, really opportunity. And in further slides, I will a little bit talk about what is relevant new in WHO recommendations for the treatment of drug-susceptible pulmonary TB. Here you can see overview, and with red letters is marked what is relevant new, because no, it is not more very new. It's 2 years ago was recommended already. And I will stay on the next slide a little bit more in details on these new recommendations, relatively new recommendations. In children and adolescents between 3 months and 16 years with non-severe drug-susceptible pulmonary TB, 4 months treatment regimen should be used. And here also is a definition of non-severe pulmonary TB, 2 months isoniazid, rifampicin, pyrazinamide, and ethambutol, and it is continued by 2 months of isoniazid and rifampicin. And patients aged 12 years and over and weighing at least 40 kilograms and more with drug-susceptible pulmonary TB regardless of disease severity, can receive 4-month regimen comprised of 2 months of isoniazid, rifampicin, moxifloxacin, pyrazinamide, and followed by 2 months of isoniazid, rifampicin, and moxifloxacin. I know that you successfully use already this regimen, or all these, both these regimens in Ukraine. And regimens for the treatment of drug-susceptible extrapulmonary TB, again, with red letters is marked what is relatively new. And again, on the next slide, this will be explained more in details. Treatment of central nervous system tuberculosis. Treatment can be with, which is already known for us. It is 2 months of 4 drugs, isoniazid, rifampicin, ethambutol, pyrazinamide, followed by 10 months of isoniazid and rifampicin, and total duration being 12 months. WHO now offer 6 months intensive regimen of treatment of central nervous system tuberculosis, where ethambutol is replaced by ethionamide. 6 months of isoniazid, rifampicin, pyrazinamide, and ethionamide. But in this regimen, we need to use higher drug dosing per milligrams kilogram per body weight, yeah? Which is shown here in the text. Treatment of osteoarticular tuberculosis should be at least 12 months. For drugs sensitive on osteoarticular tuberculosis, 12 months, comprising 2 months of isoniazid, rifampicin, ethambutol, pyrazinamide, and 10 months of 2 drugs. For other forms of extrapulmonary TB, treatment duration of 6 months is recommended, but I think that every doctor should decide if this will be enough or not enough for your patient, which you know better us. And the latest ETSK updates to the treatment of drug-resistant TB, which became available last year. And I have heard that during the next few weeks, we will have all consolidated guidelines in one document, now including these updated guidelines. And really, it's a great opportunity if we can use such 6 months regimen for treatment of drug-resistant tuberculosis, which consists on bedaquiline, delamanide, linezolid, levofloxacin, and clofazimine. This regimen can be started without delay in those about fluoroquinolone, in which fluoroquinolone resistance is not yet known, and then it can be continued either by fluoroquinolones, levofloxacin, if the sensitivity is, if the mycobacteria is sensitive to levofloxacin, or clofazimine if mycobacteria is resistant to levofloxacin. Besides, regimen about which we talked a lot of, yeah, it is 6 months BPAL regimen, either with or without moxifloxacin, recommended for those aged 14 years and older. Modified 9 months regimens, which can be used in those who have sensitivity to fluoroquinolones, yeah, and there are 3 different regimens offered, and priority of the regimens is shown also. Old regimen already, 9 months oral bedaquiline containing regimen, which can be used also in children, but the use is more limited compared with previous regimens. And I didn't mention here the longer individualized treatment regimen, where we should treat patients 18 months and more. But this regimen will be chosen only for those who have contraindications to previously mentioned regimens. Really great success, and thank you very much. Дякую за увагу, and I'm really believe that your country has the largest experience in the world, and all countries in the world could learn from your experience how to treat tuberculosis and drug-resistant tuberculosis. Thank you for attention.
Дуже дякуємо, пані Івета, за вашу таку цікаву, змістовну доповідь, яка стосувалась
Thank you for your
міжнародних
presentation that considered like international recommendation on the treatment of the pediatric tuberculosis. The presentation has been really informative and allowed us to understand better the modern tendencies in the pediatric tuberculosis. Thank you so much, and thank you so much, Iveta. We are moving forward, and we have a finishing presentation with which Yulia Senko is being invited to the chemo-resistant tuberculosis of physiology and pulmonology, a candidate of medical sciences, has 20 years of experience of work in managing cases of multi-resistant tuberculosis, also with the usage of novel medical. Yes, she is the researcher, and their work is being connected with the provision of mental health support for patients with tuberculosis, effective practices, improvement of mental health in those patients. Thank you so much, Yulia. Thank you so much, dear Marina, dear colleagues. And so I welcome all of you on our international conference, and so dedicated to the World Health Day. Let us share our experience. The depression is a widely spread condition connected with immunosuppression that is supposed to be treated and can be treated, but usually not recognized and not being diagnosed, and can lead to worsening results of the treatment. Based on the WHO data, depression is suffering from 300 million people throughout the world. In Ukraine, depression is a widely spread problem among the mental health disorder, one of the prominent ones. Ukrainians are suffering with depression much more frequently than the citizens of the European Union. And also anxiety are big there, and also they might have a risks of lifelong anxiety. And in both social, physical, and other parts of the anxiety among female and women, it's all 50-50, which is they have an anxiety for all the population throughout the world, so we have a higher numbers. And they also might have the hereditary, also GI tract pain, chest pain, palpitation, sweating, feeling nervous, and fatigue, constant fatigue, feeling like there's something bad coming, and generalized anxiety disorder, which is feeling like you're it's harder to concentrate, you clench your muscles, it's hard to control the feeling if worried all the time, and you might have the issues with the sleep and other things. And so depression is the negative thoughts of you and internationally of what is happening in the world and with yourself, feeling like you can't do stuff, you can't make anything, you can't change anything, there's no chance of improving your situation, and you can't feel happiness and wish to live, the loss of interest to the day-to-day activity of the needed or nice things that can happen in your life. They can be physical feel of the fatigue, physical fatigue, mental fatigue, and even if there's not something not complex and not complicated, and they require much more time to be there. And so also you might be self-blaming or guilt feeling, self-criticism for. And I'm so welcoming to show you what kind of signs of depression can happen in your body, apart from just negative part. There can be also cardiac arrest or change in the body mass that can be together with going hand in hand with overeating or decrease in appetite. This can be bulimia or dyspepsia, as a reduced appetite and reduced body weight. You can also have a constriction of vessels that can lead to cardiac arrest. It can be fatigue, loss of interest to whatever you're happening, problems with the memory, insomnia might happen. That can be manufactured and manifested with the bad quality of sleep or not falling asleep in time. And so problem with the memory, feeling of obsession, concerns about death, weakened immune system, and sensitivity to pain is much higher. For example, if one have a migraine, it's like the way people feel about themselves might get much worse if they have depression. Also, we did a meta-analysis that we have included 25 research and studies that have been conducted in different countries, places in the world, compared in 2011 to 2021, and reflected the situation over the past previous years. They decide upon the risk factors on what are the chances for the depression to occur in people with TB. And the last of those factors can be associated, and they included the female gender, not socially protected, if they were married, not married, level of education, living in rural areas, and also if they have been treated for depression before, and also stigma perception. So what kind of the recommended activity have been there to improve upon the situation? This is the recommended to include more volunteers for a bigger social support, to spread out courses and different kinds of knowledge can without people for people without higher education, and also psychotherapeutic support as well. What kind of tests are used for the depression screening? So most frequently PHQ-2, PHQ-9, they demonstrate a good sensitivity and specificity on the points for depression, and also for the conduct of the screening for anxiety, which can be used at GOT7 tests can be used. This is our data. We have made a questionnaire for more than 600 people. They detected anxiety among the biggest one has been around 42% of patients. The minimum level of anxiety have been in the 34% of the patients. The mean level of anxiety and the high level of anxiety has been 7% of patients. Depression has also been analyzed based on the scale PHQ-9. Depressive disorder has been noted, and we conducted an analysis among the patients that have been questioned in 2017 and 2021. And we have compared them with the patient that have been questioned in 2022 and 2024. So the moment when the full-scale invasion started. So we have mentioned here that there is the decrease in the regular status among the patients from the 44% to 48 and 9%. And so the increasing levels of the mean level of depression and regular levels of depression almost twofold, from 10% to 21%, and depression of the moderate levels of severity noted in 2017, they had in 2021 3% of patients, in 2022 and 2024 in 14% of patients. What was the self-care that can be during depression and or depressive disorders? First of all, which is to try to continue to make things that are bringing joy to you, which is recommended by psychologists, to give time to your hobby and or to try something new. This can be like reading, this can be play on the different instruments, or like any other task that brings you joy. As you saw here, we are demonstrated here that our group therapeutical tasks and everything else, with the art therapy also methodology being used. Here we have a demonstration of those pictures of how people are doing art, and the patient needed like a blanket and has demonstrated this, the picture of how they're doing the knitting and hands work. We are using mandala therapy. You should know that this is from Sanskrit, means the working in a circle. And this is the line of work that we do. Can we turn on the video here if possible?
Так. Не запустилось, ну нічого. Самодопомога
Did
при
it work? No,
депресії
okay.
та
Self-care
тривожному
and the
розладі.
depression and
Залишатися на зв'язку зі своїми
anxiety,
друзями,
be online with your
рідними,
friends and
колегами,
family,
з ким є можливість
close ones with
поговорити
whom you
про
have an
свій
ability to
стан.
work and play with your own state of health.
Також регулярно підтримувати
In the
фізичну
same way, you
активність,
need to
обрати той вид
fulfill the
активності, який вам
activity, to pick the
подобається. Це
activity
може
level that
бути
you
біг,
like,
чи ходьба, чи йога.
and
Як мінімум відвести 30 хвилин на
either
день
to
для
take 30
фізичних вправ,
minutes per
хоча б
day
у
for
вигляді
physical
коротких
exercise, at
прогулянок.
least like short walks.
Також дотримуватись режиму
And
харчування та
also to
сну.
keep the
Повинно бути збалансоване
you need to
харчування.
sleep well, you need to
Перед
have a
сном
balanced
забороняється вживання кави, вживання
and you
алкогольних
can't
напоїв,
use alcohol or anything
забороняються
else. You
силові
can't use
навантаження.
any physical
Також рекомендується
exercises, and
обмежити
also it's
перегляд
recommended to
телепередач та новин та
not
соціальних
watch news
мереж.
so much, social
А
media
навпаки,
so much, and so
рекомендовано
also what's
читання
recommended
книжок,
to read
щоб
books
був комфортний температурний
for
режим
you
в
be comfortable
кімнаті,
temperature in the room,
щоб був дотриманий режим дня.
and for
Рекомендується
and we also
медитація,
recommend to
ну
have
і здорове
meditation
харчування, не
and
переїдати
healthy
перед
dieting,
сном.
not to overeat before sleep.
Також рекомендується відмовитись від алкогольних напоїв або скоротити його вживання і не вживати заборонених наркотиків, оскільки це може
It is
посилити
also recommended
депресію.
to refuse from
Рекомендується
alcohol,
також розповідати про
from
свої
illicit
почуття людям,
drugs,
яким ви
because this can
довіряєте,
enhance depression. And
які
also,
можуть розділити з вами
you should
ваші турботи,
tell
ваші проблеми,
your
і
your friends, your
коли треба
relatives
звертатись за
about your
професійною
concerns and their
допомогою.
problems.
Якщо ви
When
відчуваєте
one should
серйозні
apply
або
for
тривожні
professional
симптоми, які
help.
тривають
If you
біля 2
feel some
тижнів або більше,
serious or
це такі
worrisome
проблеми,
symptoms
як
that
проблема зі
for
сном,
last
порушення апетиту,
2
що
weeks or
призводить до
more, such
небажаної
as sleep
маси
problems,
тіла, чи
appetite
набирається вага, чи знижується вага,
problems,
труднощі з концентрацією
leading to
уваги,
undesirable changes
втрата
in
інтересу
body
до
weight,
речей, які ви займались
difficulty in
зазвичай, які приносили
concentrating, loss of
задоволення,
interest in
нездатність
things that
виконувати
you
звичайні
usually enjoy,
повсякденні функції та
inability to
обов'язки,
perform normal daily
постійне
functions and
відчуття втоми чи
duties,
втрати енергії
constant feeling
і
of
думки
fatigue
про смерть чи
or loss
самогубство.
of energy, and thoughts
Рекомендується
of
негайно
death
звертатись за допомогою
and
до медичних
suicide. It is
фахівців.
recommended to get to healthcare workers
Що ми
for
можемо
help.
ще запропонувати,
What
коли
else
вам
can we
погано?
suggest if you feel
Почитайте
bad?
хорошу книгу, подзвоніть
Read
близьким,
some
заведіть
good book,
щоденник, вивчіть
call
новий
your
рецепт,
close
напишіть
ones,
листа, чи
write
трошечки
some
поспіть,
uh,
знайдіть нове хобі,
diary,
займіться спортом.
learn new
Можна також
recipe,
випити
write a
чаю, чи
letter,
прийняти ванну, чи
do some
пройти
sports. You
цікавий
can have
онлайн
some
якийсь
tea or
курс.
have a bath, or maybe have some interesting online
Перед вами на
course.
екрані перелік
Here on the
безоплатних
screen, you
гарячих
can
ліній,
see
які
a
є в
list of
Україні. Якщо ви
toll-free
потребуєте
hotlines
допомоги,
operating in Ukraine.
звертайтесь за одним із цих
If you
номерів.
need
Можна
help,
зараз зробити
you
якийсь
can
скріншот
call one
собі
of these
для
numbers. So you can make
пам'ятки.
a screenshot
Цей
to
контакт-центр
remember
Міністерства охорони здоров'я і
this. This is
урядова
the Ministry
лінія,
of
і
Health
лінія
Contact
підтримки для
Center and
ветеранів, членів їх
governmental
родин,
hotline,
лінія
support line
Національної
for veterans and
психологічної
their family
асоціації,
members, National Psychological
лінія
Association
Міжнародної
hotline,
гуманітарної організації
the
«Людина в
hotline of the
біді».
International
Будь-які
Humanitarian
інші ви бачите
Organization People
номери,
in
робіть
Need,
собі скріншоти
and the
та
others. Please
будете мати
take
змогу
photos,
направити
make
пацієнта
screenshots, and you'll
чи
be able
особисто
to refer
звернутися
your
за
patients
якоюсь
or
психологічною
maybe
підтримкою.
apply personally for some psychological support.
І щодо висновків,
And
поширювати
regarding
інформацію про
conclusions,
важливість психічного здоров'я та
spread information
способи його
about the importance
підтримки,
of mental health
звертатися
and
за
ways to
допомогою до
support it.
психологів,
Seek help from
психотерапевтів, групп
psychologists,
підтримки,
psychotherapists, and
підтримувати
support
одне
groups.
одного, створювати
Support each
міцні
other.
соціальні
Create
зв'язки,
strong social
обмежувати
connections.
надмірне
Limit
споживання новин
excessive
та
news
дбати про
consumption and
психологічну
take
гігієну,
care of
розвивати
psychological
державні та
hygiene.
волонтерські
Develop
програми
state
психологічної
and volunteer
реабілітації.
psychological
Важливо
rehabilitation
також
programs.
забезпечити
It is
комплексний
also
підхід до
important to provide
лікування,
a
який
comprehensive
включає
approach to treatment
психотерапевтичну
that
підтримку,
includes
за потреби медикаментозне
psychotherapeutic
лікування
support
психічних
and, if
розладів.
necessary,
Звернення
medication for
лікування,
mental
яке включає
disorders. It
фармакологічні
is
та
proven that treatment, which
психотерапевтичні
includes
способи, полегшує
pharmacological and
короткострокові
psychotherapeutic
симптоми.
modalities, has been shown
Дякую всім за
to
увагу.
alleviate
Дякую, пані
short-term
Юлія.
symptoms.
На жаль,
Thank
в
you
тих
for your
умовах, в яких
attention.
ми зараз з вами
Thank you,
живемо,
Yulia.
дійсно це питання
Unfortunately,
ментального
in
здоров'я
the
займає дуже
conditions we are
важливе
living in, The mental health issue is very important. I don't know how much time we would need to pay that much attention to it. I have a question to you, Leah. How do you assess the effectiveness of group therapy, like art therapy in the inpatient settings? Thank you. Well, group exercises using art methodologies demonstrate a good, high effectiveness because the emotional condition of patients improve. Also, the level of anxiety, level of depression decreases. The level of trust increases among patients and participants of such exercises, and the overall emotional and psychological condition improves. Thank you, Yulia. And this was the last presentation for today. We have completed our second session. I'd like to give the floor to Natalia. Thank you very much, Marina. Thank you, all the colleagues, speakers. Time has passed so quickly. I think our event was successful. What do you think, dear colleagues? We are looking forward to your feedback, both in the chat, in the feedback questionnaire, which we would ask you to fill out for us to see what your thoughts, your impressions are. Maybe you have some remarks or suggestions for our future topics at our educational events, which we are going to continue to have. And we will consider all this and we will try to stick to the topics you are interested in. And now I'd like to say that we need to make some kind of a logical wrap up of our conference. And for this, we will open the test questions and we would ask you to answer them because only the questions to this questionnaire will enable you to receive certificates. These are the Ministry of Health conditions and requirements, and the test questions will be open until 11 p.m. today. So basically, our training will be lasting until the end of the day. And after you complete the tests and answer the questions, we are urging you not to abandon your study. Like we said many times before, and you saw it in social media and in your emails. Maybe many of you have already registered for master classes, which will be part of the conference. But each of the master class will have its, and it has, a separate registration. It's a separate event. And in the end of every master class, you will have also to go through such a short testing. For you to be able to get to the master class, you would need to end this stream. You will have just to press escape button, and afterwards you can open your email mailbox where you should have probably the link to the masterclass you selected. If somebody has not registered, the masterclasses will be about more specific clinical issues. The first masterclass, where most of the people registered to, will be dedicated to some peculiarities in terms of managing patients with TB and other pulmonary diseases. First of all, we will talk about sarcoidosis, about mycobacterial infection. We will also speak about pulmonary fibrosis, which is a very serious problem now, especially in post-COVID time. And we will, if we have enough time, during the masterclass. We will talk about adverse events. First of all, how to record them correctly and why it's desirable to do for every healthcare worker, every physician, regardless of the specialty. We will talk about two main adverse events, such as medication allergy, which is life-threatening, and every doctor should know about it, regardless of the specialty. And the second is what Yulia mentioned, is a psychological and neurological adverse events. And we have a very provocative and hot topic, the role of medication therapy and the role of medical cannabis, which, as you know, has been already registered for medical use. This is what is related to the first masterclass. The second masterclass is not less interesting because it will be dedicated to all the capabilities of the instrumental diagnostics for pulmonary diseases. And even TB, which is the infectious pathology, which can be diagnosed, like Yana Terleva mentioned today, during 1 hour, one can diagnose TB. This is all good if we can find mycobacteria in the native sputum or bronchoalveolar lavage. If it's impossible, what are the other instrumental methods? What are the possibilities? Today, we touched upon the peculiarities and misconceptions related to computer tomography of chest tomography. In addition to this information, at the masterclass, we will tell you about the experience of our clinicians, the information capacity of CT, and apart from that, there will be very interesting reports on instrumental diagnostic methods. Bronchologists will tell you about transbronchial biopsy, and thoracic surgeons will tell you about the transthoracic biopsy of the lung tissue. The third masterclass will be about extrapulmonary TB, and there we gathered for you the team of a highly competent experts, not only TB doctors, but also specialty physicians. First of all, everybody is interested in CNS TB and spinal TB. That's why the leading surgeons who treat this pathology will tell you how, from their viewpoint, one should correctly diagnose this or that pathology, brain or spine, to reduce as much as possible the diagnostic errors. And also, the third master class will be dedicated to miliary generalized TB. Where is the border between disseminated and generalized or miliary TB? How to treat it correctly, how not to miss it, and how to prevent this pathology. Therefore, we think the master classes are very useful for clinicians. Please join us. And once again, I want to say that at our channel, National TB Hub, at any time you can look through the conference again and master classes after they are over and recorded. And also you subscribe to the YouTube channel, likes, etc. If you are subscribed, then you will have automatic reminders about certain videos which our YouTube channel offers. So that's why you have all the opportunities to upgrade your professional level, and we hope also to get some pleasure of this conference. Dear colleagues, have I mentioned everything? I spoke about tests. Dear colleagues, once again, let me remind you, in the bottom there is a red button, which is called Test Questions. You should press it, and you will see the test. After you pass these tests, you will see your score. And after you finish it, you would need to press Escape button or Exit button. It's in the right upper corner. But please, colleagues, it's very important for you to be able to go to the next masterclass. You need to leave this stream. Press Exit button, and then follow the link you received on your email and join the stream of the masterclass you selected. Well, everybody has a nice day, nice study. All the best to you, health to you and your patients. And let's hope that today which you spent with us, will be useful for you and interesting for you, and you will be coming to us for the new knowledge. All the best.